Good morning,
Hello.
everyone. Good morning, all doctors. It's a very fresh Sunday morning. Firstly, I welcome you all in this grand symposium of ENT surgeries called STAPE surgery. I'm sure that this is one of the best academic
इसको
fest
बोल
in the field of
अरे
ENT
स्पेकुलम
today,
रखना
with all stalwarts
फोकस करा के रख
demonstrating
लेजर लगवा
class
के रख
apart ear
सब
surgeries.
चीज
Lupin is honored to be associated and bring this mega event to your doorsteps. Lupin had always been a forefront of delivering the best of the academics in pulmonology. We have associations with the major academic bodies like Association of Chest Society, European Respiratory Society, National College of Chest Physicians, and with the Indian Chest Society, along with that many other domestic and international bodies. In ENT domain, we have delivered many high-class surgery events with eminent Indian surgeons as well as international surgeons on virtual and actual platform. Today, I thank Dr. Jain, Dr. Satish Jain, Dr. Ashish Punkar, Dr. Desai, and the Master Director, Dr. Rajiv Pachori, and with all eminent guest speakers of this program for giving us this opportunity to deliver this highly academic program to our esteemed audience. I'm sure the knowledge sharing platform will be an excellent learning experience to all participants. Lupin, as you all know, is known for one of the most reputed pharma organization in India and internationals, and Respira is a cluster dedicated towards respiratory, including upper and lower respiratories, along with the allergy. I look forward for your active participations and ask your queries at any point of time. Now, without wasting in much time, I hand over the sessions to Dr. Ashish Bunkar for the further agenda. Thank you so much on behalf of
Thank you.
Lupin.
Thank you, Ganguly. Thank you for coming forward and supporting our academic events as always. And thank you for doing this. I just have one point to do that you should do what you have done for pulmonologists to the ENTs. They only have two lungs. We have 2 ears, two nostrils, one throat. We have got five organs. So we want you to go 2.5x for the ENTs going forward from now. Yeah, I know you will always support.
I
So,
appreciate, sir.
so thank you so
I will
much.
certainly be there.
Yes, you are the people that for allergy, whenever there's an allergy thing, we are the ones we go to. But of course, you support all our surgical events. So thank you very much for that.
Thank you,
So
sir. We
Satish,
are very
we
honored.
planned this. We are calling it a mini carnival. We think we will do 10. We have got more than 17 or 18 cases lined up, but I think our target is to do 10 or a little bit more and do them with more discussions rather than rush through them. That is the idea. That's what me, Satish, and Ashimi last night we were speaking. So Satish, over to you. You have time till 10 to do your talk and to show your stappies. 10 o'clock, I'm canceling your screen. No, just kidding. Yeah. We are all excited.
Sir,
Satish,
on
up to
your
you.
mic, sir.
Unmute, Satish.
Sir, mic on your mic. Your mic is off.
Satish, unmute.
Sir, mic is off, sir. One second.
Something. So the radiology that Satish will show specifically how to look for
We can't hear.
autosclerosis. That actually our Dr. Sneha, the radiologist, we are working on how to
yes
how to approximately measure the distance or the length of the piston, how to measure from the long process. That's
yes
what we are doing. Thickness of the foot plate, and of course whatever anomaly
yeah
that is. Yes, Satish, over to you.
yeah so good morning all. And before we go ahead, I would like to acknowledge certain people who have been pillars behind our academic activities. On this time, I'm grateful to Mr. Ganguly from Lupin to extend their entire support for the event. Big thanks to Thane AY. Ashish and Ashim have been pillars. They are brothers and they are part of life, not only all these events. Thank you, boss, for always being with me. And our dream team today, who is the entire faculty for this program. And I'm so happy to be with all of these people. Arvind, Amol, I think Amol is joining now. Maruti Kalyankar, Vivek, Ramandeep, Dr. Ramandeep from PGI. Gaurav Chaturvedi, he is from Mumbai. He is from many of the
Yashod.
prestigious hospitals from Mumbai who has joined. Niranjan, I think Niranjan is online. Niranjan
I,
is
I
owning a
can't
big
see.
hospital in Anantpur and doing more than ENT, lot many things. Of course, Paramita, who has been pillar of our webinars. Same Dr. Venus Patel, Dr. Shenal Kotari, Dr. Aditya, and of course, Udbhav and Naidu, who has been part of all our activities now. Thank you so much, all of you, for being with us for this big day. And as Ashish told, it is all planning from Ashish to organize such events. Believe me, all these,
Crazy ideas.
what kind of ideas you can say coming from him to do this mini carnival, which is actually a part of, extending our webinar, which we focused on stapes in August. A dedicated webinar on stapes. We are carrying forward that. The same event of a bigger one, Carnival, was done in Jaipur in 2013, wherein we did 15 stapes, 50 stapes in 2 days with various techniques. Wherein Ashish used KTP laser, I use, you know, CO2 laser. Ashim did so many variety of pistons and grafts and so many things, and we encountered 2 or 3 gushers and other complications as well, and was a very very useful academic feast. So
Satish, I
today,
think PGB has joined our today's guest of honor.
has sir
PGB
joined?
has joined. I can't see him, but I'm reading some messages coming on the screen. Okay,
So
once he joins, maybe I'll acknowledge his presence. It's okay. You
yeah,
go ahead. Yeah.
yeah. Let me see if the sir has joined. And this program is
Satish, let me interrupt. Let me interrupt for a minute. Just last night, there's a UK-based academic foundation. Yeah, PGB sir. Good morning, sir. Welcome.
Very good morning, sir.
The
good morning.
grandmaster of autology of the country. One of the strongest pillars. PGV sir, we can't hear you. Maybe you fix it. I was referring to this association from the UK, and last night on their website they have posted a newsletter in which they have actually written that Satish Jain's work on JNA, he says the faculty themselves have never seen or heard something like this. Forget about what the students will answer in the FRCS exams. This is a UK-based training program for FRCS. He says the faculty, and they are on record saying this. The faculty themselves have never seen the kind of work Dr. Satish Jain is doing in JNA. So that's, Master, you are
Thank you.
redefining
Thank you.
everything.
Thank you. PGV sir, welcome. Can you hear us, sir? Good morning, sir. Can you hear us?
Sir, he have some audio issue might be.
Yeah, it's okay.
Dinesh,
It's okay.
I think he's not
Can you
connected to
sort
the
out?
audio. And can you just help him out?
Yeah, sir, I will call him and I will update so you can continue keeping.
Good morning, sir.
I don't think he's able to hear us, or
Yeah,
we
I
can't
think
hear
he's connecting. So it's a pleasure
connecting to
to welcome Dr. PG Vishwanathan, who is considered as a father figure for autology.
Yeah,
Now
audio
Not
is
he's
on,
only
now
for
he's
me,
muted.
like me, thousands of ENT surgeons have learned this art from him world over. Sir, can you unmute, sir?
Sir,
Is somebody
please
helping,
unmute.
sir?
He's already unmuted, sir. He's already on unmute.
No, his computer is muted. It shows up.
Okay, Satish, you carry. Okay,
Yeah.
okay, I think. Sir,
Yeah.
can you hear us?
Yeah, thank
Good
you.
morning, sir. How are you?
Satish. I'm fine, fine. Hello,
Welcome,
Jain.
welcome, welcome.
Hello, Satish. Hashim. Good morning.
Good
Very
morning,
good
sir.
morning.
Very
Welcome.
nice to see you and hear you, sir.
Thank you. Nice to see all three of you.
I am on a WhatsApp chat with sir very often, and he sent me more than 50 articles in the last 8 days. That is how academic this man is. And my journey of the posterior crust began with him in 1994 when he came, or 93 when he came to Thane to give the oration. And from then on, each conference he would ask me, Ashish, have you started drilling the posterior crust? And here, sir, we are there today. Every posterior crust will be drilled,
Very
dedicated to
good.
you. Yeah.
Very good.
Thank you. Thank you, sir. So Satish is about to read the CT scan, sir, of the
Okay.
case
Yeah.
that he's doing. Yeah.
Yeah.
Thank you
Satish.
once again, sir, for joining us. It's like a biggest blessings we can think of for this event.
Thank you, Satish.
Thank you. And another attraction for day for us to acknowledge someone who has given a lot to the ENT surgeons in life. Kalelkar, we all know the Kalelkar instruments are
Yeah.
Indian origin, who have been popular worldwide. and has given us on a, as compared to the instruments coming from the Western countries, at a much better price. And today we are happy to acknowledge Mrs. Kalelkar, who is going to join us after some time. And another attraction of the day is from the young, brilliant Dr. Sai Belsare, who is going to talk on a very important subject related to this webinar on stapes, the facial nerve in stapes surgery. I believe this is going to be one of the most attractive part of the day today. Thank you, Dr. Sai Belsare.
Thank you so much.
Sai is going to be the princess of the facial nerve of this country. Sai. And even in stepidotomy, she wants to speak about the facial nerve. That is how obsessed she is with the facial nerve. Welcome, Sai.
Thank you.
Sai is daughter of Dr. Gauri Belsare, and Dr. Sai Belsare is committed to the facial nerve work. She is already working on a lot of things on facial nerve, and today we are going to hear from her about the role of facial nerve, how to manage the facial nerve in different situations in stapes surgery. Thank you.
Thank you.
And then afterwards, we'll have a talk from a very leading radiologist from Thane, Dr. Sneha, on imaging on autosclerosis. That is very, very important, how imaging can give us a lot of information which can be surgically useful. So coming to the first case of the day, as like Ashish said, we are going to have 10 or more cases, probably more, on different aspects of different surgical techniques or dealing with different situations. So to begin with first case, I will take few minutes to discuss on CT scan, the role of CT scan. It has been a age-long debate that whether the CT scan is required before stapes surgery or not. My question is not that whether it is required or not, how useful it is. Is there any harm in getting a CT scan done before stapes surgery? And if it is useful, how useful it can be? So like if I am operating on a ear, operating on a case with a conductive hearing loss with no diagnosis in mind, it's more like exploratory tympanotomy, assuming autosclerosis as a first diagnosis, most likely diagnosis. The CT scan can give us a lot of information not related to the diagnosis per se. For if you ask me, I am not getting CT scan done for diagnosing the condition. The role of CT scan is to give you information regarding things which can complicate your surgical course. Giving anatomical information regarding certain things which are related to the stapes surgery and which can really complicate your surgical course, and you can be prepared with all those conditions to deal with or plan your ultimate treatment. That is how CT scan can really help you, and which is I'm going to highlight. Second is, a lot of people have a concern over giving radiation to the patient when you get a CT scan done. Nowadays, in the era of cone beam CT scan, you can get CT scan done with less than 17 times radiation to the patient with the same, or I would say for autosclerosis, a better quality of imaging required to highlight structures less than 0.1 millimeter in dimension. That is the beauty of cone beam CT scan. That too with a much lower radiation. Third is for diagnosis also, to rule out other diagnoses. See, we are dealing with a condition of conductive hearing loss with the intact tympanic membrane. We never know what is going to happen behind, and ultimately we finally confirm a diagnosis on exploration. The CT can give you a lot of information if something else is going on inside. So that is the role of CT scan, to rule out other diagnoses. So like for this particular patient, can you connect my laptop? My CT scan, and what kind of CT scan we need, let me tell you. CT is, connect the laptop. We need the CT of the entire temporal bone. We get the scan done of, I would say, the 20 square centimeter area. For a 20 centimeter area, to get a fine 0.5 mm scan. Why 0.5 mm scan? So we do not miss any fine structure in the temporal bone. We all know temporal bone is a complex bone with a lot of finer structures into it, including stapes. and we need to know each and every information about the stapes and the surroundings. So we order 0.5, 0.6 CT scans for this purpose, and for a 20 centimeter area to be scanned with 0.5 mm, it will require almost 400 slices in one plane, axial plane. To know the anatomy in detail, three-dimensionally, we need the information not only in axial, coronal, sagittal, sometime longitudinal plane, sometime transverse oblique plane, and so many other planes related to the structures to get more information. And all this information containing more than 2000 slices cannot be carried in a printout, in a bag, in forms of printout by a patient. So the best to order the fine slice CT scan on DVD, and this DVD you can run in this software, DICOM viewer, and you can see the dynamic imaging. Not only you can see this dynamic imaging, not only that, you can see all views in one go. You can highlight any particular structure you want to see, like I am going to focus on the cochlea, and in all three planes we can get to know where the cochlea is. So you can have a complete dynamic information three-dimensionally of that particular area. Number one. Number two, what kind of details we expect from a radiologist if we order a CT scan. Let me tell you our CT scan protocol. Our CT scan protocol we had given to radiologists earlier, and radiologists, we had given them the written points to fill up. And finally, radiologists refused to fill up this detailed form, which can take more than an hour to fill up each and every required information for that particular patient. This is our protocol, the imaging protocol for suspected autosclerosis patient. And what all we need to see in radiology, which I'm going to show you on a scan as well. This is a 0.1 mm section cone beam CT scan. The one I am showing is not a cone beam, is a regular one. The patient has already got done, so I didn't repeat. So what all you need possible, if something is not given in some detail is not given, you can leave it blank. Otherwise, if you see any autosclerotic focus, sometimes you have a big focus, you can see and you can mention the site and dimension of the focus. Regarding the stapes, we need a lot of information about superstructure, thickness of the foot plate. Let me tell you, with the cone beam CT scan, what kind of thickness of the foot plate you can get. And this information, if you have intraoperatively, see this.
Wow.
See this. This is the stapes suprastructure. The neck of the stapes, head of the stapes, incus, and see the thickness of the foot plate with a sensitivity of 0.1 millimeter, and this particular patient had a thickness of 0.3 millimeter, which you can measure through your DICOM viewer. This kind of information on an autosclerotic patient I am operating upon is vital. Ashim.
Yes, sir.
If Ashim is one who has done more than 6,000 stapes. He is the one today who is going to enlighten us with a lot of information about stapes from his experience. Ashim, if you are operating upon a case and given this kind of a thickness of the free foot plate pre-operatively, I know you are not getting CT scan done. With your experience, you'll have a lot of ways to find out the difficulties you can come across. But this CT, this kind of a picture, if you are given before operating on a patient on autosclerosis, is it useful for you?
Absolutely, because you can all see this. In general, a patient who requires the CT scan on a mandatory basis is a patient who is a revision case, a patient who has had one side done with previously reported difficulties, a congenital stapes fixation, suspected congenital fixation, suspected inner ear, a middle ear malformation. These cases absolutely mandatory. But in this kind of a case, it obviously helps you plan. So absolutely, it's very important to plan the process. and gives you so much more valid information. Say, for example, if I want to do a vein interposition, I can already plan for a vein interposition in this kind of a case. So it adds.
So I
to
think Ashim, we as a group, I think let's say that for almost every case, let's bring the protocol of CT scan. Satish,
Yes, it should be done. It
for
should be
sure,
done.
for sure. I think you can anticipate a lot of factors which are surgically very important and relevant.
Yes, Ashim,
Most definitely.
Ashish.
Yeah.
Suppose why this is important. Simple. This one point: the thickness of the foot plate.
Yeah.
If you are encountering a thick obliterative foot plate, see, number one, you have to be very, very experienced to avoid complication. The results of an obliterative focus foot plate than a simple foot plate are much different, particularly in the inexperienced hands. For the beginner, it makes a lot of difference. And if you know pre-operatively in your patient as a thick obliterative focus, you can counsel accordingly for the surgery as well. So this is one of the most important factor, I would say, if I know the thickness of the foot plate. You know, in otology practice, the stapes surgery invites one of the biggest, the collection of medical legal issues. Stapes surgery is like all or none phenomena. The outcome for stapes surgery, the patient can be very, very thankful, where you can give hearing on the table. At the same time, you can end up giving a dead ear. So you have to be very, very careful. And this imaging, which I'm going to take you further with some more information, can really help you avoiding this situation to certain extent.
Satish, can you guide us? Can you guide us as to how to identify the otosclerotic focus on the scan?
Yes. I'm coming to.
Yeah.
It's not always possible, but yes, I am coming to. And I already mentioned, Ashish.
Yeah.
This otosclerotic focus may not be identified on a even good high resolution CT scan.
Yeah, it's not for diagnosis.
A thin focus, a thinnest focus, which cannot be identified on CT scan, can be good enough to fix the stapes.
Yeah, okay.
Can you keep silence? Viru. So, like I mentioned in our previous webinar, how the otosclerotic focus results in jamming the foot plate. The focus starts basically, why I'm saying, Ashish, at this point of time, this is fistula and antefenestrum. Yeah. The focus starts here, the earliest focus starts here, and it starts pushing the foot plate behind. Because of this focus, the foot plate is jammed posteriorly at the posterior vestibular joint. The earliest fixation by this focus giving a minimal conductive hearing loss. It can result in minimal conductive hearing loss and fixation of the foot plate at the posterior vestibular joint, even without complete fixation of the annular ligament. So such patients have minimal airborne gap like 15 to 20 dB. That's why we discussed earlier in what to do in minimal airborne gaps. These are the patients wherein if you are not careful, not having laser, you can end up mobilizing the foot plate if you are operating such patients. Laser can certainly avoid that until the annular ligament gets completely fixed, which gives you a conductive hearing loss about 30 dB. Generally, we do not operate. That's the reason behind that. So the smallest focus at the fistula antefenestrum can result in otosclerotic fixation, which cannot be picked up by a good, even high resolution CT scan. So the diagnosis of otosclerosis, can be given on a completely normal high resolution CT scan. There could be otosclerosis in that situation. So the CT scan is not, ordered to diagnose the condition, to rule out other pathologies and to get more anatomical information. And this picture is regarding the cone beam. Last time we discussed, the Ravi has acquired a new cone beam machine, Ravi Ramalingam.
Yeah.
After our webinar, and this is how you can scan the patient in sitting position in less than 10 seconds. With much less radiation, with much more information, with a resolution of 0.1 millimeter, you can get a good cone beam CT scan done. Now,
Dr. Satish, good morning.
Yes, Gauri.
Cone beam CT is usually done by dental people.
Yes.
In Pune.
Yes.
So, do you have to order something specific? Because I have been trying to get good cone beam CT for my stapes
Yeah,
patients.
you can order 0.1 mm section cone beam CT scan of temporal bone.
Gau-
And
Gauri, make
see,
them talk to Satish, the CBCT people, because unless they
Because
know
there
what to
is
look
some
for,
spatial sequence or something, I don't know, like,
no,
no, no.
because,
See, let them give only axial. Rest you can reform it on
okay,
your own. See, what we acquire is only axial.
okay,
See this.
axial point
What we
one,
acquire is only axial. Rest I'm reformatting through this software. You
okay,
don't need to ask for multiplanar and all that. CT scan can be reformatted. For MRI, you have to ask for every different, sequence, because
correct,
MRI cannot be
cannot be
reformatted
reconstructed.
that way. You have to take this every sequence separately. So for CT scan, you can just ask for axial and then rest you can reformat.
Okay,
Second thing, what I was talking about, this format given to the radiologists and what all need to be seen. For the stapes, you need to see all this, including depth of hole window, obliterative focus, thickness, any malformation, dimension of the hole window, IS joint, round window, any foci involvement, basal ton cochlear involvement, anterior malleolar ligament calcification. This is will have more information from Ashim during his case. He has a lot of experience on dealing with anterior malleolar ligament fixation, and here I can point out, Ashim, we can make out hyalinization, calcification of the ligament, if any, on a good high resolution CT scan preoperatively. That can prepare you before you operate on dealing with this situation. So this is something, a very, very vital information you can say on from CT scan. Any other pathology on the ossicles which can result in fixation and giving conductive hearing loss, looks like otosclerosis, like superior malleolar ligament fixation. We have encountered such cases in our practice, couple of cases on exploration, when the entire ossicular chain found to be normal, and it was the superior malleolar ligament fixation leading to fixation of malleus head in the atic. Similarly, the anterior fixation of the malleus in the attic to the anterior wall through a bony fixation. Similarly, for the incus, any displacement, fixation, absence, joint, any abnormality, facial canal, very important, which can complicate our course. Dr. Saib Elsere will highlight more, but we need to know in every case before surgery how the facial canal is related to the oval window. You know, this is very important to understand. The development of the stapes and the facial canal begins simultaneously in the 6th week of embryo in the fetal life, and this relationship is maintained throughout, and that developmental anomaly at the 6th week of embryo can lead to oval window agenesis, like Ashish discussed yesterday, day before, a case of oval window agenesis with him. So we need to know in every case, and the CT scan gives us a brilliant picture. I'm going to show you the relation of the facial canal to the oval window. If it is overhanging, prolapsing, or anything of the facial canal complicating the stapes surgery, we should know beforehand. If you know that, you can tell your patient in advance, or you can go with the alternative treatment if the patient doesn't agree. So the
Satish,
foramens,
Aditya has asked a question: can the tympanosclerosis be distinguished from
very
otosclerosis on a
difficult.
yes,
cone beam
yes,
Asti,
CT?
tympanosclerosis cannot be picked up so easily.
Cannot. Okay. Okay.
It is
Later, when you
soft.
have the time, you can
Yes,
comment on that.
yes. Sometimes you get a normal CT scan, even having good tympanosclerosis. So that cannot be picked up and differentiated so convincingly.
Okay.
Then the relation of foramen spinosum, we always mention, through which the middle meningeal artery passes. It gives us something to rule out the situation of a, I would say, what
Persistent.
do you call that, vessel
Persistent
passing through
stapedial
the
artery. Persistent stapedial
Stapedial
artery.
artery.
stapedial artery passing to the stapedial arch. So
Obturator foramen.
this
Yeah.
vessel, again, this is, you have to relate embryologically, when the dorsal hyoid artery in the embryo is the principal artery supplying the head and neck, and it finally, you know, disappears as the middle meningeal artery for the future. And from that artery, a small vessel running on the promontory passes through the stapedial arch into the facial canal, and then is destined to supply some part of the brain. With evolution, that vessel disappears, and finally the the middle meningeal artery remains, which passes through the foramen spinosum. In any given scan, if you find the absence of foramen spinosum, you can predict the situation of a persistent stapedial artery. We have come across couple of cases. Ashish last time had demonstrated one
Yeah,
case, I remember,
yeah.
who sent me pictures of a persistent stapedial artery, because then this situation, if you come across intraoperatively, you have to take a call whether to continue surgery or to abandon it. There are a lot of concerns for, ischemia in the brain where it is destined to supply if you coagulate that vessel. There are so many contradictory reports in the literature. Or you can still go ahead with the surgery by keeping the artery in place, by putting your piston besides the artery and with utmost care, or lot many things we'll discuss later. So this situation you can predict by means of absence of foramen spinosum, which I'm going to show you. Along with that, dilatation of the fallopian canal, because once it passes the stapedial arch, it enters the fallopian canal to enter into the brain. And in that situation, when the vessel is there, the fallopian canal dimension is much more increased. The dimension of the horizontal facial canal, which gives you another suspicion. Then the semicircular canals, any malformation, particularly superior canal. We discussed in detail last time about the superior canal dehiscence, which gives you a phenomena of a third window. Third window phenomena is where your sound leaks through the third window. In general, we have two windows which leads to propulsion of the cochlear fluid. The sound coming through the ossicular chain, mobilizing the whole window, and the whole window goes in, the round window comes out, and that's how the cochlear fluid mobilizes. And if there is a third window anywhere in the vestibule, the sound is going to leak and give you a situation of a conductive hearing loss, and which can lead to a misdiagnosis of autosclerosis in a situation of intact TM. A CT scan can completely rule out. I will show you how to rule out the situation of a superior canal dehiscence from the CT scan. Though there are other methods, the patient might have vertigo, the all patient may not have vertigo. The patients have a conductive loss in the lower frequencies, particularly when you have a third window phenomena.
है ना
Patients have
patient,
a
yeah.
much better,
सोनल को
bone
है ना,
conduction sometimes is
सोनल को है,
negative
डॉक्टर सोनल को लेफ्ट ईयर
because
में,
of the increased sensitivity of the cochlear partition to the
वो सरदार
bone
जी ना,
conduction. So all these things are,
माइक्रो शेयर किया अपन उसको.
important for the diagnosis beside the CT scan. But a good CT scan can definitely rule out whether there is a straightforward diagnosis for a superior canal dehiscence, if any, vestibule, any, pass, any abnormality, any, opacities, any piston, particularly in the revision surgeries or post-surgery, even the post-TAPI surgery, sometimes patients have a persistent vertigo. Ashim is going to talk in detail later about the dealing with the post-TAPI vertigo. And if you have a deep piston inside, we always mention the single most determinant of the outcome of the stapes surgery, the single most important determinant, I would say, the length of the piston. And if it is an overlong piston, it is a disaster, what we believe. So you can, by means of a CT scan, good CT scan, you can actually measure the intravestibular length of the prosthesis, though it measures a little more than actually it is by 10 to 20% more, but still it is quite reliable in case you have a long prosthesis. In case you have a persistent vertigo or some fluctuating hearing loss, something abnormal, you can have a good idea of a perilimb fistula by means of air in the vestibule. Air is a good sign of a perilimb fistula, which can occur even months or years later after the stapes surgery. So all these things can be seen on a CT scan. Then a lot of information about the
Satish,
cochlea.
correct me if I'm wrong. Apparently, first 10 days, even after a routine stepidotomy, even if there's no giddiness, you can still find air. Is it 10
Yes,
days or?
yes,
Yeah.
yes. It depends whether you have sealed the foot plate or not. That
Okay.
is what Ashim always, highlights. He always uses the vein graft to seal the oval window. That is effective on the spot sealing, which can certainly be more effective in preventing the situation of perilimb fistula.
Yeah.
So,
I mean,
in
the thing
case
was, if
you
the
are
patient
open,
has, sorry, if the patient has giddiness on day 1 or day 2, and you do a CT scan and find air in the vestibule,
Yeah.
I
Well,
don't think
what
we
day
can
1 and
conclude.
2
Yeah,
is not going to give you any information,
any information. Correct.
because
That's what I want. That's
yeah,
the point I
the
wanted to make. Yeah.
first first week post surgery
Yeah.
as of no relevance as
Yeah.
far as the air is concerned, because it
Yeah.
is likely to be once you open the whole window.
Yeah. Okay. Sorry. Go ahead.
Hello, Dr.
Yeah.
Satish.
Yes.
If you have used a titanium piston, can you do
Yeah.
CT scan?
Yes. Yes.
Will
Even
it
MRI as well. These
uh,
titanium prostheses are MRI compatible.
not the compatibility, but will it
Yeah, it will be
distort the
visible.
image?
It will be visible.
Okay.
You can pick up very well.
That's a big advantage of the titanium.
Yes. Yes. Titanium has a huge advantage, or Teflon we'll discuss whole day as far as the material is concerned. Then about the cochlea, that is very important information. Sometimes there is cochlear involvement, minimal involvement, how far the cochlea is involved, whether the basal turn is involved, round window is involved, how the destruction of the bone is there, any narrowing of the lumen. This is particularly important in patients with a mixed hearing loss or advanced otosclerosis or far advanced otosclerosis. This terminology of far advanced otosclerosis is given to patients having more than 85 dB overall hearing loss, bone conduction loss, and these are the candidates sometime which, on the basis of the CT scan and speech discrimination score along with the audiogram, you have to take a call on continuing with a stapes surgery or a cochlear implantation. We'll discuss in detail, but this is very, very important. CT scan is one thing which has a huge role in decision making for the cochlear implantation. For example, the patient has a far advanced otosclerosis and hardly any cochlear lumen involvement. My first choice would be to go ahead with a stepidotomy followed by hearing aid. Even if I don't get much gain with the stapes surgery, my hearing aid will work better. And first of all, this doesn't rule out the possibility of future cochlear implantation. This is, as far as the cost is concerned, as much less than the cochlear implant, and leaves the possibility of the cochlear implant in future. So in that situation, the stapes surgery should be first option along with the hearing aid, then cochlear implantation. But if CT shows narrowing of the lumen and a lot of bone destruction of the cochlea, then in spite of all other findings and audiograms and all, my first choice would be to implant. Otherwise, that may rule out the possibility of implantation in the future when the cochlea is completely obliterated. So this is, the CT scan is one of the most decision making factor in those situations. Then the vestibular aqueduct, will talk a lot about the cochlear and the vestibular aqueduct, which are maintaining the pressure inside the vestibule, and the dimensions of these aqueducts. The enlargement of the aqueducts, has a lot of bearing on the cochlear implant surgery. Last time in the Stapes Carnival at Jaipur, we came across two huge gushers. All those patients did not have CT scan before, and finally post surgery we got the CT scan done and got the positive findings. So that was one of the patient was a X-linked disorder with a cochlear base defect, and this is how you can pre-op, you can identify any communication of the internal ear with the subarachnoid space. If it is, you can rule out the stapes surgery. You can invite more complication than giving benefit. If your vestibular aqueduct is dilated, that means there is a situation of intracochlear hypertension. Once you open the inner ear, it is going to invite the complications. This is how you can avoid. I am going to focus on one of the slides of the MRI of a patient, how you can avoid operating on these ears to prevent sensorineural hearing loss on the patients. So all these are important: the vestibular aqueduct, cochlear aqueduct, dimension of the intra-auditory canal. It is a misbelief. It is a, I would say, in other way, no enlarged cochlear aqueduct has given a gusher so far. in the stapes or cochlear implant surgery, it is always the enlarged internal auditory canal or the cochlear base defect results into gushers, not the enlargement of the cochlear aqueduct. And we had a lot of publication on it, and one landmark publication uh, uh, from Ashish, your friend, um, from Stanford, who published about the cochlear aqueduct, a huge detailed study on the cochlear aqueduct.
Go on.
This is
That
not
is Rob Jackler. Yeah.
Jackler,
Yeah.
and it has finally been very clear that cochlear aqueduct enlargement is never responsible for any gusher. So, but we still need to see all these factors in your mind and MRI. Then besides that, the cochlear aperture dimension and any other middle or mastoid or temporal bone pathology giving rise to conductive hearing loss, we need to rule out. And CT scan can clearly rule out. That's how, in brief, the role of the CT scan. On this protocol, we actually need to give our radiologists who can, if they're helpful, can really give us a lot of information. But there's still, the written information what you get may not be so useful to the surgeon unless he sees himself the particular anatomy so that he can plan the surgery accordingly, which I'm going to run the CT scan and show you. And this is something about the MRI. Let me tell you something about the MRI. Ashish, I'm sure Dr. Sneha is online. Is
She's
she?
there online? Yeah.
Yes, sir.
Neha, hi.
Yeah.
Yes, sir.
Please, Neha, feel free to comment and
Yes, sir.
correct
Yes.
anything that
So
may be.
this particular sequence of MRI, the reason to get this sequence done, let me tell you. In stapes surgery, we always tell our patient up to 0.5% to 1% of the patient, in spite of having done a brilliant surgery, can develop sensorineural hearing loss or a dead ear. This is all we believe world over. And there are certain hidden regions we do not know. And to elaborate one of these regions, this study was conducted and we had now a number of cases done and picked up few positive results. So this is to see any subclinical hydrops going on. Subclinical endolymphatic hydrops going on. So hydrops is a condition wherein the intralabyrinthine, structures are engorged with the cochlear fluid, dilated. Particularly the membranous labyrinth is dilated. The endolymphatic space is enlarged because of the high pressure. And if it remains subclinical, in a patient with autosclerosis, if there is associated subclinical endolymphatic hydrops, opening the vestibule can be a disaster. So in spite of having done a good surgical work with good fenestration, good piston application, having checked everything, the patient may develop sensorineural hearing loss. And how you can pick up this subclinical high drops. If you are able to pick up that high drops, it is so vital. Are you getting what I'm trying to say, Ashish?
Yeah, Satish.
So this is the study to know how you can pick up the subclinical high drops. So what this MRI is, this is IV gadolinium given to the patient, and after 4 hours of gadolinium injection, this MRI was taken. This enhancement is seen in the perilymphatic space. Can you see?
Yes.
And the endolymphatic space doesn't enhance with the gadolinium. And that property is taken to see if there is any high drops. Can you see this picture?
Yeah.
The perilymphatic space, and see this picture, this non-enhancing endolymphatic space. Can you see this?
Yes.
If such patient, if I have pre-op with this much of endolymphatic space high drops, with a case for autosclerosis, with as usual conductive hearing loss and everything subclinical, no symptomatic vertigo or anything, with this much of high drops going on, I would never operate. And
I
this is
completely
how
agree.
one can avoid the situation of unpredictable sensorineural hearing loss. There are so many regions for the unpredictable sensorineural hearing loss. There are many of them are avoidable, you can avoid, but many are unpredictable. And this is one of the regions which we should avoid in our practice, because no patient with otosclerosis coming to you with a conductive hearing loss is going to digest the sensorineural hearing loss, and this is one of the things inviting medical legal complications. So let me tell you this slide. There are so many regions to the unpredictable or whatever predictable sensorineural hearing loss post TP surgery. And one of the regions which is avoidable is, we always mention, is to avoid suctioning over the fenestra, which can be one of the biggest region inviting the sensorineural hearing loss. So there are so many things beyond your control. These are a list of causes, list of situations beyond your control which can cause sensorineural hearing loss. That's why we take a constant, and that is, I would say, a reality that up to 0.5% of the patients, in spite of having done a good stapes surgery, can ultimately develop sensorineural hearing loss, and that is what we need to avoid. I hope it is clear.
Very clear.
Ashim,
Very clear.
Satish,
Ashim, you want to add on something?
Do you want PGV to make any comment in his?
Sir.
Sir, would you like to comment on the role of CT scan in your?
Sir, please unmute yourself. Dr. PTV, please unmute yourself.
And now I will run this particular patient's CT quickly before I start the case.
Yeah, okay. Go ahead.
So this is the axial CT scan, and we are operating on the right side. Let me tell you what all need to be seen quickly. Number one, this is the superior canal. See the first canal appearing from above downwards is the superior canal. In axial sections, you cannot pick up whether there is,
Superior semicircular canal.
This is the anterior one is the this is anterior one, and this is posterior end, and this posterior end continues as a crus commune joining the posterior canal. So how to see the superior canal fistula? It is best seen in the coronal section, that too dynamically. Now see, this is coronal. Now see, this is vestibule. All the three canals, can you see? This is lateral, this is superior, this is posterior canal. Can you see?
Yes, sir.
Yes.
Now see the superior canal dynamically where my cursor is. See, this is the temporal bone, temporal lobe of the brain. This is superior canal and the thick bone over the canal. See, this is coming. Again, can you see dynamically?
Yes.
Everywhere there is bone. If there is dehiscence of the bone over it, wherein the brain is in contact with the contents of the inner ear, inviting problems, giving problems. See this? This is absolutely intact superior canal. This is how it is best seen rather than on a printout. What's my point? To know the complete information about the superior canal dehiscence, the best is to see a dynamic CT scan, that too in a coronal plane or a I would say another plane. We call it as a superior semicircular canal plane or a vestibular aqueduct plane. This plane is also known as vestibular aqueduct plane. So the first information need to be seen on CT scan when you come from above downwards is the superior canal. Okay? Is that clear?
Correct.
Yes, sir. Yes.
Yeah.
Now coming to the intra-auditory canal. See the dimension of the intra-auditory canal. This looks normal. If you are in doubt, you can measure. At the mid canal position, you can measure. Let me take the measuring. See this 3.3 millimeter, it is not enlarged. If it is enlarged, it must give you a suspicion of an abnormal communication with the inner ear space. And in that situation, when the subarachnoid space is in continuity with the inner ear fluid, there is obviously a high pressure in the inner ear fluid. And that is one of the situations when there is a cochlear base defect. This is cochlear base. If there is a defect, there is persistent situation of a so-called inner ear hypertension leading to the restricting to the movement of the stapes foot plate inwards and giving us false conductive hearing loss, which if you take up and do a fenestration can present as a gusher. So you have to be careful. A CT scan can definitely avoid you from this. This is cochlear base. The dimension of the cochlear base is important. If it is too high, too big, it can lead to a gusher. And this, see, in this particular patient, this base is quite big. See my dimension of this base from here?
Yes.
Oh, this is more than 2 point. Oh, God.
75.
I can get a, God forbid, I can get a gusher. But see, the modulus is good. Can you see the modulus inside?
Yes, sir.
So a well-formed modulus can prevent the situation of direct communication and a gusher. Then the cochlear turns, all the 3 turns of the cochlea at this point of time. And this is the labyrinthine portion of the facial nerve. Can you see?
Yes, sir.
This is labyrinthine portion of the facial nerve going anteriorly, where this is the geniculate ganglion, and from there this is greater superficial petrosal nerve going anteriorly. And if I follow this behind, see, this is horizontal facial nerve. This is horizontal facial nerve. This is where my cursor is. This is the genu of the facial nerve. And if I follow this, this is the vertical segment of the facial nerve. See where my cursor is going. And finally, this is going to go out to the stylomastoid foramen.
How old is the patient, Satish?
Pardon?
How old is your patient?
41.
40. Okay.
So this is horizontal facial nerve. That is important to see in relation to the stapes. But in axial section, upward, coming from above downwards, in this plane, you cannot have a good idea of relationship of the facial nerve to the stapes, because the facial nerve is above the stapes, above the whole window, above the foot plate. So this above downward, relationship is best seen in coronal. Now see in coronal. This is your vestibule. Can you see? This is your facial nerve. This is your lateral semicircular canal. Can you see the lateral canal or not?
Yes, we can.
You see the anteromedial to the lateral canal is the facial nerve, the horizontal and the genu, and see, this is facial nerve. Now where the stapes is, this is your foot plate. This is your vestibule. And now see the ossicular chain. This is in dynamic way. This is malleus, incus. This is incus. And can you see the stapes suprastructure?
Yes.
Malleus,
Not very
incus,
clear.
and the stapes suprastructure going to the oval window. Can you see very clear?
Correct.
And see the facial is above that, superior to that. Had there been facial prolapse, this facial would have been here right on the foot plate. You can have a very good idea pre-op how the facial nerve is related to the oval window. Is it really coming down? Is it really descent? See the bone over it all the way. If it is descent, if it is prolapsing, how it is related to the oval window, you can see very, very precisely with a good coronal CT scan. Is it clear to everyone?
Yes.
So also the narrow and deep niche you can identify very well.
Yes.
It has a relevance to Ashim's vein interposition technique. In those cases, you can't do. And many times, sometimes the width of the foot plate is just 0.8 or 0.7. So then you have to use a 0.4 millimeter piston. All these information you can have pre-operatively. Yeah.
Great point, Ashish. Now coming to your point, Ashish, that is a master's point, that the depth of the oval window. See from this level, this oval window to this, the facial now. My depth is 1.34 millimeter, which is adequate. It's not too much. Got my point? Had this been a deep oval window niche with a lot of obliterative focus, everything would have changed in terms of while you're operating, drilling the oval window region, assessing the required length of the piston, everything changes. Second thing is the oval window dimension, particularly superior-inferior dimension, which is important for piston placement. Your ease of the piston placement. See from superior to inferior, can you see this? 1.54 millimeter is the oval window superior-inferior dimension, which is quite adequate.
More than
Isn't it?
adequate. Yeah. Yes, very wide, very wide. Yeah.
So the depth, dimension of the oval window, everything are important. And if your radiologist, even if the radiologist fulfills that pro forma, giving you all dimension is not going to work unless you see yourself the intraoperative conditions. This is a rehearsal of the intraoperative condition preoperatively by means of a CT scan. That is what I want to point out, that how dynamic CT imaging can really help you during your surgical course. You yourself can see what things can complicate intraoperatively. Our radiologist madam is online. Madam, can you give
Sir,
us all this information on a pro forma? Our radiologist has refused.
I am currently giving all of this except the malleolar ligament. Till now, I have not seen any ossification on CT.
AML,
Breast,
yeah.
oval window, round window, niche. I'm measuring one more thing called as incudostapedial length.
Yes.
On coronal image from incudostapedial joint to the midpoint of the oval window, then footplate stapes thickness, along with that dehiscence of semicircular canal membrane, cochlear duct and vestibular duct measurements, and presence of any other infections or any other pathologies in middle ear.
So we are
Great.
running this parallel the intraoperative measurements and the radiological. We will come out with some data soon.
Yeah, Ashish, it is
Yeah.
actually something which requires a coordination between the radiologist and the
Oh,
surgeon.
she's
Because
fantastic. She's,
being
I think,
surgeon,
yeah,
we need to know, we need
yeah,
to ask the required information.
yeah.
If you prescribe HRCT temporal bone, the radiologist will do maybe with a 2 mm section. They do not know what all you want from them.
Yes,
So we
it
need
is,
to
it is.
precisely tell them that 0.5 mm section we are suspecting autosclerosis, and these are the required information we want to know. And we want this information on a fine slice sections in a DVD so that we can see
Yes.
ourselves multiplanar.
No, your
Sometimes you
multiplanar
need,
DICOM has been a revolution, Satish. You have brought
yes.
it on our, yeah,
So it is the
absolutely,
onus on the surgeon to order proper
absolutely right.
information.
Yeah.
Like for the MRI, I tell you, we have a lot of diagnostic centers with a huge signboard MRI brain in 1,500 rupees.
Yeah.
For the reason I'm getting MRI brain, I know MRI cannot be reformatted always. So like for a tumor, skull-based tumor, I'm ordering an MRI. I will specifically mention that I want T1 weighted axial coronal sagittal, T2 weighted axial coronal sagittal, T2 weighted fat suppressed axial coronal sagittal separately, contrast, 3D contrast, diffusion weighted, and so on. With all these sequences in a DVD, the radiologist cannot do in 1,500 because this will take more than an hour or 1.5 hours. So if you write an MRI brain, the radiologist will finish in 5 minutes, boss, and he can certainly do in 1,500 and out of it. That is not done. The thing is, the onus is on the surgeon to order the required, imaging.
Yeah.
Because the radiologist is blindfolded with the clinical information, diagnosis, and the onus is always on the surgeon
Definitely there has to be an intense
to order
communication.
the required investigation. Yes.
Yeah.
So
Satish,
now,
let's go to the, any more?
yeah, 2 minutes.
10 o'clock.
Then we have seen the facial now, the entire course of the facial now, the inner ear, all the 3 turns of the cochlea. This vestibule, particularly if it is dilated, we need to be very careful. Any fistula of the lateral canal, we have to see here, this is the lateral canal and this is the bone over it. This is the editus, the entire ossicular chain you can see. Now see, at the level of the vestibule, this is the stapedial arch. Can you see? This is the stapedial arch. This is incudostapedial joint. This is incudostapedial joint. This is long process of the incus, the malleus. Now, at this point of time, we need to see if there is any hyalinization or calcification of the anterior malleolar ligament. See, this is malleus, Ashish.
Yeah.
And see, anterior to this is, if there is any hyalinization or calcification, you would find a bony opacity connecting the malleus to the anterior wall. If it is hyalinized or calcified anterior malleolar ligament, which you need to cut across while operating to give a movement, complete movement to the ossicular chain. Similarly, for the superior malleolar ligament, where the head is fixed in the attic, we need the information in the
Coronal plane.
coronal plane. See now, this, let me show you the ossicles. See the ossicles in the atic. This is malleus in the atic. If there is any superior fixation, you will find this bony
This
fixation
is what Amol's
in
case
this
was.
plane.
I think he had a fixation of the malleus.
Yeah. So any information you want in the upside down plane, you need to refer to coronal. Okay. Then about the information of the, see, this is our enteroauditory canal again, the vestibule. This is your round window. This is round window. This is your cochlea, rest of the cochlea. And this is cochlear aqueduct below the, this is intra-auditory canal, this is cochlear aqueduct, this is cochlea per se, and below the cochlea, this is your jugular bulb. See that? We should have a complete information about the, upper extent of the jugular bulb. Sometimes the jugular bulb may be high and complicate your condition. You have to be prepared with that. If you know preoperatively, you are much more prepared and deal with that situation. Similarly with the carotid artery, this is the horizontal petrous carotid artery, and this is the bony partition between the cochlea and the carotid. If this is dehiscent, it can work as a third window phenomena. Again, the vestibule is leaking. The sound is leaking through the vestibule and behave like a third window phenomena. So this information again is vital. So you are not dealing with the carotid artery, but the third window phenomena can be vital. Is that clear?
Yeah.
Then any other thing, any other pathology in the temporal bone which can give conductive hearing loss through with intact TM, and which you can rule out by means of a CT scan preoperatively. And as far as the otosclerotic foci is concerned, a small foci may not be visible. This is oval window. This is oval window. And sometime you may make out the hypodensity at the fistula antefenestrum, which I cannot see here, but you can very well pick up if it is. And moreover, the destruction of the cochlea if there is cochlear otosclerosis.
Aditya is going to speak about a reverse round window reflex.
Great.
To sort of, because he is something which probably is going to have his slides, but he keeps a gel foam in the round window after the fenestra is made and presses on that gel foam to see whether there's a reverse reflex you can see. That is his way of establishing the patency of the system and that there is no third window. Sort of something smart that he's thinking of.
Great.
Yeah.
So anything you want to me to show on the CT scan further, Ashish?
No, please go. My patient is also ready. I have lifted the flap, but I'm not removing the overhang. So,
okay.
Your patient is ready enough, flap elevated?
No. The first case I'm going to show from beginning.
Okay. Can I show the thing then here, or you'll go ahead now?
Pardon?
My case is ready. My flap is elevated.
You can show your case first.
Can I? Okay.
Yes,
okay.
yes,
Okay.
Ashish.
Okay.
I will follow this after that.
Cut.
Anybody, any comment regarding the diagnostic workup, particularly imaging? Any other experience? And Sneha madam is going to give a talk in the sometime
later in the afternoon. We'll see how. Currently, I've told her 3 o'clock.
Yeah.
Because I wanted
to
finish.
In between also, feel free to comment.
Dr. Rajesh from Vadodara wants to know how to identify persistent stapedial artery on CT.
That
I told you,
foramen spinosum.
I told you two things. If there is persistent stapedial artery, let me show you. This horizontal facial canal dimension would have been much more.
Yes.
Got my point?
Yes, sir.
Number two, the foramen spinosum. Can you see here?
Yes.
This is foramen spinosum.
Yes.
This would have been absent, which is through which the the middle meningeal artery is traversing. Because if the stapedial artery is not absorbed, it is persistent, then there is no middle meningeal artery. And that is why the concern is this vessel could be destined to supply some part of the brain. That's why people had a concern in coagulating this. We coagulated two vessels and then went to literature.
Centralization vyavasthit karat raha.
Yeah.
Can we go to the microscopic picture, please?
Yes, sir, please.
Yes, Ashish.
Yeah.
Just to comment.
I have only elevated. I have done nothing because there's a gross overhang here. And I think
Yeah.
majority, the most important relevant surgical step in stepidotomy is
Dinesh, please
actually
enlarge the surgical picture from
straight
Ashish.
knife. Zara.
PGV sir, please feel free to comment anytime.
Tell me once my,
Yeah.
because there's something I want to point out before I begin.
Yeah,
Second,
we got the
Yeah,
picture.
okay.
Go
you
ahead.
want to see
So
the
this is the
flap
right
and
ear. This is the right ear that we are doing. And the moment you raise the flap, and I think Satish will show you the raising of the flap, the only one
yes, sir.
time, all other times. See, between the malleus and the incus, the first thing I look for is between the malleus and the incus. You see this whitish discoloration? You
Yes,
look for
that
the
is the focus.
autosclerotic focus.
That is the focus.
Look at the color of the promontory, the yellowish ivory and the whitish. The moment you see this, your diagnosis is sort of established, reconfirmed, and you also know that the autosclerotic focus is anterior, so your surgery is likely to be easy. The mobility I have checked. Yeah. Now I haven't touched the chorda. The chorda is a little bit more superiorly. It did not get elevated along with the thing, but now, ek number. I can get a glimpse of the chorda here. It's running into a canal here like this, deep inside. So first I will start unroofing this before I start removing my overhang. So I'll use the curette here now. Look at the direction of the stroke, and I will use it to unroof without causing any damage. At the
Ashish,
back, yeah.
can you say a few points regarding preservation of the chorda? How you do?
Yes.
How you go about?
Yeah. So for us, all of
Suggestion.
us, me, Satish, Ashim, stapes surgery is also about preserving the taste. So 2-3 things that we do now in this particular case not relevant, but there's always a mucosal band between the undersurface and here undersurface of the drum and the chorda. I try to preserve that. That way the nutrition and hydration of the chorda during the surgery is maintained. It remains away from your surgical field. This is one first thing that I do. Second thing is like what I'm doing here, you mobilize it more toward where it is fixed into the bony canal so that your stretch is very minimal. And third is you do not allow it to become dry. So I use a gel foam soaked in steroid in Dexa. And if it is getting to be dry, if the surgery is going to take longer, that is when I will keep it soaked in keep it soaked with a gel foam with steroid.
That's a very important
So
point
these are the
because
things I
we
do.
often
And
use xenon light, which is extremely hot, and inadvertently you can chorda. Very important point.
so I am ready and willing to even drill this, but I am trying my luck if I can manage. This is a 60-year-old adult male, so the bone tends to be very thick, but you have to be very patient. And as you go closer, see my movements are only at the wrist, very micro curating I'm doing, not the big one. So it's almost like using a coarse drill, and I'm actually sort of doing the drilling of the bone with the curette. It's a mechanic. So now, yeah.
See how Ashish is trying to preserve even the mucosa on top of the chorda, which carries some of the nutrition.
Yeah, otherwise it becomes dry and it's very
Yeah.
unpredictable. So
Then the taste becomes
the
unpredictable.
chorda has to be respected and worshipped, I think, in all otology procedures.
As Professor Fish says, the intact chorda is a calling card of a good surgeon.
Yes, the chorda tympana is the visiting card of an otologist. That used to be his word.
Yeah. And this is especially true when you're operating on the second side.
Yes, absolutely. But and you are going to operate hopefully on the second side of the same patient. So
no, often you get a situation where one side has been done by a surgeon which is not doing extremely well, and you then choose to do the virgin ear.
yes.
For the simple reason that the chances of your success in the virgin ear is a lot more. Of course, needless to say, such cases will require imaging for sure.
Yeah. So now here I am trying to mobilize it.
Wonderful.
Suction. And what happens is if I don't do this and if I use the gouge and hammer, the bony piece is going to get entangled in the chorda like a donut, and then it
Very
becomes
true.
very difficult to get that piece out.
Very true.
One more time, curate. So you create the I actually waited. I could have done this, but I think this is important to show this part of the overhang removal
Completely.
as you get closer to the chorda.
It's very important not to take huge bites to start with. Until the chorda is completely free of the mucosal attachments to the bone. So one of the questions that always begs to be answered is that 90% of the time in my revision cases, what I have found is that the exposure is inadequate. So you will see Ashish here showing you exactly how much exposure is ideal, and it should be attempted in each and every case of otosclerosis. So it's important to decompress the chorda till such extent as is required in order to have perfect visualization.
The egg number. Yeah, I think I'm okay with this.
Yes.
I will try to mobilize it on the undersurface, right angle there. The other thing, when there is a eggshell thin bone now on the chorda, you can pass your right angle and unroof it, remove the bone over it, and gently lift the chorda off the bone. Yeah, it is getting mobilized more anteriorly. Yeah, okay.
The important thing is to mobilize it
me
further
curate.
down so that there is no stretch on the chord. As you see,
Yeah.
Ashish has perfectly done that.
And now I will try and this is a very thick bone. So let me drill करो दे sir. Let me drill it just as a variation. Let me drill this bone. फिर हमारा gel foam दे.
Ashish, what is the minimum size of speculum you require before you decide to do an endoral incision?
Ashish,
Yeah.
can
Hello.
you show your micro gauze?
Satish, okay, this is a very thick bone. I have to thin it.
Okay.
You know, because otherwise I'll be using too much energy.
Okay, fine.
Yeah.
So that is a good information. If you have a thick bone, first thin it out so you can get it quickly.
Gel foam then.
Rather than mobilizing the entire thick extraordinary canal. So thin out properly so you can control over removal of that bone.
Yeah, I have only had one time where there was a transient facial palsy when I inadvertently used more force with the gouge. Baste, drill.
It hit the facial canal?
Not really, actually. I think
Transient,
I was there on that
I
day.
think the micro crack must have gone. Right on the table, the patient started to feel not good and there was a facial, but in 2-3 hours it recovered.
By the time the patient was in the recovery, it had recovered. I think I was there on that day.
Yeah.
Yeah.
Okay. So now I'm just drilling you to make sure that you don't damage the tympanic membrane or the flap. And there's a
Ashish, may I recommend you put one more wet gel foam so that there's no bone dust going into the middle ear?
Yeah, give me one bigger one. So the middle, yeah. So this bone dust, I think in private we will speak of how important this bone dust is. Because I have a little opinion on that because we do so much drilling in mastoid.
No, but you see, in mastoid, you flush and flush and flush and more flush. As Professor House used to say, that you should use several 100 ml in order to flush out all the bone dust.
So There is overhang removal also, and there's a smoothing of the canal to remove the speed breakers that come in the way. And I think the drill allows you to do that most efficiently.
Ashish, are you, which size burr you are using? Diamond burr?
Actually, the
2.3,
sister, she
2.5.
gave me, this may be a 2.4 or a 2.7 is what I think.
Yeah.
And speed of the drill?
Speed is any. This we are drilling just a regular. It's like a canal plasty that I'm doing, no?
Correct. And angled handpiece or straight?
Angled. Yeah. Ashim, if you don't mind, I'm going to allow myself to be oriented.
Yeah, please, please.
Yeah.
You see how he's making it eggshell thin rather than going through and through. Very important.
The color change.
The bone
You
transparent.
looking. Yeah. Now I have to drill a little bit closer to the corda, so little bit. And the rest of it I will take it out with the curette or with the gouge. We have.
You can see what Dr. Bonkar is doing is that he's hardly pressing down. He's just eroding the bone
Yeah.
like a
You have to be
sandpaper.
careful because I'm also very concerned that it should not touch the tympanomeatal flap or the. Yeah. Give me curette.
Total center. Yeah.
Yeah. So Arvind and Vivek are here with me in the OT to give me moral support.
Arvind and Vivek, Hardik Pranam. How are you guys?
Sakshan जरा मोठा जरा पटापटा तिथे सतीश तयार होईल. You know.
A word about Arvind and Vivek. Both have very experienced otologists, good surgeons. I've seen their Stapes work and Stapes results. Also outstanding surgeons.
Like Dr. Ajay from Mumbai wants to know, are you using any speculum holder?
Yeah, my OT nurse, her name is Sushma.
Live. You see, the problem with speculum holders in our scenario is that we do it under local anesthesia.
Yes.
So there can be micro movements with the patient here and so on and so forth, and that would be extremely traumatizing to the external canal. The Austin speculum holder is best when the patient's under GA, and 9 times out of 10 we tend to 9.9 times out of 10 we tend to do our stapes surgeries under local.
It has to be, if you use the speculum holder, you must do it under GA.
Yeah.
Because if the patient moves, suction.
And for those who don't have extremely well-trained nurses like Ashish is blessed with, what you need to do is learn to use your little finger of the left hand to try and manipulate it, to stabilize the speculum holder, the speculum. And the minimum size of speculum we recommend before you consider going on to an endural procedure would be 6.5 millimeters. Because
Sorry, Ashim, I did not answer that question because I did not know the answer.
Oh, come on, man.
No, I mean, I honestly, I struggle to work through. I'm not good at endural. I'm on record to say that. So, yeah.
So Dr. Rajesh from Baroda wants to know if you are expecting a overhang, do you modify your Rojan's incision, like more laterally you give the incision, something like that?
Yeah, you have to make sure that your flap does not fall short.
Okay.
So that's a good point he's raising. Okay, curate. Sorry, Satish, I wanted to show this.
So now you can see superiorly the facial is coming, just revealing itself, a little glimpse.
Yeah.
And that is the correct amount of exposure. There is something like too much exposure. When you start seeing the body of the incus, that is too much exposure. And if
Yeah,
you
now
cannot
I
see
get,
part of the facial, that's too little exposure. So this is a very
now
precise.
I'm getting the first glimpse of the posterior crust.
Wonderful.
Now the step is, yeah, there are curate. Too much overhang, but see, I
Oh, oh.
but never to rush, never ever to rush to the
This is not a race.
suction. No, what I need to do is move the head a little towards me. And yeah, see the personality is accurate, please. The personality of the posterior crust, Santosh laser law. It's a very uneven foot plate. The thickness is very variable. See, now the entire foot plate is nicely visible to me. I can see the posterior crust. I can see the area posterior to the posterior crust.
Excellent.
And now there's something that I want to usually make a big deal of is when you now this now I'm thinking of where my piston is going to go on the incus sickle knife.
Like Dr. Suhaib
So,
from Lahore, Pakistan is asking any specific, like local anesthesia, any specific thing you give in stapes cases?
no, I think it's the usual, at least unless my anesthetist is doing. So my rule is not to interfere with the anesthetist. So you see this, the way I lifted off the chorda from the incus without stripping the mucosa over the long process of the incus. Otherwise, if you do a harsh stroke, this entire mucosa gets stripped. You must go from down up, release that mucosal band, and then lift off the uh, uh, chorda. And now make it
Very
stick to the
important.
undersurface. There it remains nice. Now I have the advantage. Let me check the mobility one more time.
You
And
can see that it's an
this,
extremely uneven foot plate.
yeah, very uneven. I'll go a little higher in magnification and see.
It's a case
See,
worthy of Dr. Bunkar.
see the post. See, it's like the actually the obturator foramen is actually visible.
Yeah.
The anterior and the posterior crura are actually forming a ring there.
Yes, it's a
So
very thick
suction,
posterior
please.
crust.
Yeah, very thick posterior crust. The superior half of the foot plate is grossly thick. Inferiorly, there is a lot of thin. So very variable. These are very dangerous for a perforator. Laser, please.
So,
So I'm going to use a 0.6 watt, zero point 0.6, yeah. Laser, posterior crust, and a little bit. First, I will take care of this little vascularity here. Doing it's like using your cautery effectively. And now I will.
you're using a continuous mode?
Yes.
Okay.
Which
So I have charred the posterior crust. I will drill, please. We
The
have to go a
advantage
little
of the
quick, so I'll keep
KTP,
making. Yeah,
yeah, the advantage of the KTP is that it is reduces the
being
vascularity
fiber
quickly.
drill ready. See now the other thing my mind is telling me that my anterior crust is visible. The anterior crust, the way it is connecting with the foot plate, I have an access to the base of the anterior crust, which I'm going to later on drill and weaken. Now I'm drilling the posterior crust. This is to PGV, sir, 1993 or 94. जरा सा suction hello. I have drilled more than 50% or 60% of the posterior crust. I am able to see the entire width of the footplate. See, I was making a point that the footplate has a variable thickness. Inferiorly, it is very thin, and superiorly, it is very thick.
Super picture, Ashish.
Yeah, super. Thank you, Satish.
See, this step of thinning the posterior crust makes you,
you are able to keep
avoiding
the
lot of complications.
Yes.
Posterior crust is a thick one, and removal of the posterior crust may invite a lot of complications, including mobilization of the foot plate, fracture of the foot plate, and so on. Thinning the posterior crust, more than that, it gives you more space to work on the foot plate. More foot plate gets exposed. See now the exposure of the foot plate.
See, now I can see the entire width of the foot plate.
Yes.
And you can very clearly make out the laser, please, quickly.
See, the picture is dramatically changed.
Yes.
The visualization has improved like anything with only one step, drilling the posterior crust or vaporizing the posterior crust, whatever. You remove the posterior crust, thin out.
Can you
show the microscopic, please?
Microscope picture, please.
Ashish,
Yes,
using
Satish.
KTP, you want to see?
Yeah, I just used it. Now I'm going to what I'm going to do is that thick part superiorly, I'm going to thin it out and make it look gray thin like the inferior part. The foot plate.
The important thing here is the saucerization of the foot plate.
Yeah,
And
you have to make
should
it
be
all
perfectly flat.
Yeah, Dr. Bashrat and many other people are asking the settings of the KTP laser, like which pulse, what are the wattage, and other things.
कर दिया? क्या लग रहा है? कल क्यूरेट भी कर दे थोड़ा.
नाही फुट प्लेटला ड्रिल करून थिन करायचे.
Ashish sir,
this foot plate, yeah, I'll answer that. I got that question. Let me thin this out. We generally keep it at 0.6 or a 0.8, but I'm not. I mean, this is more of a technical. Now watch this. I am just drilling and thinning the foot plate, which is the thicker part. There are 0.7. The motor there. So I'm not making a fenestra. I'm going to make the foot plate thin, even, and bluish gray like the inferior part, the way it is thin. Because if I make a fenestra now and measure the length from the thicker part, I will be terribly short. So I have to make the foot plate evenly thin before I make my measurement.
and sir, before beginning of this webinar, we are getting this question again and again: how to measure the accurate length of the piston and all those things. So can we discuss that also?
Suction, yeah. Udbhav, this is a very important step. So let's concentrate. See this now?
Yes, sir. Yes.
See, the entire thickness has gone away. Where the fenestra will come, it's all looking now blue-gray. And you see, there's still a little bit of a thin layer there, manageable, but suction and quickly here. And then we will come now from this point on. You can make the length measurement. I have to thin it, but not penetrate. Okay. Now I'm good. Malay dry gel from there.
There's one caveat that I want to say. In this case, the mucosa is not very thick, but in cases of thick mucosa, it's important to first demucosalize the foot plate. And that is particularly true of obliterative otosclerosis, in which the mucosa is routinely thick and vascular.
Yeah, which is where my KTP laser comes handy.
Absolutely.
Because I can quickly, there are suction, thoda dada de canala. See why that overhang removal, the bony overhang removal was so important. There's so much work that you have to do at the foot plate. It's not just about making a fenestra. You have to understand the personality of the foot plate and accordingly manage it. Suction, please. Suction, please, quickly, and be ready with the Satish. 10 more minutes or less.
Ashish, superb.
Yeah.
Going on.
Going
Carry
on.
carry
Sorry, there are ready. Okay.
No need to rush.
Yeah. Okay. Now it is nice and thin. The foot plate. See, the thicker band is gone. 1 minute. Give me 1 number there. See, let me show you the anterior crura and the way I call it the anterior crura foot plate junction. See, this is the anterior crura and it is getting attached to the foot plate here. Very thick anterior crura foot plate junction. I'll do my piston length measurement. I will put a shot of laser here and make this also weak. Sometimes if it is thick, one can go ahead and drill the anterior crus at the base itself. But in this case, the crura looks flimsy. It does not look too strong. But the crura foot plate junction is dangerous. See, it is very thick. If this anterior crura comes out with the base, you're going to get anterior half of the foot plate coming out. So this is what the anterior crura is talking to me. It is inviting me to weaken it before it can be fractured. This is something that my mind is telling me, beware, beware, beware of the anterior crura foot plate junction. But for now, I'll do the fenestra, I'll do the piston length measurement. Unfortunately, I don't use the measuring rod. I use this piston rehearsal technique is what I call it. Ek number. This gives me a lot of information besides just the length. It tells me the ease with which it is going to go. It tells me the point X and Y, X on the foot plate and Y on the long process of incus, of where my fenestra should be for the most precise perpendicularity. This is quite long. There I can also section there, but
See, what is showing is the most practical way. Rather than falling into the length, millimeter, whatever, is most practical way what is looking at. So the piston is sitting on the foot plate. We all know the thickness of the foot plate is a fraction of millimeter.
yes, because we have made it thin. See, it's not on a thick foot plate that we're doing. Fine section.
Yeah. So he
you
looked
make
at
the
the
foot
loop
plate-
of the piston in relationship to the long process of the incus.
Sir is doing a rehearsal.
That's a right angle. Yeah. Many times at this point, the chorda tends to trouble you a lot, and that's when, because it does not allow. So I will now cut the length. This is more of a trial and error and judgment, but you have to keep taking it back down there. And it tells me a lot of things besides the point X and Y. It tells me whether my overhang removal has been adequate or not. Later on, when I have to crimp the piston, whether my crimper will go in the forceps. Because this is a good point before the fenestra is made, to make sure that everything else, once the fenestra is done, every other surgical step is absolutely adequate or perfect. Many times the overhang removal superiorly is inadequate. That's when you will have problem with getting your crimping forceps in. Satish has permanently solved the problem of crimping by using the titanium clip. For some reason, me and Ashim are not yet. Not some reason. It is because I like to cut the piston and until they come out with the easy way of cutting a titanium piston like the Teflon, I am unlikely to change. Although I would also like the precision of crimping which the titanium clip offers. There is no doubt that that is the best possible crimping on the planet. The clip, titanium clip, the way it gives you, the way it protects the...
Like Dr. Fazal from Pakistan wants to know.
See this, Udba.
Yeah.
See this. This is what we were telling. Now we know the point there. See, this is the loop of the piston, and the loop of the piston, the inferior edge of this loop is what you relate with the long process of incus. Somewhere about the midpoint is what it should come. It's slightly longer, so I'll remove a wafer thin little later on, because sometimes we can go wrong on the judgment of the thickness of the foot plate.
Very
Yeah.
nice, sir. Yes,
So
nice.
this is like just about adequate or slightly long, and I will take away the slightly part. Sorry, you are asking some question. Yeah.
Yes, sir. Dr. Fazal wants to know if by chance we have cut the corda, is there any way to again repair it? Any material available to repair the corda?
No, not that I know of.
Not really.
Satish can answer that question if there's something in
Not
literature.
really.
Now,
Corda
sir,
is a complex nerve. It contains the mixed kind of fibers destined to
original taste
supply.
pathway.
Can you centralize, please? Yeah, thank you.
Yeah.
Sorry, Satish.
Destined to supply the salivary glands. Destined to supply the test sensation,
I'm
the
just
spatial test
changing the
visceral
steps a
fibers.
little bit. I am going to laserize the anterior crura. See, I can go way anterior. And
Can you precisely see the anterior crus?
yes, very nicely.
And how often you are able to see this anterior crus? Clearly.
So very often, Satish, because what I do, I used to call it the B notch. Ek minute, ek number there.
Can I ask him here how to improve the visibility?
See here, this overhang, Satish, this overhang, the posterior superior, this overhang, if you remove it a little bit more, then you can go to the anterior crura in an oblique way. Laser.
Ashim, how can you improve the visibility of the anterior crus, and how often you are struggling with the visibility of the anterior crus?
No, I agree. Once in a while, the anterior crus is very difficult to visualize, and the way Ashish has described, you take away a small additional posterior superior quadrant curating or using a Gaussian hammer, and you will be able to then turn your microscope and be able to visualize it quite well.
And is it really required always?
No, except when you are suspecting an extremely thick anterior crus. Most of the time, the anterior. I would say 1 in 10 cases.
It is so unusual.
No, I would say once in 20 cases, the anterior crus is extremely thick.
Really?
In that case, what I generally use is a diamond saw.
Satish, when I don't see, initially when I raise the tympanomeatal flap, and if I don't see that anterior focus, that is when I'm more worried about the anterior crura. Because the anterior focus sort of holds it there, right? If that is missing, then that anterior crura is little vulnerable.
So now I have also often started now, Satish, that in case I'm not really able to see it, sometimes every visualization is very narrow and all that, one can start using the endoscope just to have a look.
Okay, I'm making the fenestra now, the 0.7 diamond burr.
So, see why I'm asking this. Our concern for the anterior crus is while fracture the suprastructure, if it is too thick, can mobilize the foot plate.
Absolutely.
So how significant the thickening in terms of percentage of cases this anterior crus is, which requires a proper drilling or something, vaporization or something.
You see, one of the most important things that I've noticed is that when there is a vertical bar of bone going from the anterior crus to the posterior crus with a blue part of the foot plate inferiorly, those are where it's going to be the most vulnerable. I'm sure Dr. PGV will agree with me that in that area, in such cases, it's very important to be very...
Satish and Ashim.
Sorry.
Let me show you besides the laser.
Yeah.
Satish, now my incudostapital joint is intact. My assembly is intact.
Ashish,
so
can I interrupt you for a moment?
Yeah.
At this point, for everyone who are watching, see how Ashish was suctioning around the fenestra.
Yes, not on and around. Yeah.
One of the most common reason to give sensorineural hearing loss or inner ear problems.
So we have a perfect fenestra there.
He was suctioning around the fenestra with low power was the key. This is the commonest reason to give inner ear issues. Directly suctioning over the fenestra. Yes, Ashish, now you can.
So now, because my incudostapedial joint and stapedius is intact, I have my incus is not going to get subluxated. I'm passing the burr below the long process towards the anterior crus, and I'm going to drill it a little bit to further weaken it. See that?
Yeah.
Unfortunately, there was a little oozing coming from there.
Talking about the oozing, one of the important thing is do not get scared of the oozing. Always the blood will remain above. The only way you'll get blood into the vestibule is when you suck out that part. So it is always better to suck around and don't be in a hurry to suck the blood, allow it to clot, and then you can use a pick to remove it also.
One more important thing
Piston.
here.
Okay, I'm going to.
As long as the vestibule is full of perilimb, the pressure inside the vestibule is always more than the pressure inside the middle ear.
Exactly.
As long as the vestibule is full of perilimb, this blood is not going to seep inside.
Absolutely.
So don't worry about that. You are not supposed to suck directly over the fenestra to remove the blood. See, Ashish had removed the blood from over the fenestra by sucking around it. And you can see at the end of that, the perilymph was completely filling the vestibule undisturbed. See again.
Yeah, there are 2-3 tricks. Maladra dry gel from there.
See this?
There are 2-3 tricks now. This has stopped. Otherwise, what you do is you take a dry gel foam,
over the perilymph,
a big dry gel foam, and keep it either posteriorly or anteriorly.
Yeah,
Now it has stopped.
Ashish, your
So
voice is not audible.
Hello? Hello? Can you hear me now, Sir?
Yes, sir.
Very
Yes, sir.
feeble.
We can hear
Yes,
you.
sir. We can hear you, sir.
Suction, please. Satish?
Satish, sir, got some little bit power failure. So,
Dinesh, Ashish's voice is not.
sir, आवाज आ रही है, sir?
We are getting the voice. We are getting the voice.
We are getting voice, sir.
Hello, can you hear me, sir?
Perfectly circular fenestra which Satish is going to show.
Perilymph.
See, why I don't like to strip the long process of incus off the mucosa is this step otherwise becomes very difficult. The moist mucosa allows the piston to stick to it very nicely while you're doing the I like to do it in a very graded manner and not one shot. So I like to see the piston entering the fenestra. I like to make sure it is not snug. I like to see that it's going in 1 minute.
Dinesh, do something. Ashish's voice is not properly audible.
Sir, from your side, sir, it's audible to us. Actually, they're changing a TV. Already I talked to the local guys.
See now, the piston, the lower end, I know it is not too wide, the fenestra, and the ease with which it is slipping in. The sorry. This is okay. Now it has gone. The lower end of the loop is in line with the incus long process. And all I have to do is just make sure this moves at the right angle. All this is giving me a lot of information that the fenestra size is not snug. Sometimes if the fenestra is too snug, this 90-degree movement of the loop does not happen well. Sometimes if the perpendicularity is not good, the piston tends to come backwards. Suction, please. Now this is all fine. I'll go ahead and do the crimping. Speculum angle, yeah, it's okay. The right side. Now for the crimping, it's very important. See, actually you can't see it. My left thumb is stabilizing the shaft of the crocodile forceps that I'm holding, like in a billiards table. And then I'm seeing both ends of the forceps and then very gently Once it is in position, I have to move the fingers. Ek number. Because my entire assembly is still intact, because my incus is still supported and stabilized by the stapes suprastructure, I can crimp at leisure without any fear of subluxating the incus. This is the other reason why I like this reverse stepidotomy. Yeah. So it is all done there. And now, of course, the surgery is not at all over. In fact, the main steps are now coming in. Yeah. So now things can go wrong, right angle? So now I like to disarticulate. Again, this is something which I like to do in a very calculated way. Go into the joint capsule, puncture the joint capsule a little bit, and then
This is a very important step, and you can see what Ashish is doing is that he is disarticulating in the axis of the stapedius.
Yeah.
And not from side to side. A very important step.
Here, Ashim, we are at a point now when we are thinking that we should be doing this disarticulation before I put the piston.
I generally do that before I put the piston.
Yeah. Suction band padla.
But you know, this surgery is a matter of habits, passions, preferences, and prejudices. So, whatever works. The only reason I tend to do it first is because I want to really check the malleolinguinal joint. You know, there was a lot of discussion earlier on today regarding the recognition of the ossification.
Sorry.
9 times out of 10, it's not.
Now I have to, I have to cut the stapedius. Sorry.
Dr. Girish wants to know indication for reverse stapedectomy, when to do, when not to do.
Ashim can take it.
See, when not to do is very clear. The point is that when you have a very, very, very narrow access, you really need to drill out the complete posterior crust, because sometimes it's only the thickness of the posterior crust. The oval window is about as narrow exactly as the thickness of the posterior crust. In that case, there's no question of doing a reverse tapedotomy. In other situations, when you are planning to do a vein interposition, for example, it does not make sense to do a reverse tapedotomy, because you need to first remove the anterior and posterior crust, saucerize the foot plate completely, and then put your vein, and then put your piston. So in these cases, it's an absolute contraindication to do a reverse tapedotomy. Otherwise, in most of the cases, you can always get away with doing a reverse tapedotomy, exactly as Ashish has said. And that was a beautiful fracturing, and that was entirely thanks to the proper drilling of the posterior crust to thin it completely, and the lasering of the anterior crust to render it weak, so that the removal will not create a problem.
Right angle.
Because one of the issues that we have seen is right at the very end, everything has gone off perfectly. And then when we try to remove, the anterior crust is very thick and it mobilizes the whole foot plate.
Yeah. So this is fine. Yeah. So,
So
now there's a little clot that has occurred around the fenestra. The fenestra was of a perfect size. So this is okay. We are done with this. The chorda, all good. Sometimes there's a middle ear, there's a blood clot in the middle ear around the round window.
Yeah, that should be sucked out, but the blood clot in the oval window is preferred, not, you're not supposed to remove it.
Yeah. So Satish, I'm done. You can.
Yes, superb.
I just have to get the,
And see the best thing.
Outstanding. Super. As always.
What I learned out of it, the message to everyone is.
Ek minute. Satish, sorry, 1 minute. What I'll do is I'll park the chorda right angle there. I'll park the chorda inferior to the loop of the piston. If it's anyway getting parked like this, I would like it to come here and then go here.
To prevent the piston from slippage, huh?
Slippage additionally, like something like that.
It's an additional reinforcement.
I would rather have it below it rather than in
Ashish,
above it.
you can place a very small gel foam over it as well.
Yeah.
Between the corda and the drum anteriorly below the piston to keep it in place.
Okay.
It will not
Right
mobilize
angle
then.
there. Right angle.
Very
One
small
never
gel
knows.
foam.
Actually, the corda may migrate and get attached to the undersurface of the
So
drum
that will
also.
prevent, that gel foam will
That-
prevent, surely.
Acha. Okay.
Because if it stays for a day or
Sir,
two,
there are a few questions. Can I take them, sir?
Yes, please. This side knife. Yeah, please take.
Sir, Dr. Girish has asked prolapse, and facial now touching the prosthesis.
I'm sorry.
Sir, prolapsed dehiscent facial now, if it's touching the prosthesis.
Yeah, nothing will happen. And I think Sai is going to cover that. I'm sure she's going to cover that. But Ashim and Satish can be. My experience, it
yes.
does not affect the hearing at all.
It doesn't affect the hearing and it does not affect the facial.
It does not affect the facial. Yeah,
As
true.
long as it is in contact, touching the facial now, it is not going to give any problem.
So if the shaft of
Unless
the
it
piston
compresses.
touches the nerve, it's not a problem. The hearing is as good.
Yeah.
Because it is.
In fact, if the organizers permit, I have a 3-minute clip to show how to deal with an extremely prolapsed facial, which we can show towards
We
the
would
end.
like to see in between.
Ashim.
Yeah.
We would like to see.
You are the organizer. You have to permit yourself.
No, let's see how time goes and then accordingly.
Yeah, no, sorry. I took little longer, but I thought that overhang removal showing was important.
Yes, Satish.
Ashim, feel free to show some of the interesting videos during changeovers.
Yeah.
For everyone's benefit.
Yeah. So this is over now, Satish. You can show your case, and Ashim, your case is ready.
Yeah, my case is ready. I can start as soon as Satish starts.
So Satish
Because
has
Satish will end
indicated
before I
to
take
us.
the incision.
Satish has indicated to us on the CT scan that he may have a gusher situation. So I'm very excited.
Yeah. I'm also looking
I
forward
don't
to
think it is going to give because the modulus was good, but still the aperture was a big one. So before I start, I would like to mention few points what I learned from Ashish, very important for everyone. One is to show patience. He drilled the part of the foot plate in spite of having a blue area, adequate blue area below. Number two, the piston rehearsal. This is to ensure the adequate length of the piston. This is to ensure not using an overlong piston into the vestibule. That is most important. Third is not to suck over the fenestra. That was the best demonstration you could see, how he was sucking around the fenestra without disturbing the perilymph at all. That is something which invites the biggest problem.
Yeah, so you also use
a surgery. I told you this is a sort of all or none phenomena where the smallest of the problem can give a sensorineural hearing loss, which any patient walking in with a conductive never wants to go back with sensorineural hearing loss, even the surgeon. And this is the surgery which requires the extreme level of diligence. The exercise at the foot plate level must be very, very accurate. And this was one of the best demonstration. Thank you, Ashish.
Yes, Satish, thanks. We use a 26 number gauge suction when we are near to the foot plate.
Super. Super. So now, this case, the next one, I have already shown the CT, which we have already started because we had the time. So we had already induced the case. So we have already raised the flap. I'll show you what we have done to raise the flap, how we raise the flap. And in one of the next case, we'll show from beginning. This is just to utilize the time during the first case. Now, microscopic picture, please.
एक additional point. If you have persistent stapedial anomaly, then horizontal part of the facial.
Let me know when you get the microscopic picture, please.
We are having pictures, sir.
We are getting the picture, sir.
Now?
Yes, sir. We are able to
मैं
see the
ऑडियो ऑफ करता हूँ
microscopy.
इसका, खाली देखता हूँ. नहीं नहीं ये क्या, हाँ उधर का टीवी बंद करो चल.
Sir, just Ashish, sir, just mute your mic, sir.
How is the picture?
Good, sir. Good. Good.
So this is a few words regarding exposure. We always mention this thing. The exposure is the key to facilitate your further work smoothly. So the points to remember, important point for the exposure, that the reason, what is the reason behind a good exposure, the need of good exposure? To visualize your foot plate completely, to work over it, and secondly, to maneuver your piston and instrument, which requires adequate space. And how do you get to know? First of all, superiorly, you should be able to see the fallopian canal. Looks little prominent. We saw the thick bone over the stapes, the facial now. I showed in CT scan there was a thick bone over the horizontal facial, and the facial was not decent. And second point, important point is, see, this is a long piston or long process of the, yeah, that is the long process of the incus, which started broadening, and that is the point to stop. If you expose more going up superiorly, it can lead to problems as you deposit your flap, which may come in contact with the incus, may medialize, and can come in contact with
Can
the piston later on.
unstabilize, it can destabilize the incus itself.
Yes. So the point is not to go superiorly beyond the broadening of the incus which has started, and at some point of time you even see the incudomyolar joint. Now see here what I'm going to show you. The inferior aspect of the incudomyolar joint. See, this is my malleus. Can you
Centralize,
see?
please. Centralize, please.
Yes.
This is a very stout, long process of incus, a very thick incus. Yeah.
Yes. See, this is my malleus. You can see.
Yes, very nicely seen.
This
You
is
can
the
see.
inferior aspect of the inculomalleolar joint, which has just become visible.
Visible, yeah.
So these are the important points for the exposure limits. See the
Yeah.
inculomalleolar joint.
Very nicely seen.
I would say it could have been a half a millimeter less, this exposure.
Yes, agreed. Yeah.
Now posteriorly, see this space from here to the canal wall. You should be able to see your complete length of the foot plate anterior-posteriorly, number one. Number two, you should be able to maneuver your instrument and the piston behind properly. See
yes,
that?
one should get a good access posterior to the posterior crus. This is what he did. He tilted the head and now he can see the posterior edge of the posterior crus.
Tendon of the stapedius. You can see the pyramid from where it is emerging. It's not always required that you should be able to reach to the level of the pyramid to expose. It is your judgment that how much space you need posteriorly and how your entire foot plate is visible behind. So this is your tendon,
trick. The
and
trick
this is
done.
your posterior crus. This is your
very,
posterior
very
crus.
well visible. Very well. There is a
Dr.
gel foam
Satish?
that he has kept
Yes,
attached to the corda and the undersurface of the drum. Please note that. He's keeping it moist and he's keeping it away from the surgical field.
This is something I learned from Ashish, to keep the corda relationship with the undersurface of the drum intact at some point of time. To nourish it.
When do you call it a narrow niche? Is it just a visual impression?
A little, I would not call it narrow, but yes, the facial canal is prominent.
Correct, correct. So
it is not the facial. It is not the facial which is prolapsing. It is the thick facial canal. Okay.
Yeah, but when do you call it a narrow niche?
Narrow niche when the superior inferior dimension is less than a millimeter.
Correct. And what is the ideal distance between the suprastructure of stapes and the fallopian canal at that level? At the level of the
Yes, I got
neck
your
of
point.
stapes.
The
You are talking
distance.
about the height of the stapes?
No,
Not the height. The
she's talking
distance
about this
between.
distance between the stapedial crura and the fallopian
Correct,
canal.
correct.
The distance between them.
1 millimeter or.
Yeah, 1.3 millimeter according to the literature. If it is so, it is considered adequate. See, it is the experience how you look at it. I cannot summarize in terms of distance, millimeter, some millimeter, but yes, you have to assess. Now, assessing the mobility of the foot plate, that is important. See, I'm mobilizing the malleus.
Yes, you can see the play in the incudostapedial
See
joint.
the
capsule.
incudostapedial joint here.
Yes,
here.
very nicely. Yeah.
Can you see?
Yes, beautiful, Satish. Yeah.
Now, if I mobilize the posterior crura, see the posterior crus.
Yeah, rock hard.
The foot
Yeah.
plate is completely fixed. That confirms my diagnosis, number one. Number two, now with such narrow area, see what Ashish did. He thinned out the posterior crus and improved the exposure like anything. This is important because the posterior crus is stout. Now, like in this particular case, I'm using my luminous laser. I don't need to do that. I would vaporize the posterior crust completely without any mechanical movement. My concern in the stapes surgery is always at two places where there is always some sort of uncertainty we have in terms of giving complication by means of mechanical movement. One is while doing crurotomy, removing the crura can mobilize the foot plate, particularly if it is not completely fixed all around, number one. Number two, at the time of fenestration, again, you can mobilize the foot plate, you can subluxate it. So you have to be careful at these two steps. And this has always given us uncertainty, which made us to look for something and which ultimately we found a couple of years back. It's been now more than 13 years I've been using this laser. It's completely, I would say, not touch technique, no mechanical movement, and I can certainly avoid, a mechanical movement at the level of the foot plate. If I am not having laser, one of the case will show. I would do like what Ashish did. I would thin out the posterior crust to prevent the mobilization while crurotomy. And I would do, if the space or the anatomy allows, a reverse stepedotomy, the fish technique, wherein taking the advantage of the entire fixation of the stapedial arch with the tendon and everything, IS joint, I would first make a fenestra to prevent the mobilization of the foot plate, put a piston, and then dismantle the suprastructures. This is another strategy called reverse stepedotomy, proposed by Hugo Fish, which we do. And one can do if you don't have a laser. That is something to add on to the safety of not mobilizing the foot plate. So here I am going to show you the classical, value of the laser. First of all, I will disarticulate the incudostapedial joint. Where the joint is? Joint knife, patla wala.
I was about to say it's a very thick.
Yes, joint capsule. And one has to be very careful not to traumatize the lenticular process. We have to be careful not to traumatize the lenticular process. Other one.
Amazing how much literature is there only on the incudostapedial, the joint, the capsule of the incudostapedial joint. People have studied the Sherpa's fibers and how it creates an illusion of it being one body. It's unbelievable how much.
Ashish,
Satish.
If I show in magnification, see this.
Yeah.
See the vascularity over it.
Yeah.
Let me see the vascularity over the.
Yes, from the vessels running from the stapedius
lenticular process of the incus.
Yes.
See the vessels.
Yes.
One of the regions people try to preserve this tendon is to preserve this vessel coming to the IS joint. Can you see the vessels coming over the tendon?
Yes, very nicely.
This is one of the regions, besides, preserving the tendon for other regions, that is doubtful. to preserve the reflex, but certainly it helps in preserving the vascularity to the dicey
To the
lenticular
lenticular
process.
process, yes, absolutely.
Another vessel coming from above, and one is coming from here, other from the stapedial arch from below. Now, where is the joint? See, if I mobilize antero-posteriorly, that is the level of the joint. Could you
You
see?
can see the cleavage, yes.
Yes,
Correct.
sir.
And
Very
I'm
nice.
gently trying to insinuate my joint capsule.
Yes.
Yes,
So
the
the-
knife into the, yes, perfect.
Yeah.
Can you see?
Yes.
Yeah.
Sir, Dr.
That's a
Manish
beaut-
Juvekar sir is asking to place the piston perpendicularly. Do you have a fixed exposure of the incus in every case, or you differ case to case?
Do you have a what?
Sir, fixed exposure of the incus.
What
exposure of the
exposure?
incus is important, and what I've already commented, the maximum exposure one can think of. In exposure of the incus is one should know when to stop. It
Okay.
should not be overexposure. See, from the piston placement point of view, the ideal place to place the piston over the incus is 1.5 millimeter above the lenticular process.
Okay.
For piston placement, this further incus is not exposed.
Yes.
The reason for exposure of the incus is to look at the inferior aspect of the incubomalleolar joint, to go further if you want to see the anterior malleolar ligament, to keep an eye on the fallopian canal as an upper limit, and to improve the superior exposure of the oval window. Not for piston, not for piston placement. Piston placement, for the ideal place for the piston placement is 1.5 millimeter from the tip of the long process, which is somewhere here. So this exposure of the incus is an important thing to talk about, and the basic thing is to prevent an overexposure of the incus. So one thing is achieved, that is IS joint, this articulation. Now the other thing, before I come to the important point of chorotomy, what I want to show with the laser, this vaporization of the tendon. I can take a sharp scissors and cut the tendon as well without any issues. But if I use the laser, would be a sort of rehearsal of my laser before I go to the critical steps. Got my point?
Yes,
See, this is an aiming beam. This is an aiming beam laser. Let me focus my laser onto it, reduce the red. ये पूरा नहीं आ रहा गोला. Red increase करो. Let me show you my aiming beam. We'll discuss on the laser. What Ashish uses is a KTP laser, the visible laser. The CO2 is an invisible laser, and this is carried to the point, to the target through the holmium laser. Now, can you see my laser beam? Can you see the beam?
No, sir, it's not very clear.
On to the
Yes, now we can see.
tendon.
Yes.
Now, I will simply vaporize the tendon in no time. This is not very important. You can use your conventional instrument, scissors. Yes, ready? Say this, focus the beam, match the focal length.
Sir, can we place some wet gel foams in the middle here when we are doing this?
Now see, where is the tendon? Gone, vaporized. Can you see? And what you see in front of you now?
1 minute, पंच इकडे या ना.
Can you see the posterior crus? Very prominent stout posterior crus. Can you see? Is it visible or not?
ही खालचे आहेत ना, खालून आणल्यात ना.
Hello? Gel form. Hello?
Yes, sir, we can hear you, sir.
See, one of the laser fire on the posterior crus you can see. Now there's a thick posterior crus. My foot plate I could see below. My facial has a thick bone, so I am not worried about using the laser over here. One of the regions, sometimes for not using the laser, so freely is when you have a prolapse facial now. Dehiscent facial now. In that situation, we don't want the laser energy to affect the bare facial now. In that situation, either you cover the facial now with a wet gel form or use a laser with minimal wattage after covering the wet gel form, or
That is
not to
where
use it.
fiber guided has an advantage, Satish.
Yes, yeah, that is more precise in the sense, but still you can. It is not about aiming the target. It is about giving the thermal energy to the surroundings. And this CO2 laser has a beauty of being absorbed by the fluid. See, this is an invisible laser. That's why we use the wet gel form which absorb the laser energy. The CO2, the KTP laser is a colored laser. It has an affinity for hemoglobin. It has a beauty of, hemostasis which CO2 doesn't have. And it is not absorbed by water. So here, if you ask me, KTP has a disadvantage because it is not absorbed by the water and can transmit the heat energy further in the depth. So there are different lasers with different characteristics we need to know. And now see what I'm doing. My aim would be to vaporize the posterior crust, because my fear is if I try to remove this posterior crust, thick posterior crust, I may mobilize the foot plate. I never know the kind of fixation at the periphery all around, and my mechanical movement may not be perfect to prevent mobilization. So here, what can assure you preventing mobilization is this no touch technique laser. कितने पे? बड़ा? हाँ. Now I will vaporize the posterior crust easily. See, I'm slowly vaporizing it. थोड़ा सा बढ़ा देना. See how thick and stout the posterior crust is. Can you appreciate?
Yes, sir. Sir, Dr. Minesh Juvekar sir wants to know the laser beam settings.
Laser beam?
Settings in this luminous laser. Power and voltage.
Okay, I am using a 0.3 mm beam. I am using 12 watt for this crust. I was using 10 increased to 12.
Okay.
See how stout it is. Now give me, see it is thinned out. Let me check. No, देना दूसरा वाला. See, it's already gone. Can you see?
Gone, Satish? Crush is gone?
Yes, this posterior crust.
Yeah.
Suction. See how it is vaporized. Look at the posterior crust. Let me remove the gel form. बंद हो गया.
Very normal. This is a slightly stout.
Give me other section. See, my posterior crust is vaporized. Let me show you in a moment. Centralize. I'm just removing the gel form to show you. Can you see the posterior crust?
Yes, sir. Yes.
See what I was saying, that I have already vaporized the posterior crust. Can you see very well? Can you see the free stump? And now the onus is on fracturing the anterior crust. That's what I was asking Ashim that time. How often you get the thick anterior crust which can mobilize the foot plate? Otherwise, you can easily fracture it. See this? Could you see?
Yes, sir. Yes.
I could easily fracture it. Forceps. So once you are over with the posterior crust safely, you can see the anterior crust. Can you see the anterior crus?
Yes, we can see.
It is not so stout and could be easily fractured. So it is not the anterior crus which is a issue most of the times. It is the posterior crus which is a big issue. See the thick focus gel foam. Could you see the thick focus inferiorly?
We need little more focusing.
Okay. And the rest of the foot plate is good. The rest of the foot plate is superb. How the picture? I hope the picture is good.
The focus is not on the foot plate.
Okay,
Ashim, Satish is going to finish in the next 5 minutes. I hope you are ready with the case.
Yeah, I'm going to be soon through. This is to wipe out the foot plate to improve the visibility. Patla section. Patla. This is 22 gauge section. Let me focus on the foot plate. I hope the focus on the foot plate is good. Little blood over it. Could you see?
Yes, yes.
Can you see the foot plate properly?
Yes, now we can see.
Yes or not?
Yes, we can see, Ashim.
And now my aim is to make a fenestra. And before that, I would like to show my piston. Like Ashish already mentioned, a lot of things about the piston, his trial. Here I am going to use the titanium piston with certain advantages. And what I'm going to measure is the required length of the piston. And for this, for every piston, there's a different, parameters for the length by the company. So it is ideal to use the same manufacturer's measuring length jig for particular piston. See, this is from this particular piston. And this is the measuring jig. Can you see this?
Yes, sir. Yes.
This is the rod which is coming out, and this is the bar which is going to coincide the middle of the thickness of the incus. And how much it comes out, see this, like we'll measure like this, we will find over here. And you can see this is 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, 4.25, 4.5, and this is what coinciding here at 4.75. Where it coincides is the required length of the piston, and why we coincide with the middle of the length of the incus, which cover ups for the thickness of the foot plate, as it automatically includes the 0.25 mm of the piston projecting into the vestibule. So it ensures that you are not going to use an overlong piston. Let me see what required length of the piston for this particular patient is. Oh, this is 4.25. Can you see? Hello?
Yes, sir. Yes, sir.
This is 4.25 is adequate for this particular patient.
म्हणजे तो म्हणाला 1.3 mm is adequate.
Huh?
1 to 2 millimeter.
Most of the time we use 4.25. It depends. Sometimes even we have used 4.75, but depends from patient to patient. One size doesn't fit all. You have to measure for every patient. Lal come kar thoda. Red come. Thoda. Yes. Can you see my laser beam?
Yes, sir.
3 to 4 ली मला वाटतं ते.
I am using the 0.5 mm fenestra size beam for a 0.4 mm piston.
हा right आहे. ते किती
And
कुठपासून
see,
कुठपर्यंत?
for a safe place of the fenestra,
पासून फुटले.
our concern is our piston should not project more than 0.25, more than 0.3 mm into the vestibule to prevent hitting the membranous labyrinth. And from lot many studies, temporal bone studies, it has been proven that the safest place, which is farthest from the, I would say, the membranous labyrinth from laterally, is the central part of the foot plate inferiorly, where I'm going to fenestrate. Number two, this is a single shot, 20-watt shot for fenestra. This single shot means this energy is adequate enough to vaporize the foot thickness of the foot plate, the bone. Laser acts by coagulating the target. See this? Can you see? Ready? Can you see my fenestra?
Yes, beautiful.
Ashish?
Boom, yeah.
Single
Perfect,
shot
sir. Perfect.
without suction.
You should be
Without
called
touching
boom.
anything, without mobilize anything, without
Yeah.
traumatizing anything, and the vestibule is full of perilymph.
So you should be called boom car. It was boom that.
So this is my fenestra. This is 0.5 mm fenestra.
This is 0.5?
Yes, this is 0.5. I have a measuring instrument for the fenestra.
Yes.
Gifted by
ABR.
ABR, sir. See now what we always mention, not to suck over the fenestra. Can you see the fenestra?
Very beautifully seen, yeah.
And now my last job is to place the piston. See, the beauty of laser is to prevent mechanical energy transferring to the foot plate while removing the suprastructure and fenestration. That is the crucial step in the stapes surgery wherein one can easily give a sensorineural hearing loss. If your foot plate is not completely fixed, you can easily give that problem. Even if your foot plate is fixed and your mechanical movement is not up to the mark, you can still mobilize, you can give a floater, and you can get away with the floater by placing the piston over it, whatever. But an accident mobilization will surely give some sort of sensorineural hearing loss. It may be minimum, it depends on how lucky you are.
Dr. Satish, if you see small bony particles around the fenestra,
Yeah,
how
that's
do you
why I
sort
use
them
my
out?
pick to clear. I use my pick gently to clear, and I don't see any more.
Can I ask you one thing? Like in cochlear implant, we can flush with hydrocort solution in the cochleostomy. Can we do the same here?
Not really. Here I don't want anything changing pressures inside the inner ear.
Okay.
Absolutely no touch. See that? The vestibule is full of perilymph. That is something you want. That is a sort of insurance that you are not going to give any problem inside as long as it is full of perilymph. See, my blood will never seep inside as long as perilymph is full. And now the beauty of the piston. Now there are a lot of things are required from an ideal piston. Number one should be biocompatible, and titanium is extremely biocompatible. Of course, Teflon is biocompatible, but if you ask me, typically in terms of comparison, the titanium is having an edge little more biocompatible than Teflon. Number one, extremely slim piston with a weight of exactly same like stapes, less than 3 milligram. That is something required from a piston. Third is not needing the crimping. Crimping is an extremely, I would say, balanced procedure wherein an over crimping and under crimping both can be disaster. Under crimping can leave a loose piston which can keep on hitting at the lower or upper end. If at the upper end, the incus can erode the incus. And this is one of the common reasons which we see at the time of revision stepidotomy, where there is a loose fitting, ill fitting piston eroding the incus. And over tight crimping, over crimping, that mechanical, the mechanical energy used for the over crimping can be a disaster if it dislocates the incudomalleol joint. That is something, a disaster. And the third one is the vascularity. Though, if the way you use the Teflon, the Ashim is going to show next case, the way he crimps with the two hands is something amazing. The vascularity to the long process of the incus comes to some vessels to the core of the length of the long process, particularly emerging out antero-inferiorly, and that area should not be tightly crimped. If that area is tightly crimped, can be a disaster. So the crimping is something which should be avoided, and this piston is specifically,
Anterior, superior, and it's not really narrow, but anteriorly, though.
What, Ashish? Ek minute hold karna.
Yeah, Satish, hi.
Yes, yes. Now I am going to increase the focal length to take my piston inside. Okay?
माझा PIP वर गेला. माझा mic हे on आहे का? नाही, mic is on or no? आणि Ashimला आता दाखवायचं आहे. I'm just.
Your last minute, Ashish.
Yeah. No, Ashim. No, I've just started raising the flap, but I'll wait.
And another thing important, which is important for a piston, is the ease.
Straight holding for the cotton ball. Oh.
See, I am leaving the piston at the lower end. Can you see?
Yes, sir. Yes.
With my upper hand taking on the incus. This is upper open end taking the incus, and there is a middle slot. This is first slot here taking on the incus. This is open clip. The middle is a different slot, which now I have to push my piston to take on the incus tightly. See this? Yes. This is the tight middle slot of the piston, which is taking on the incus like a clip tightly. Like a clip means this clip is holding the incus tightly with the area of contact less than 30% of the circumference of the incus. See this, the gel foam nourishing the chorda all the time. Could you see the piston snugly fit? Hello?
Yes, Satish, yes, absolutely.
Yes.
And it has become one single assembly.
Yes.
There is no play between
the see this lower end. See this lower end. What I'm trying to show now is the bending test. See this?
Yeah, I'm sorry, I forgot to show that. Yeah.
Adequately in. See, it doesn't come out. Hanging, I cannot show. Ashim is going to show on Teflon. But I don't need hanging here because I know I have not used the overlong piston.
Correct.
Got my point?
Yes.
So the length is important. The ease of placement is important. preventing complication by means of using laser is most important. And see how tight assembly. See, there should not be any play between the incus and the piston. Whatever sound energy coming to the incus should be delivered to the vestibule. And if the crimping is not adequate, that resultant play can lead to hearing loss, some sort of hearing loss. See here. See, it's a tight assembly. See that? Absolutely holding tight like a clip. Another important thing, while I was, repeatedly, I am clearing the whole window of whatever the perilymph is by means of using a very, very low power suction around the fenestra. Or while clearing the blood, never ever use the gel form. Can be a disaster. Gel form can suck the perilymph from the vestibule and can lead the vestibule dry. So can be a disaster if you use a gel form open over the open fenestra to wipe off the blood, perilymph or anything. Gel form can suck the perilymph from inside and can lead to a dry labyrinth. Dry labyrinth is the invitation to the problem. See that? Now the final thing is sealing the vestibule. See, this is a direct piston, not using the vein graft. The Ashim is ready with the next case, where he's going to show you that his technique of using the Teflon piston and a vein graft, and his technique of crimping. The superhuman effort of crimping using two hands is something a treat to watch from him. And here, I am not using anything to seal the fenestra, but just a micro drop of blood. I have already told you blood is not going to seep inside as long as the perilymph is filling the vestibule. The blood contains the fibrin, and a small micro drop can create a clot or a fibrin clot over it to prevent problems. So this is a simple micro drop of blood, which I am
side mein.
So Satish, Dr. Satish, what is the size of the fenestra and size of the diameter of the piston?
Yes, great. So I already mentioned, Gauri, this is a 0.5 mm. See this micro drop of blood around the piston at the lower end. That's it.
So 0.5, 0.4.
0.4. So what happens? On either side of the piston is a 0.05 mm free area for the mobility of the piston, where the inner endosteum forms like an annular ligament.
Yeah.
See my blood? There's the oval window, that's the round window. And this micro drop of the blood around the piston on the fenestra in the oval window. That's it. See the chorda pretty intact, nourished, red, and the oval window with a little bit of the blood over it, the complete exposure, and we'll deposit the flap. Now, we could not show the flap raising. Let me tell you last minute about few points about the simple flap raising. See, for the junior colleagues, for the beginners, the simplest way is first make a horizontal incision. This horizontal incision, a few millimeters lateral to the annulus. See, this is the level of the annulus. This is 4 or 5 millimeter lateral to the annular. It should not be too lateral
anterior focus
to make a big flap, which may be cumbersome. It should not be too small, because we need to curate some part of the bone of the medial part of the extraordinary canal. If you use a too short a flap, it may fall short and can lead to a perforation.
No anterior focus, the superior
See,
focus. Superior
that is one. Number two,
so very risky.
After this horizontal incision, our area of interest is posterior superior, not inferior. So we make a release incision inferiorly, vertically down to the level just just above the annulus. So you can raise it completely till the level of the annulus inferiorly, and superiorly you may have to extend it anteriorly in case you need to go to the annular ligament or work far anteriorly to curate more posterior superior area. What you can do, anterior superiorly, you can leave it a curvilinear incision like this, not a vertical horizontal dipping down, so that you can extend it further anteriorly to the level you want. That is the simple philosophy of flap raising. And see the
This is a difficult anterior
both cut ends of the flap coming
difficult to
in
access.
close proximity.
Satish, can you hear me?
Yes, boss, you take over.
Yes, boss,
Thank
that was
you
a
so
beautiful
much.
demonstration. Satish.
Yeah, we are ready.
We are ready to start now. What I wanted to do
So
is
we'll
show
just
the
close
gouge
it.
hammer to remove the posterior superior quadrant.
Yeah, just a minute. Wait, Ashim. Dinesh, can you enlarge his picture?
Yes, I will.
Oh.
Can you bring his
नाही
picture
नाही
to the
नाही
main
YouTube वर
screen?
दिसायला पाहिजे.
Yes, sir. Done.
मग काय फायदा नाही.
Not
Okay,
yet.
so now this is Ashish being shown.
We want Ashim's picture.
Ashim picture. 1 second, sir.
No, this is mine. This is mine.
Yeah,
This
that's
is Ashish
Ashish's
Boomkar.
picture.
Ashim, go to Ashim. My
Yes,
case
yes.
is ready.
Yes,
Okay,
yes,
okay,
this
sir.
one.
Okay. Just give
But
me 1
Enlarge
second.
this
Ashim, not this. Please change to Ashim.
Enlarge Ashim's picture to the entire screen.
Yes.
Yeah. So
Not
I have
yet.
just outlined.
Yes,
Dinesh,
sir.
remove
Yes,
my
sir.
picture.
Okay, sir. You want to your picture or Ashim,
Not
sir?
at all. Only Ashim's.
Only Ashim's. Yeah, now I can put it Ashim, sir.
So
Full
now
screen.
what I'm doing is I'm using
Just
the
a
gouge
minute.
hammer.
Boss,
Yes.
wait for a moment. Yes, now you're on.
Yeah, so I'm using my gouge hammer.
No. Can you tell us what you have done until now?
Okay, up to now, what I've done is I've just raised the flap. And I want to
Transcanal?
take this opportunity to introduce a junior colleague of mine, Dr. Priyank Talati, very, very talented star of tomorrow. And he's helping me with my work, and he has raised a flap. And you can see that there's an adequate flap being raised about 6 millimeters posteriorly and 3 millimeters inferiorly.
Ashim, can I ask one thing?
Yeah.
You are a mini endoral person. For stapes, I know you always go transmeatal.
Yes.
Any indication when you feel like going mini endoral for
No,
stapes
that was a
surgery?
question actually I posed to Ashish, and the answer to that is that if I'm not able to put in a 6.5 millimeter speculum, I will go endorally.
जरा इसका audio
Because
बढ़ाओ,
I
थोड़ा सा
need
audio.
2 hands going inside at any given time.
आणि त्याला विचार
Now what I have done also is
झालं
I've
की
used the
सांग मग
pick
आपण
to
थोडं करूया.
outline the posterior superior overhang removal, and now I'm using the gouge hammer to do that. Can you see?
You created a fracture line already.
I
Yeah.
just created a small fracture line, and then I've just gone through it with the gouge hammer. The way I create it, and this I had discussed earlier with Dr. Vivek, is to use a strong pick to create a fracture line.
How do you control the medial movement, not hitting the vital structure down?
Because you cannot allow it to sort of go deep. You're just using it to crack the bone.
And how do you preserve the chorda?
As you can see, I have used the right angle pick, just as you saw Ashish do it earlier, to remove the mucosal attachments of the chorda.
Amazing, amazing. See the entire overhang coming in one piece.
So the advantage
Go
here
fast.
is that it's much faster.
Yes.
Now you can see that I've got my exposure already.
For everyone, Ashim has designed this micro gauze.
No, actually, it's my father, Dr. Abia Desai, who's done it. Curate.
Yes. And Ashim, is it available with Kalelkar?
I don't know.
I think it is available with Kalelkar now.
Curate.
Am I here? Am I audible? Kalelkar कडे आहे ना gouge and hammer?
Or
Yeah.
Santosh Surgical, which one?
Actually, it was the Hegdes who used to make it, Ashim, right?
Sorry, yeah, Hegde used to make it in the past. Hegde, unfortunately, is no more, but...
Look at those movements.
See how fast this step is done. You can use your curate, you can use your micro drill, whatever way you are
Now you
comfortable
can
with,
see the
used to.
posterior crura footplate junction. See already.
See, now the posterior crura footplate junction is well seen, and the pyramid is just hidden by the chorda, as you can see. The idea is to be able to visualize the entire posterior
The
crust
beauty
of
is
it.
the way you preserve the chorda.
Now you can see that the mucosa on the chorda tympani also is completely preserved.
हट गया बस आ गया
Ashim will be
Long
over
curve,
also.
please.
So Ashim has also not yet touched the chorda.
Slowly move the
He will
chorda
decide where to
anteriorly.
touch and how much to touch.
I'm sorry?
No, you have also not yet touched the chorda. He said,
No, I'm
now you
not.
will.
I'm just
Yeah,
moving
yeah.
it anteriorly very gently.
This is what Ashim is very famous for in us. See the gel foam, how he uses them to even further delicatize his touch.
So I like to use the gel
थोड़ा इतना
foam
audio वाढवा ना.
rather than the cold steel instruments when I am
Yeah. Now
trying
this
to.
bony ledge which is under the chorda, this
Can you
also
see
with the
that bony
gouge and hammer
ledge?
can come out. With the curate it can come out. But yeah.
Curate, micro curate. So in this case, I will use a very small micro curate to take care of it.
Yeah.
You see the super small curate?
Okay. Yes. Yes. Now the entire stapedius is seen. Yeah. Beautiful.
Now we can see the stapedial tendon, and this to me is adequate exposure. In this adequate exposure, I can just about see the facial nerve superiorly. You can see that. You can see the pyramidal process. You can see the stapedial
नाही
tendon,
नाही आपलं पण केलं सध्या नको
and
त्यांना
you can see the
सध्या
foot plate
त्याचं
in
राहू दे
its
मग करूया
entirety.
आपण त्याचं
Super.
Long curve, please. Now the next step is to make sure that our diagnosis is perfect. We will move. See, it's moving. The malleus is moving. The incus is
Can you focus on the
independently
foot plate,
mobile.
please?
Sorry?
Ashim, can you focus on the foot plate?
Yes, it's a blue foot plate.
Yes, we saw it was easy, hopefully. Currently, make only Ashim's screen, please, Dinesh.
Okay,
Get
sir.
my
Okay.
screen. Get my screen out.
Okay, sir. Okay.
Yeah. We will do this from the next case. Yeah. Let Ashim be. Yeah. Okay. Yeah.
Okay, so
Yeah.
you can see the
Ashim.
foot plate. It's an irregular thickening on
Irregular.
the foot plate.
Yes.
Yeah.
Yes.
Can you describe this foot plate? What exactly
Well,
is
anteriorly,
there
as you
finding?
can see, anteriorly is getting thickened and posteriorly is more blue. It's similar to Ashish's foot plate. Ashish had a little more unevenness. So
My
now the
next-
next step is long curve.
Do you mind mopping the foot plate for us to assess its personality?
Ashish, I
sorry?
want to ask you one question. Like you could see an irregular autosclerotic focus on the foot plate in your case.
Yeah.
So you use drill and you've used laser
cleaned it
and
up.
you've made the foot plate blue and then you've made a hole,
Yes.
0.5 and 0.4 piston.
I did a point. Yeah. Okay. Yeah.
Yeah. So do you think removing that autosclerotic focus, whatever it is or whatever is possible,
Yeah.
reduces the chance of refixing of the piston in that hole?
No, not at all. I mean, you need to thin it out because you want your fenestra to be very precise and you want your length measurements to be also very precise. Therefore, you have to flush the footplate flat. It was not for any other reason that it was done.
No, this is the posterior crust.
And the piston lower end is below, deeper to the. Okay,
So
this
now
is the
I'm going to
posterior
remove
crust
the
now.
Posterior crust.
Yeah.
Completely.
You're going to drill away completely?
Yes, because I am planning to use a vein.
Vein, yeah. Okay, when he says completely means right up to the base. From the base
Try to
onwards.
try and flush it as much as you can.
Yes, to the foot plate.
Yes.
Because he does not want any speed breakers or any humps. Yeah. So he goes all the way to the base. I tend to go to the shoulder for my exposure, but Ashim is going right to the base. And this is Skeeter, Ashim?
This is the BNR one.
BNR Skeeter, yeah.
I'm a little bit happier with the BNR than with the Skeeter itself.
If the anatomy permits, what is the ideal area of cutting the crura? Whether you should go to
As
the
flat
base
as possible.
But that is because his Gauri is using the vein. He wants the vein. If we don't use the vein, like I don't, we can, whichever part of the crura is coming in the way as an overhang, we can weaken that. Yeah. So typically for me, it's the shoulder and a little bit more inferior.
Now what I'm trying to do, Ashish, is trying to see if I can see the anterior crus also.
Yes, yes.
My next case, I cannot see it.
Yeah. My next case on the
through
table,
the
I
posterior
can't.
crus, can you see?
Yes, very nicely.
Okay,
See, now you appreciate the thickness of the posterior crus, see?
Number 2. So now the next step is to disarticulate the IS joint. And I'm using the tension provided by the
stapedius.
The chorda, I mean, not the chorda, but I mean the stapedius tendon.
Again, the same thing is his micro puncturing the capsule. You see that little, At a tactile level, this gives you two different sensations. Yeah.
The next step, of course, is to cut the stapedial tendon. You can use a laser to do it. I have access to a CO2 laser. Satish knows that. But for all of those who not have it, it's better to show the traditional techniques. Now I will use a number 5 needle.
Now this is something important from Ashim to learn. How to fracture the the stapedius is not fully cut.
Yeah. Now what I'm using is the number 5 needle to twist the superstructure towards. So the action is a twisting movement. You understand?
Yeah.
Blocked.
This the answer to the difficult anterior crus was
when
here.
You have a thick. Can you see how thick the anterior crus is?
Yes.
Yes, and yet when you do this twisting movement, because force is not transmitted in a lateral dimension, you are very sure of your not disrupting.
Avulsing the
avulsing the foot plate, disrupting the stapediovestibular joint.
So Vivek is making a point that in what we do, we keep the piston already in place and then do the fracture. Then this is not possible.
Of course, but my thing is the vein, na?
Yeah, correct. No. So he's trying to figure out. Yeah.
So now the next step, of course, is the measuring gauge. So,
do you mind mopping the foot plate, Ashim?
In a second.
Yeah. The laser लागणार आहे आपल्याला.
So this is 4.25 millimeters, the second notch.
ची क्लॅरिटी मगाशी सतीश एवढी चांगली नाही दिसत आहे. लॅपटॉप चांगलं
Right. Now I will just mop.
Yeah, Satish works on that.
Can you see? Very
yes,
similar
nice.
to it, Ashish.
Yes, sir. Yes. My next one is even worse. I'll show you.
Now the next step that I would do is to demucosify the foot plate.
Now this step is important because he's going to put the vein, okay?
Yeah,
not
because
for
I need a
the
slightly
direct
larger
piston.
fenestra.
And there's a question which Gauri asked about the bony fragments. If your mucosa is intact, the bony fragments get held there and they don't sink into the vestibule. But of course, if you have demucosified, then the particles can float.
Sir, if there is a
Okay, I've
vertical
removed the
or horizontal
mucosa.
crest, and if you are drilling it, and if there is a partial platinectomy, then what should one do?
Then one should treat it like a large fenestra and put a vein interposition and put the piston.
Yes, sir. So another small question, Roomkar, to you.
Yeah.
As in CSOM, there is foreshortening of the malleus. So malleus gets pushed inside, almost touching the promontory sometimes.
Yeah.
In autosclerosis, in your opinion of so many cases you operated, does it happen that the incus is fixed inside because of the autosclerosis? And once you remove the IS joint or disarticulate, it just goes a little up, like laterally. Does that happen?
No. It is a fibrosis. It's not like an elastic which will suddenly recoil.
Okay.
Yeah. What we and what Satish has been. Okay, let's watch this. Beautiful. Hashim, could you centralize, please?
Yeah, sorry.
Yeah, sorry. Sorry at the wrong time to tell you this. Yeah, okay.
Dry form.
See, it's
in
the
spite of
posterior
the heat,
superior
because it is
overhang
still
removal which
having
makes
a lot
life
of wood.
so easy inside. Hashim is the gel foam man. Yeah, fantastic. Beautiful, Hashim. So Hashim will make with a 0.7 burr a 0.8 millimeter hole. It's the other way around,
No,
right, Hashim?
yeah, or 0.6, and then I slowly enlarge it a little bit more and more because I don't like to go deep inside.
Yeah. They don't like the ball of the burr to sink in.
Yes, you see the
That is the
thickness of
Desai school. Yeah.
the thickness of the burr. Obviously, the diameter of the burr will be 0.3, so you don't want it to go deep inside. So we will use the edge. See, without disrupting what we call the bubble of perilymph. Ekdam barik de suction.
Centralized. Has the vein been harvested yet?
Yes, the vein is harvested. 1 second. I'll just centralize the thing. Suction. Let's unblock it. Now the next step, once I just suck out this extra blood and everything, you can see how I'm doing it from the periphery. Point 0.4 disc. Now I will measure the diameter of the fenestra.
This is also, you got a very nice and wide foot plate. Satish's was a little bit narrow. This is 0.6?
No, this is a 0.4.
0.4, okay. So
he,
see, Gauri, he took out those little fenestra. No, the disc was 0.4.
0.4.
The disc was 0.4. Yeah.
Okay.
This is a 0.4 disc. Now I'm
The
going to
0.6.
measure my piston in its position. 425.
Sorry, Ashim, what did you say?
I saw 425. So I'm going to measure it in position.
In position means now you will keep it there and before you widen.
I will anchor it around the incus and then do my hanging test, bending test to figure out what's happening, whether the length that I measured is precise or not, because sometimes what happens is the angulation is such.
The angulation of the incus.
You
Yeah.
are measuring and where the piston actually goes in, slightly different. I love the way you guys do it, but somehow I find that this
फ्री
way
नहीं
suits
करना
me a
यार,
little bit.
जल्दी मत करो उसको, अभी और है इसमें एब्सेस.
So this is 425. And I use a razor blade.
क्या दे रहे हो उसको?
I'm finding access a little bit difficult in this particular patient because he's an extremely obese individual. One of those you want to choose for bariatric surgery. So here I will use this to give
Are you
compliments to
measuring
my
something? Can you show?
anesthesiologist.
We can't see anything, Ashim.
No,
Are you
nothing to
measuring
show.
something?
1 second. There's nothing to show. I just cut the piston.
He's cut the piston with a regular razor blade. That was the point he was making.
No,
Not the
but
15
any particular length or what?
425, buddy.
4.25 is what we had measured, and he's cut to 4.25, Satish.
So if suppose you need a 4.5, then this piston is waste.
Yeah, because I first measured, no? You may not have
you
seen
first
it,
measured.
I first measured
Okay,
it.
I didn't saw that. Didn't see that.
Yeah. First I measure it. I use my measuring gauge. And another point regarding the measuring gauge is that the measuring jig and the measuring gauge should be from the same company for the same type of piston.
Satish sir.
Yes.
So Dr. Khalid wants to know in how many percentage of cases have you encountered cochlear autosclerosis while operating, and if you notice it before on CT, will you still operate or anything different you will do?
Yes, that's a good question. I already mentioned all those patients having mixed hearing loss, having sensorineural hearing loss as a component, with demonstration of cochlear involvement on CT scan is something that you need to take into consideration certain points for decision making. So, by and large, still stepidotomy is the first choice, followed by use of hearing aid as and when required. Secondly, the use of pharmacotherapy in these cases. Autofloor or
when possible, please centralize, Ashim. Yeah.
Pardon?
No. I'm telling Ashim, when possible,
Yeah.
please centralize. Yeah.
Are you using alendronate now?
Yeah. More often, alendronate is a much better drug in the terms of not needing I would say unlike autofloor, you don't need to take daily. Now the latest one, Zolendronate, has come wherein you can use an injection once in 6 months. Alendronate you need to take on a weekly basis. Autofloor you need to take twice a day. And the autofloor is associated with certain problems which certain patients like they cannot tolerate, gastrointestinal side effects, allergy, and so on. And alendronate is much safer, much effective, and nowadays in this era, I would say is a preferred drug as compared to the autofloor. So in such patients with cochlear autosclerosis, we always give these bicarbonates,
biphosphonates
along with the surgical treatment, and by and large,
Ashish,
unless the cochlea,
you're not centralized, Ashim.
Unless the cochlea is completely destroyed, the lumen is compromised, the first choice is the stepidotomy. Cochlear implant is always a viable option.
Yes, very nicely seen. Beautiful.
It is precisely touching.
Yeah.
The oval window. Can you see that?
Yes. Nice.
Okay, so now I will widen the fenestra.
See the exposure what he has given with full space for the piston rehearsal. That is important.
Now I'm going to first open up my vein. I have already harvested the vein here. And it's very important that the intima faces the surgeon and the adventitia faces the vestibule. Intima is the smoothest surface in the body, while adventitia is the roughest surface in the body. So in order to prevent any adhesions, so on and so forth, it's very important.
Satish, what is the dose for alendronate and zoledronate? Like how many mg and about the schedule? Till how long we need to give?
Yeah. Dosing and the indications as well.
Yes.
See, indications First of all, like I said, for all cochlear involvement, it is always given.
Okay.
Patients with a positive Schwartz sign, with obliterative focus, all these patients are always given.
Okay.
I would also include high frequency sensory neural hearing losses.
Yes, all patients having obviously sensory hearing loss.
Otosclerosis, what I mean.
Yeah, always given, always given. Number two, a lot of people give this in patients who have high risk of otosclerosis when it is running in the families, and those have started showing the signs of otosclerosis development in the early phase for the prevention as well.
One protocol, sorry to interrupt you, Satish, that one protocol.
Our dosage schedule for otosclerosis is weekly.
Okay.
We give almost 35 milligram once a week.
It's a single tablet.
Yes.
Okay.
Satish, I want to add one thing.
Yeah.
That we have created a regimen in which we are all otosclerotic patients. When they have children, we ask them to come in around the age of 18 or 20, irrespective of whether they have hearing loss or not.
Yes, screening.
And what we do is we ask them to do a tympanometry in spite of a normal audiogram.
Okay.
And absence stapedius reflex would be an indication for using sodium fluoride or alendronate measuring. Now you can see I've opened up the vein.
Yeah, this is intima.
This is the intima. So you saw as I cut the vein, I allowed it to open up. Measuring gauge, please.
Okay, can I ask one thing? When you use the vein graft, how much the surrounding you make raw?
Not really, not really. I used to make a lot of rawness around it in the past. But I figured that it's not material. As long as the footplate area is raw, that's enough.
Yeah,
so now I'm measuring. As
So
you
the
can see,
entire
this
footplate.
is just over 4.5 millimeters.
Yeah.
So
And
both
secondly,
ways around 4.
Secondly,
50.
irregularities on the foot plate need to be flushed.
They have to be saucerized. There's no option there.
Flattened, actually, not just saucerized, flattened.
Well, that's what we mean.
See,
so
vein
now you
graft.
can see that this is around a 5 by 5 millimeter.
Yes.
You do not trust your eyes. At least I cannot trust my eyes for all of these things.
Vein graft is something, is a, you can say,
all the gauges.
direct feel good on the table that you are not giving perineum fistula.
See, this is slightly big.
Though if you use a direct piston, if you use a direct piston, if you use a direct piston with not using an overlong piston, the piston not going more than 0.3, 0.4 millimeter in the vestibule, it is always the endosteal membrane forms. It is the long piston which prevents and leading to the perineum fistula. So the vein graft, it would say, is a direct sense of security on the table that you are not giving a perineum fistula. More than that, what I believe, the value of the vein graft. See, when he places the vein graft and the piston over it, the clear picture of the oval window, if the vein invaginates too much with the piston, that means you are using an overlong piston, and this vein graft certainly warns you from using an overlong piston. That is the biggest advantage, I believe, along with that, prevention of the perineum leak.
Yeah, I need to add here that the use of a vein graft is not an indication for you to be careless with the length of the piston drill.
Yes, exactly.
I think PGB also still uses the vein. If he's there, he can make a comment. I think his center also uses the vein graft.
Yeah, sir,
Okay,
please
so
unmute.
now I'm enlarging the fenestra a little bit.
See, this is beauty. Enlarging the open vestibule. That is the beauty, how you use the micro drill over it. Like you are using the drill over the cover slip with a very, very calculated movement without giving any extra undue pressure over it.
You can see when I've used a drill, what has happened is that I have ensured that the bone does not go inside. Can you see that?
Yes.
Then I carefully
Super.
remove it.
Superb. See, this maneuver is so important. Otherwise, these patients can develop BPPV later on.
Not only
These
that,
bone,
but if you leave a lot of bone dust in the open
yes,
oval window, it can reossify your vein graft.
yes, that is one. And secondly, these bone dust particle can settle down in the vestibule, and the connections of the vestibule, if you see, the most dependent connection is the posterior semicircular canal opening.
Can you see
And
there's a
if these
precise
bone
0.8 hole?
particles,
Sorry to interrupt you. That was a 0.8 hole.
yes,
0.4 disc.
Ashim,
Yes, sir.
Yes.
it's a beautiful demonstration.
Thank
I
you,
love
sir.
it.
Thank you, sir. My pranam to you, and you are a great inspiration to all of us.
Thank you.
So, sir, do you still use the vein graft, sir?
Yes, 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 yes.
I know how close
Only
you
thing,
are to your father.
Ashim,
Yes, sir.
we preserve the stapedius tendon as far as possible.
I also do that.
Yeah.
But in this case, I don't know if I'm sorry, I should have mentioned. It was too low.
Yeah.
The attachment was too low, so there was no way I could preserve it.
Yeah. Huh?
Is this medium?
Did you hear me?
Long curved.
Aruna, did you hear me? எண்ணக்காரமா வந்துருச்சு நான் போகணும். சரி.
Satish, my flap is elevated.
Okay, now
the next one, next case.
No, yeah. So once Ashim is, so again I have a superior 1/3 or more of the foot plate, very very thick, and the inferior small thin.
Oh, great!
So I will
and after you, my case is also ready.
Ready, yeah. So we will do that, and once I finish this, I'll keep the third one ready also.
Ashish, I was making a point about BPPV.
Yes.
Some of the patients wherein these bone particles happen to settle down in the vestibule can develop BPPV later on. The reason is very simple. The most dependable connection of the vestibule is the posterior semicircular canal opening.
Yeah.
Wherein these particles can settle down and can lead to BPPV by means of, a posterior semicircular canal settlement.
Yeah.
So that is the reason for it. Number two, in our practice, like Ashim using vein graft in almost all cases with certain contraindication he mentioned, particularly in obliterative cases and all. Our practice is to use a direct piston with a very, very, utmost care about the length of the piston.
Yes.
With certain situation, high risk situation, we use vein graft. Like revision cases, all revision cases almost always use vein graft. Number two, high, I would say, risk cases, like patients who are more demanding in terms of their,
lying,
their profession. Patients who are frequent flyers, divers, patients who have more risk of piston movement in terms of piston going inside the vestibule. We use
Occupation or sport, yeah, whatever.
Yes. So all most demanding cases we use vein graft, and revision cases. Revision, you can't take a chance for a future revision. More the number of revisions, less are the chances of improvement.
That is true.
See the way he has introduced the vein graft inside
by taking the help of a small gel foam ball.
I call
Ashim?
it the gel foam potli.
Potli. I could see it. Amazing. And that makes your intima up all the time. This
You're
you have to
very
ensure,
sure.
because once graph dries up, you cannot see which surface is what. So from the beginning, he put a gel foam over it to make sure which surface is intima.
Jad. Okay. So now what I'm going to do is I'll just spread out this and put
Yes.
me, if you want.
Beyond
Ashish,
the
you can
surface of
begin.
the foot plate, beyond the foot plate.
Now small. Now
You're
you
spreading
can,
it beyond the
small.
foot plate, isn't it?
Yes, it is exactly on the foot plate.
Facial canal.
He took a 5 by 5.
5 by 5, exactly. See how nicely it's sitting?
Yeah. Can you centralize a little bit, please?
Still further. Okay.
Not yet, not yet. Some more. Yes, better.
Satish,
Yes, sir.
Dr. PGV here.
Yes, sir, please.
You post-operatively, you can do a tympanometry
Barik.
and then
Sir.
see whether these patients become dizzy or not. Then you can allow them to fly after a week.
Yes, that is a great point, sir. We do that. If some patient asks, sir's point is valid. Some patient asks for the fitness to fly, whether they can fly post-AP surgery or not.
Yes.
Simply you subject them to tympanometry test. If the patient passes tympanometry means pressure excursion from minus 400 to plus 400 millimeter of mercury.
Yeah.
If the patient passes without vertigo, he is fit to do anything. As simple as that.
Yeah.
Because that
we do
extreme
that as a
pressure of the
routine protocol.
tympanometry, that pressure makes the tympanic membrane completely taut, fixed like a wall. It doesn't mobilize anymore with any increasing pressure. So if the tympanic membrane is completely fixed, no more pressure is transferred to the inner ear. So if the patient passes tympanometry without vertigo, is a simplest way to give him fitness to do anything, to fly or dive or whatever.
Yeah.
Okay, now
But
we
if he
routinely do
fails,
that in our
Satish, what to do?
post-operative protocol.
If he fails, you have to warn him not to indulge in all that. He can develop problem.
We routinely do this in our post-op protocol. At the end of 1 month, every patient is subject to tympanometry.
We can't dare to routinely subject to tympanometry. Why? Unless it is required. In case 1%.
No, but see, most people fly. Most people have an active lifestyle nowadays.
See,
so
for a regular
what is
flyer,
the contraindication to doing that?
I know flying is a word we are using in one of the way, but normally in a routine flying, what we fly in the pressurized aircrafts. It generally doesn't give problem. Yes, it gives problem. We get eustachian tube issues, blockage. We advise wall salvo, all that, but routinely doesn't give problem. But still, even that kind of a pressure change can lead to problems. If you have a short piston, even a slightest sneeze can bring the piston out of the hole, out of the fenestra. So even a slightest pressure can give problem. So the adequate length is another issue which should be addressed. See now, the piston is sitting on the vein.
The piston is, but the piston is in love with the chorda.
Yeah.
It's trying to embrace it.
Around the chorda.
Ashim managing well.
Yeah, this is one of the tricky situation.
Jodi tod di usne. It is going to marry the incus.
Yeah, it's got to divorce the chorda.
Yeah.
And go to the incus.
Fantastic.
Yeah. See, the beauty is the piston sitting on the
much,
vein can never be an overlong piston. That is the beauty.
No, but we already checked it, Satish. We already checked the vein.
Yeah, I know. Still, you can see.
still you can see the appearance of the piston over the vein.
And it is steadfastly refusing to go inside. Now it did. Mandap pe bitha diya.
And now I'm waiting for that movement, that superhuman effort of crimping by 2
No, but
ends.
Satish, he doesn't have to do every time. Yeah, every time you make him do, he can do a regular crimping also.
He will
I
show.
often do the
He
regular
will.
crimping.
Because that is when there is a crowding between malleus and incus. But Ashim, you can show, of course.
Yeah, I will. 5 and 5.
Okay, so I think I'm going to get ready. Ashim, iske
Yeah,
baad
you can
flap
get
down, no?
started actually. Put me in PIP if you like.
Yeah. No,
So
you show the crimping and then we'll go.
particular technique.
Chashma card.
The advantage of this particular technique of crimping is that you are ensuring that the movement is such that you are not pushing the piston inside while you are crimping.
Just light.
At the same time, this movement should not be transferred to the incus to subluxate the inculomalleolar joint. It is a very, very calculative movement. See both the ends with no pressure being transferred to the incus. That's a beauty.
Yeah.
See the loop engulfing the piston.
Well intact.
And
Now
it's
the
a
last
very,
step, of
very
course, is to look for the
calculated
round window
movement.
reflex. In a vein, you always get a round window reflex mostly. See?
कब थे? सर लाइट कमी है. साइड में. चलो लेजर लाओ. 0.8 वर कर लेजर.
Can you see the round window reflex?
Yeah.
Curate.
So that is only possible in a vein interposition. I will just spread it out a little bit more. Okay, thank you very much. Any questions?
Good, Ashim. It's a beautiful demonstration.
Thank you, Professor. It's a great honor coming from you, sir.
What Ashim has shown, this crimping looks so simple, but it
Yeah.
is not so. This can be a hazardous movement in the beginner's hand.
Yeah.
And having done a good stapes surgery, corotomy, fenestration, good piston length, a mal crimping can ruin everything. This is one of the most critical steps which made us using the titanium piston which doesn't require crimping.
Yeah.
That is true. That is true, Satish. I agree with you for that particular point. But
Yeah, superb.
You know what,
Super.
Satish? My problem is that crazy obsession I have with the length. To be able to do all the maneuvers, that is the only reason I have not embraced it wholeheartedly yet.
Ashim, that crazy obsession of the length, the vein graft, and that crimping manure makes it very special. Thank you so
Thank
much.
you, Gauri. Thank you so
Love
much.
to see it again and again.
Thank you, my dear. Thank you so much indeed. Okay, thank you very much. Now
Okay,
the
are we
last
there?
step.
Change.
Just you can put me in PIP, but I will now check for the AML bit. No, it's extremely mobile. The AML does not need to be released. Thank you, everybody. Let's go to Dr. Ashish Bhumkar now.
Ashish Bunker.
Yeah, so I've just elevated the flap. Very little overhang had to be removed in this case, the posterior superior. But hello?
Yeah.
Yeah. Can we see the personality of the foot plate again? The superior half is dense.
Yeah.
The bad news here is that there is no anterior focus. So the focus is actually a superior focus. Between the malleus and incus, you don't see a distinct focus. This runs all along anteriorly, but there is no separate focus out there holding the anterior crura. So this is a little, one has to be very careful when one is doing this case. Two, the foot plate currently is very oblique. So I may actually have to end up giving a head low when I'm making a fenestra. See, it is oblique from superior to inferior. I will go ahead and use the laser to vaporize the mucosa over the posterior crust. Point. So I am.
அம்மா வந்துட்டாங்களா?
உங்களை சாப்பிட சொன்னாங்க அம்மா ஆயில் ரூமுக்கு போயிட்டாங்க.
அம்மா
This further weakens it. I am just to save on time taking care of the mucosa over the foot plate suction. Posterior crura drill. जागा झाला काय तिला सांग. पुढचा पेशंट घ्यायच्या आधी जरा विचारा मला. The posterior crust drilling. See that little shoulder of the posterior crust is coming in the way, so I will take it out, flush it to the thoda sa utla hai. Just careful. Light बरोबर आहे. See, now I can see now it is actually 1/3 and 2/3. 1/3 of it is thick and 2/3 is very thin. Laser, please. You can, I don't know whether you can appreciate the obliqueness of the foot plate. It is almost like a 0.5 millimeter down the posterior edge, the inferior edge. Now I will again even out the 0.7 there. I will even out the foot plate before I do the measurement. Zara drill, please. Then I'll have to give a head low to this patient. See, only the upper edge of the burr is drilling the autosclerotic focus and trying to, and I'm moving. I'm using a 0.7 or 0.6. I keep a watch on how much bone dust is getting generated, and there's a strong tactile relationship which I have with my burr. There's a little mucosa there. I'm not damaging it yet. A little bit more of the thinning, and then I'm ready for the piston length. See, because my assembly is intact, I have a lot of freedom to use my burr because I'm not afraid of floater. Now it's very common for the autosclerotic focus to start oozing a little bit. There are times when the foot plate will be like this. Okay, give me one gel foam. I'll be just a little patient. I won't use the laser yet. I'll just keep a gel foam there for a minute, or not a minute, for 5 seconds. Now I'm ready to get the piston length measurement, because now the area in which I have to make the fenestra and a little beyond that has been flattened out, not the entire foot plate, because this is not an obliterative autosclerosis. So this is the mopping through the foot plate, through the gel foam. Now you see the color of the foot plate in the area that we want to do it. The only thing in this case, we haven't seen the anterior crus, and there is no way to go there. There are code fiber.
બે મિનિટ બેન મારે થોડું હજી એડજસ્ટમેન્ટ છે બેન.
Can you see the autosclerotic focus drilled? See that? Absolutely distinctly you can see. Now
Yes.
the fiber we will pass through the under the, so now this is a
Give me Jeffo.
Sir, Dr. Nitisho from Infal wants to know if by chance malleol joint is dislocated while doing stapes.
Yeah.
Then what to do?
Sorry, let me show you how the fiber is going through a curved suction cannula, and now I will just shoot on the anterior crura with the curved. 1 minute, I will answer that question.
Do you touch the foot plate or you keep a small distance?
No, it's near contact, not full contact.
Okay.
Now, of course, I did not anticipate, and I have not over removed the posterior superior overhang, but see, I'm gone anterior to the incus, and I am suction. The blood didn't allow it to.
Malam.
They patkan. See, this is the advantage why I bought the fiber.
Yeah, it can't go through. Even CO2 cannot go through blood.
Yeah. Okay. Piston length, please.
Leader.
So I felt the anterior crura with the tip of my fiber. Then I came out a little bit, and I have, in whichever way, I have shot it to make it little weaker than what it can be.
एक side worker.
Now the piston length is our
This is your rehearsal.
piston rehearsal. Yes, sir.
Absolutely wonderful.
Suction.
Once you put the piston in, I just want to show our intraoperative audiometry.
Yes. Yeah, you can. I'm just going to be doing this back and forth.
Okay, so just for 1 second, can I have the external camera in my OT on the main screen? Okay. Can you make my external camera big for just 2 minutes?
You are not on the main screen, Dinesh.
So this is the only Ashim's is the only center in the whole world which does intraoperative audiometry, as far as we know.
So this allows me to have a very comfortable indication. Can you put my external camera, please, on main screen, Dinesh?
I think post-op, you can confidently tell the patient about the results, I think, no, sir?
Yeah, it is very comforting for the surgeon and patient both.
Yes, sir.
Can we have this external camera on the main screen for just 1 minute?
Sir, Niteshwar is asking a question. If inguinal-malleolar joint is dislocated before piston insertion, what is the best way to proceed?
Dinesh?
Straight. Yeah, you have to include a malleolar joint. If it is subluxated, you have to just push it back, keep a gel foam. Whether it is salvageable or not, whether the assembly is able to move or not, that is the question, which is the decision of the algorithm. If it is independent, then you have to just push it back into anatomical position, keep a gel foam, and you're better off coming out. Rather than, you would not ever want to do a stepidotomy if your incus is unstable or not in a near anatomical position.
Sir.
Does that answer? There's a vascular mucosa here, so I'm going to before. Acha. Ashim, you're on the main screen.
Okay, I'm on the main screen.
Yeah.
Okay,
Yes,
so you
sir.
can see the preoperative audiogram. This is like 55, 65, 55 dB with a 15 to 20, with a 30 dB sensory neural hearing loss in the high frequencies. The other ear had been done by me about 3 years ago.
Sir.
Again, both ears had a slight high frequency sensory neural hearing loss. And here you can see the intraoperative audiogram. So it's 25, 30, 30, 40. It corresponds well to the bone conduction. So I can rest assured that I'm in a very happy situation here. So the way to do it, I will just show very quickly. You can see the audiogram here. And this is a sterile glove, which I am sterile drape, which I use for my single headphone. And the audiogram is right here. So we have this intraoperative audiometry that allows us to, sometimes when we see that the intraoperative audiometry does not come up enough, subclinical malleus head fixation is often the cause. And when we divide it, my anesthetist, Dr. Sonal, is also an accomplished audiologist there. And she will verify that there's a huge jump of maybe 10 to 15 decibels. So this is one thing, one suggestion that I can give, that people should do intraoperative audiometry. I know that all of us are accomplished surgeons and mostly we have a good result, but this is something that is more reinforcing to all of us. Thank you, Ashish. Over to you again. Thank you.
Yes. So the
Please go
piston,
ahead with your exquisite surgery.
meantime, great. So the secret about me, Ashim and Satish is our anesthetists do more than anesthesia.
I was just going to say that, sir.
Yeah.
I think sir is continuing the tradition of sir's father of doing intraop audiometry.
That's true.
Yes. So we've done the accurate measurement of the piston after we have flattened the foot plate. And now we are going ahead with the fenestra. I use usually a 0.7. So this automatically also becomes my measuring device. So this is 0.7.
Yes, sir.
And I have to see, I have not yet given the head low because I am attempting.
Sir, what would be the RPM, sir, you're using now?
I honestly don't know, but it is. Easy, hai?
See the fact that there is no inward pressure whatsoever. We never
Yes,
get
sir.
tired of emphasizing that aspect.
Yes, sir. Very true.
See, not yet done. It has further thinned it out.
Yeah.
I'm exercising a lot of control because of the obliqueness.
Sir. Sir, there are some requests coming on the questions, like some are asking, can we do without a drill and only with perforator, if you can do a demo? And some are asking with Skeeter also, sir, if it is possible.
See, the Skeeter was what I had used.
Sir.
I mean, I've used the BNR Skeeter.
Sir.
And using a perforator with an irregular foot plate is a no-no as far as I'm concerned.
No,
I
sir.
do not
In
know.
any of
Maybe
the cases.
Satish and Ashish have that expertise, but I don't.
No, sir. They are asking.
Perforate.
You know, perforator has many variables attached to it. The thickness of the
Very true,
push
sir. Very true.
dust, the
Sandeep, if you don't mind, kindly
Sir.
appreciate the thin bone dust that we are generating.
yes.
Yes, sir.
Something. I mean,
Amazing, sir.
the surgical workshop is meant for. Yeah, we have made things eggshell thin, not yet through
Yes,
and
sir.
through.
That
Yeah,
is the
it's just the
way.
footplate is weeping now.
Every
Just
step.
slightly weeping.
Yeah, see now,
Yes,
now
sir.
this precision and this bar of excellence you cannot get with the perforator.
Very true, sir. Very
The
true.
uneven thickness. So the perforator, I think it was good in the evolution of stepidotomy, but I think now the
I
time
think
for
this
that.
is the updated version, which we should follow the updated techniques.
I think it's just about the precision in most fine section. In a multiple of situations, when 80 to 90% of the times you have a thin foot plate, then it doesn't really matter perforator, drill, or a
Very true,
laser.
sir.
But when you have situations like this situation cannot be
Like this,
dealt
it is
with by
not
a
possible, sir. No, it's
perforator.
not possible.
Yeah.
Amazing.
Very important.
The way you drill and monitor, again go back, again check, it's really great.
No. That's not what I meant. I meant this is what one has to. This workshop is meant for this.
Yes, sir. Yes.
And now the final ultra delicate touch.
Yes. Yes, sir. This is all with tactile sensation. You are able to judge
Yes.
it, right, sir?
Tactile
Yes.
and also the visual, because I can see the ball of my.
An
See
amount
that?
of bone dust being generated.
Yes, see that perfectly circular.
Yes, and what should
Yes,
be
sir.
observed is that the bone dust has not gone inside. It is just at
Not
the
gone
surface.
inside. We
Yes,
have not
sir.
invaded
Yes,
the
sir.
fine section. Yeah. Okay, Satish can. The burr ball should not go inside. Yes, Arvind is emphasizing that point which Ashim made.
Very true, sir.
Side knife there. Now I will make sure that my incus long process is well under. We can go a little lower on magnification. When you're handling the piston, you can go a little lower on the magnification. Yeah.
Yeah, because then you'll get a better depth of field.
Yeah, and then you're not honestly. Once you put it there, then you can increase the magnification. See that? Once it is there, you can go a little higher. And then for the final.
Now it's loving your corda now.
My God, I was about to say you started the piston corda affairs.
Yeah.
So this that plot,
put a message
I
saying
may, एक minute, Chris. In cluster suction, the fenestra size may just be a little bit snug. So I may have to widen it, because that autosclerotic focus was there. I was being a little.
You were more conservative, but I think it'll be all right, I think.
Yeah, I will see now how it dips in.
Yeah.
Yeah. Ek number. Now the ease with which it will dip in will tell me whether I'm snug or not. And always manipulate the lower surface of the lobe. No, it went beautifully inside.
Yeah, beautiful.
No problem. It has turned very nicely.
the amount of information coming in this workshop is not less than a book, sir. I think this workshop can be just.
See, again, it's not pushing posteriorly, so the perpendicularity is good. I think it's all good, buddy.
Yes.
Perfect, sir. Perfect. Crimping.
Suction. We'll still look at the lower end and we will do the bending test in honor of my dear friend Ashim. Suction, please.
That was a drop of blood, sir.
That came from the edge of the bone. it ran along the shaft of my suction from the edge of this posterior superior overhang. This, it came from there. Yeah.
Should help
Bending.
sealing.
Fish hook.
You can see a 0.1 millimeter edge.
Edge, yes. You
That
can
is
see a very
exactly what you want to see. That's exactly what you want to see.
That's not, yeah.
Yeah, it's not too much, it's not too little. It's
Not
just
too much, and
as usual, perfect.
And I just do the bending test and nothing else. So it's not coming out. Yeah. Right angle. Satish, ready? No, suction, sorry, suction. Satish, ready with your next case?
Rush me fast. Don't do tempers, please.
Huh? If not, then we can have Sai give the talk if Sai is ready. And Mrs. Khalil, किती वाजले? 1 वाजला? Okay. Ask Satish, जरा phone करून विचार. Now I will disarticulate the joint the way I do it. First puncture. You identify it where it is.
Capsule.
Puncture the joint, and then this is a little thicker right angle suction.
Aparo sir just made a statement sir, saying like this is all about 2 ossicles, 2 nerves, and 2 fenestras.
2 ossicles,
2 fenestra and 2 nerves.
I'm sorry, I don't understand. Which 2
No,
fenestra?
sir wrote a statement saying that the SAP surgery is all about 2 fenestra, 2 nerves, and 2 ossicles.
Okay, the
I mean,
2
he means
windows,
a
what he
round.
means.
Yeah,
2
2
windows.
windows. Yeah. Sir, Sai's message that she's ready.
She's ready, then okay, you can go there like in a minute. Ask Satish whether he is ready.
I'll find out.
Yes, sir.
Japanese have recently found out a biomarker to identify the perilymph.
Biomarker to identify the perilymph?
Yeah,
fish
it's called cochlean tomoprotein.
Cochlean?
Tomoprotein. Cochlean tomoprotein.
Okay.
Yeah, that is very specific for perilymph. You can do ELISA test and then identify whether it is a perilymph leak or something else.
This is after doing an exploration. You have to keep it on the oval window niche.
Yeah. You are right. You are right. See, you can't rely on the beta to transferrin. The reason being, it's more abundantly present in CSF.
Yes, but not in the perilymph.
Yeah. So cochlean tomoprotein is a helpful biomarker.
Okay, great. We didn't know this, sir. Thank you.
Yeah.
We'll read up on this and then discuss with you again.
Thank you. I sent you already.
Yes. Sir, I have not printed them out. I told you, you sent me 50 or 50. So
there's a article by Dajalian from California University, Irvine, regarding the perilymph management, diagnosis and management. In that, he mentions about this.
Okay.
Yeah. And another interesting thing is when they have both auditory and vestibular symptoms pointing out to the perilymph phenomena, perilymph leakage, what you do is you simply draw out 0.5 ml of blood and inject it into the mesotympanum. Okay?
Yeah.
It settles down on the oval and the round windows, which are the critical areas often you get involved in the perilymph phenomena. Okay.
And that is enough if it clots and it can heal?
Yeah, you can see these patients, both vestibular symptoms and auditory symptoms decline in 24 to 48 hours. That means you confirm the diagnosis, then you can do your definitive treatment.
Ah, okay. Okay.
Yeah.
So it's like a temporary seal. It's not a
Yeah.
It's equivalent of a gel foam patch. I mean,
Yeah.
temporarily you have, okay.
Yeah.
Thank you, sir. It was indeed. Sai, if you are ready, you can go ahead and give the talk.
Yeah.
Dinesh, can we have Sai give the talk, please?
Yes, sir, I'll start.
We have started this new thing. We are going to identify these young stars who are very enthusiastic and who reach out, and we get to interact with them. She's really a brilliant mind, very dedicated, totally in love with ENT. So, Sai, please go ahead. She's
Yes,
going
sir.
to speak about the facial nerve in stepidotomy.
Yes,
In
sir.
stapes surgery.
Hi,
Yeah.
all your good luck and well wishes for you.
Thank you, sir.
Okay. Go ahead.
Yes, sir. Just 1 minute. Connecting.
मी कुठे बसू तिकडे का इकडे
A very good afternoon to everyone. And is my slideshow visible?
Only you are visible.
Yes.
Okay.
It's on the screen, sir.
Is that yours? I don't know. Me, Satish, Ashim, and
Yes.
Yeah.
That is.
Okay.
Yes,
Then that's you. Okay.
Yes, sir.
Yeah.
So, good afternoon, everyone. It is a huge honor for me to be a part of this live surgical workshop. I am extremely grateful to Dr. Bhumkar, Dr. Satish Jain, Dr. Ashim sir, Dr. Pachori sir, and the organizers of this workshop for selecting me to speak for this young rising star oration. I'll be speaking on the topic, the facial nerve in stepidotomy. And I would definitely not call this a mini stapes carnival. Because to be able to watch stalwarts like Dr. Bhumkar, Dr. Jain, and Dr. Ashim operate more than 10 stapes surgeries in a day is not a mini event, it is a mega event. So, stepidotomy is one such surgery in ENT which is highly rewarding because it gives instant results, but it is equally challenging as it requires extreme skill and precision, and the complications can often be irreversible. I'll be discussing the following points: the anatomy of the facial nerve and the stapes, the embryological development of the stapes and facial, along with the facial and the stapes anomalies, congenital stapes fixation, the role of HRCT and cone beam CT, intraoperative management of the different anomalous facial nerve, postoperative facial palsy, and revision stapes surgery. So the intratemporal part of the facial nerve is encased within the bony canal, that is the fallopian canal, which is further divided in the labyrinthine part, the first genu, the tympanic part, the second genu, and the vertical facial. The anatomy of this tympanic part of the facial, along with the second genu and the superior part of the vertical facial, is clinically relevant during the stapes surgery. The distance between the oval window and the second genu area is 2 to 3 millimeters, and between the oval window and the tympanic segment of the facial is 1 to 2 millimeters. In this magnified view of the middle ear, we are able to see the tensor tympani tendon, the malleus, the incus, the scrurae of the stapes, the oval window, the stapedius tendon, and here we can see the facial nerve. So there are different cadaveric studies where the dehiscence in the facial nerve is calculated. In some, it is 29.3% cases, but calculating the dehiscence along with the microdehiscences in the fallopian canal, it was assessed to be in up to the 70% of the different of temporal bone dissections that were assessed. The tympanic segment of the facial nerve has maximum dehiscence more in the area of the second genu, which is followed by the vertical facial. The applied importance is that laser cannot be usually used in cases where marked facial nerve dehiscence is found. Moving on to the embryology, the malleus and the incus, they develop from the Meckel's cartilage of the first pharyngeal arch. And the stapes suprastructure, along with a part of the fallopian canal, develop from the Richards cartilage of the second arch. So at 5 to 6 weeks of intrauterine life, the primordium of the stapes appears as a mesenchymal mass, and it folds around the stapedial artery, as it is seen going in this diagram. The failure of formation of this ring leads to a rudimentary or absent crura. The facial nerve creates a groove between this developing stapedial enlarge, and it forms the stapes proper along with the lateral hyal, which later forms the anterior canal of the facial nerve. At 6 weeks, the stapes begins to press on the otic capsule, and at around 12 to 14 weeks, it de-differentiates from the otic capsule. So in cases of congenital fixation of the stapes, it is due to the failure of this taking place. As Satish sir even previously discussed, in cases of oval window atresia, it occurs when the facial nerve is getting anteriorly displaced and interposed between the developing stapes and otic capsule. So this is due to a developmental anomaly occurring at 5th or 6th week of intrauterine life. And it is often and almost always associated with tympanic segment facial nerve anomalies. So in this diagram, I will be showing the different anomalies of the facial nerve. This is a normal course of the tympanic segment. Here we can see a partial prolapse. In this, there is a complete prolapse. This is showing a bifid facial, and this shows an inferiorly displaced facial over the promontory. As per studies, in 6.75% of the cases which are operated for otosclerosis, they show an anomalous course of the facial nerve, of which 78% show partial prolapse, 13% show complete prolapse, 5% show duplicated facial, and in 4% there is a widened nerve. After discussing the facial anomalies, we'll be coming to the anomalies of the stapes. So they are actually, according to literature, there are around 16 different types of stapes anomalies. They can be broadly classified in 4 different gross varieties. So the most common is the stapes footplate fixation, which is in 54% cases. The stapes footplate fixation along with another anomaly in another 15%. No stapes footplate with other anomalies in 10%, and a mobile footplate with other ossicular abnormalities in 19%. This is a diagram showing the normal ossicular chain, and this is the first group where there is a mobile footplate but anomaly in the stapes suprastructure. And in this, the long process of incus is absent and it is replaced by a fibrous band only. The second variety, which is the most common in 55%, where is the congenital stapes footplate fixation. This is the third variety where there is a fixed footplate along with anomalies of the suprastructure, like absent anterior crura, absent incus, absent suprastructure, and here there is an absent obturator foramen along with an absent incus in the fifth diagram. This is the fourth and the last variety where there is an absent footplate along with, in some, there is an absent oval window and other anomalies. As here, there is an underdeveloped crura with no oval window. Here there are fused crurae without an oval window. Here there is an absent stapes and oval window with the incus lying directly over the facial. In this, we can see the incus is in direct contact with the promontory. So it is extremely important to differentiate between otosclerosis and congenital stapes fixation, because an anomalous course of the facial nerve is found in 32% cases of congenital ear. That is when there is external as well as middle ear deformity. And an anomalous facial nerve is found in 11% of the cases with only a congenital stapes fixation. That is when there is no external deformity. So to differentiate between otosclerosis and congenital fixation, we use history, audiological evaluation, and radiological evaluation. A patient of otosclerosis will usually present as a young adult with a progressive hearing loss and a positive family history. A patient with congenital fixation of the foot plate will probably present in childhood with a non-progressive hearing loss, and rarely a family history is positive. Tinnitus is often present in patients with otosclerosis, and it may be absent. It is usually absent in cases of congenital fixation. On audiological evaluation, there is a conductive hearing loss which might be greater at lower frequencies, and sometimes it may even be mixed. Whereas in congenital fixation, it is usually a pure conductive hearing loss of around 45 to 55 decibels. Surgically, there will be increased vascularity which is seen especially anteriorly near the promontory in cases of otosclerosis, which will be absent in congenital fixation. There might be partial or total fixation in otosclerosis, which will be absent in congenital fixation. And the fixation center is usually placed anteriorly in otosclerosis, which is not the case in congenital fixation as it occurs throughout the foot plate. And it is usually possible to differentiate the margin of the foot plate and the annular ligament in case of otosclerosis, which is not the case in congenital fixation. So moving on to the most important, that is the imaging in stapes surgery. So this is actually the CT scan of a patient, 8-year-old boy, who was actually supposed to be posted for this workshop. So Dr. Bhumkar has been kind enough to share the scan with me. And as we can see in the coronal view, as sir discussed in the morning, we can see the ossicles. And this is the stapes, and this is the part of the horizontal facial seen in the coronal cut. And this is seen in the axial cut. So this report suggested a bilateral oval window atresia along with abnormal stapes orientation and a prolapse of both the facial nerves. So this only indicates how important it is to get a CT scan done prior to stapes surgery or any conductive hearing loss. So the indications of HR-CT temporal bone, as discussed previously, are in cases of unilateral conductive hearing loss, division, stepidotomy, pediatric cases, to rule out other causes of conductive hearing loss, to know the finer details of middle ear anatomy, as a widened horizontal fallopian canal and the absence of middle meningeal artery in the stylomastoid foramen can suggest a persistent stapedial artery. According to literature, the sensitivity to detect active otosclerosis is 70 to 84% for the HRCT. The investigation of choice at present is the cone beam CT, as it has 100% sensitivity for detecting active otosclerosis. It has better resolution for measuring even the width and the depth of the stapes foot plate, the facial nerve, the vestibular aqueduct, and the semicircular canal. And these can be very well seen in these images. I found an interesting article where the level of the difficulty of stapes surgery and the facial nerve anatomy was assessed preoperatively. And this was done using a cone beam CT. And radiologically, the assessment of the width of the oval window niche along with the depth of the oval window was done, and the angle between the facial, the tympanic segment of the facial and the promontory was measured. And the inference was that when the oval window width was less than 1.1 millimeters intraoperatively, in 46% of these cases, the facial nerve was found to be obscuring the oval window. And when it was greater than 1.1, only 9% cases had a facial nerve obscuring the oval window. Similarly, when the facio-promontory angle was less than 42, the surgical difficulty was found in a lot of the cases. Whereas when it was greater than 42 degrees, it was quite less.
I think it's a very important point, say. I think radiologically, fantastic.
Yes, sir.
We can know the measurements. Yeah, great. Sorry to interrupt.
Yes, sir. So moving on to the intraoperative management of the anomalous facial nerve in stapes surgery. So as it has been discussed by the surgeons through in the previous live demonstration, but I will be going through. So if the facial nerve is overhanging and impeding the view of the foot plate, And if it is covered with a bone, then the inferior bony edge of the oval window on the promontory can be carefully drilled by using a skeeter. So care must be taken not to injure the annular ligament, and sometimes the piston can even be bent to not touch the facial. In the second case, where the facial is uncovered, the nerve can be gently pushed, and then with a suction tip and the inferior edge of the oval window can be drilled. However, this requires extreme precision and skill by the surgeon. And moving on to the third type, where the facial overlaps the oval window completely and obscures the view, then the hole can be created over the promontory just inferior to the oval window. The next type, that is the post-operative facial nerve palsy. It is of two types. It can be immediate and it can be delayed. Immediate can be due to local infiltration and it usually recovers within a few hours. The other one is due to the trauma to the facial during surgery. So this can be due to curating, drilling, or if the stapes suprastructure is fractured towards the fallopian canal. So in these situations, the patient needs to be counseled and probably re-explored with decompression of the facial nerve. The next type is the post-operative facial palsy of delayed origin. According to a paper by Professor John Chia, it was found in 0.51% of his cases. That is around 7 cases out of 600 cases that he had operated. And it was seen that in all the 7 patients, there was a history of recurrent labial herpes. The patients usually presented between 5 to 16 days after the surgery. And the pathogenesis is due to the reactivation of the herpes simplex virus. On further assessment, the antibody titer was found to be greater than 20 units per ml. And they were treated with antiviral acyclovir and per oral steroids, and all of them recovered. So the following predisposing factors were also found in these cases: if there was a facial nerve dehiscence with a bare or a bulging nerve, chorda tympani stretch, and a granulomatous reaction to the gel foam. Moving on to the last topic that I'll be discussing, that is in cases of revision stapes surgery, there is a very high chance of adhesions and fibrosis. And whether or not the previous surgery reports are available, it is highly advisable to get an HRCT done to look for the condition of the foot plate and to see if there are any anomalies which are present in the facial. I would like to conclude by saying that dehiscence of the tympanic segment of the facial nerve is seen in about 19% of the cases of otosclerosis, where special care should be taken not to cause any damage. Embryologically, as we have seen, the development of stapes and facial go hand in hand. So anomalies of either are often commonly seen together. Congenital fixation of stapes foot plate is the most common congenital anomaly of the stapes. And in these, anomalous facial is found in 6.75% of the cases. Cone beam CT is the investigation of choice. And in majority of facial anomalies, in spite of the anomalies, one is able to negotiate a small piston. And herpes simplex may be a cause of delayed facial palsy. Thank you.
Lovely. Great.
Very nice. Very nice. We're very proud of you, Sai.
Thank you, sir.
Wallace, you're a pro, Sai. You look like you're used to giving talks. Excellent. Excellent.
Thank you, sir.
That last slide is also
I'm
wonderful.
sure Gauri would be very, very proud of you, and it's amazing. And we love that last slide also.
Yes.
There's some people here.
Yes, it's a tribute to all the surgeons who have contributed
Thank you
to
so
making
much.
this surgery.
That's a good creative thing to put them in the stapes arch.
Yes.
Yeah.
Thank you, Sai.
Thank you, sir.
Great, great. Wonderful. Satish, you want to make a comment? Aditya has a small video to show about his reverse round window reflex. Sai,
Super efforts, Dr. Sai Belsare.
Thank you, sir.
Very nice presentation.
Thank you.
Covered almost every aspect of the facial nerve related to stapes.
Yes.
Great hard work.
Thank you, sir.
Congratulations.
Satish, we should be speaking about the 1.1 millimeter width and the 42-degree angle that she spoke. when we
Yes,
speak
sir.
about narrow and a deep niche, I think she's brought in the measurements to what we talk.
Super.
And
Yes, sir.
it's great to see those embryology. I'm going to borrow those slides from you.
Thank you, sir.
Thank you so much. Yeah.
Ashish, whenever you ask, Ashish, I'm ready with the case.
Yes, Satish, we are ready.
Satish, you're ready. Go ahead.
Aditya, you can finish the video in what, 2-3 minutes?
Yes, sir.
Yeah.
So,
Ashish,
yeah.
Yes, sir. So PGV want to say.
there's a wonder drug which is
Uh-huh.
being used for facial palsy,
Which one,
vocal
sir?
cord palsy, called nimodipine.
Nimodipine, yeah.
दिखाना नहीं है.
Sir, can I come in?
Yeah.
Bhumka, sir?
Yes, yes, Aditya,
Yeah,
go ahead.
you're on.
Yeah, first of all, I would like to thank the three maestros of today.
Go to the science.
Yeah, for showing the finesse of steppies surgery. I'll quickly go on to the science now. There already exists a round window reflex for for usually in all our tympanoplasty. That is when you press the malleus, you can see the round window fluid movement. Also in stapes only situation in cholesteatoma, you can see the same, like where there is only a stapes, you can see the round window reflex here. But there does not exist a round window reflex in stapes surgery after successful placement of stapes piston due to dissipation of energy. So Dr. Ashim has discussed, showed us that reflex while after putting a vein graft that is possible, but without a vein graft it is not possible. So what we have done, so if you do a hanging, you can confirm the placement of the stapes piston by doing a hanging test and a bending test. That is a routine. So what we have done is come up with a reverse round window reflex. That is, we put a wet gel foam in the round window. I put a wet gel foam in the round window and just tap it little by ball probe. What you can see here is the movement of the perilymph coming from the oval window area where your piston is fixed. Here. So what does information does that give us? This step is simple yet helpful step in stapes surgery as it confirms the round window reflex after making the fenestra and piston fixation. It might rule out any mucosal band near the round window causing fixation. In revision surgery, it is important to use this step to rule out any perilymph fistula due to long piston, as you will see some fluid coming from the oval window piston side when you put a gel foam onto the round window. It can also be useful to detect a third window formation in a doubtful labyrinthine fistula by cholesteatoma. And in this, what you can do is you can avoid palpating a weak or a partially destroyed stapes. Rather, you can employ this gel foam placed in round window to see whether there is third window formation or a labyrinthine fistula. Probably it could also give a fair idea of outcome of surgery in patients with mixed hearing loss and cochlear otosclerosis, probably. And this can be used as a novel teaching tool to show to our students.
Great.
Very
Wonderful.
nice. Very nice.
Wonderful, Aditya.
Wonderful.
We'll have the other panels. Good, makes sense. I mean, I of course talked to you about this. Therefore, we thought we should present this at this forum and get any views of appreciation or criticism or whatever. But I think it makes sense to use such a simple maneuver to give us some information. Yeah.
Thank you so much.
Very nice. Very nice. Very interesting. Very novel. Very
The
innovative.
PGV was saying about nimodipine.
Yeah.
Yeah.
Yeah, nimodipine is a wonder drug. It has antioxidant property, neuroprotective property, and vasoactive property. They used it in recurrent nerve, vocal cord palsy, facial nerve palsy, then in vestibular schwannoma removal also by Professor Presutti and Macchioni.
Okay.
They found very good result.
Okay. We'll look at this. Yeah.
Yeah.
Satish, are you ready?
Yes, yes.
Yes, please go on. Main screen, Satish Jain. Surgery. Ashim?
Yeah.
I'll go next.
Yeah, are you ready?
No, I will take the patient in.
Okay, my flap will be elevated by the time Satish finishes. So we'll see.
Okay, then you go after Satish, then I'll go later.
Okay. Ashish?
Yeah, Satish, we can see your...
Like utilizing time, again we are ready with raising the flaps. We are done. Hello?
Yeah, Satish, we can see.
It looks like a straightforward situation. Let me show you. Give me the speculum. Are you getting the picture?
Not yet. Yeah, now we can. Satish,
Yes, sir.
Satish, have you come across any facial nerve schwannoma?
Facial nerve schwannoma during exploration? Not really.
Okay.
And for that matter, for last couple of years, we are not facing any surprises once we have included CT scan routinely in our protocol.
Okay.
So no more surprises now. Our CT tells us everything what we are going to come across.
Yeah.
But that is the biggest advantage of what I believe with the CT scan. No more surprises. So this case, can you see the picture?
Beautiful.
It's a straightforward situation. See the exposure or ideal exposure.
Yeah.
See this, the incus has started broadening. The fallopian canal below, this is the tendon of the stapedius. The foot plate, absolutely fixed. Blue foot plate, a small gel form. How's the picture there, sir?
Beautiful.
So now using the laser is the most straightforward situation for me in this particular case.
Yeah.
So let me show you again the utility of the laser. And this CO2 laser, as I have already enumerated the advantages. See, this gel form is to keep the chorda in place.
Yeah.
Not to allow the chorda to fall in our, surgical field.
Use single shot stepidotomy.
Yes, sir. Now, this laser is to vaporize the tendon, and before that, I will show you the incudostapedial joint. See this. See the level of the joint. Can you see?
Yeah.
Here. This another joint knife I have pierced, and I am through. Can you see?
Yes.
It is done. And now my laser magic starts. I call it like a video game in these straightforward situations. Suction. Ready? With the less power, I'm first going to vaporize my tendon. Can you see?
Yeah.
Yeah, tendon completely vaporized. And see the posterior crus, unlike the previous patient, it is not that much thick. Can you see? The last patient's anatomy and this patient is altogether different. What I'm going to use is a small piece of gel foam. Here the facial canal is not prominent, the entire oval window is visualized. I'm leaving a small gel foam to prevent misfiring at the oval window. Can you see that?
Yeah.
बढ़ा दिया? On. And now, see my posterior crus is hollowed out. Can you see?
Yeah.
It is already hollowed out, not completely vaporized. It has already made it thin.
Yes.
And if I check this,
yeah.
See this?
Yeah. See, so most of the Sandeep, most of the cases are like this. And
see the movement of the foot plate, the anterior crust is still there. See the mobility?
Yeah.
This is something I don't want.
Yes. No,
Even
but
the
I mean, I was talking about the thin foot plate. Now, in such a thin foot plate, whether you use a perforator or a drill or a laser does not really matter.
I never expected this mobilization with the anterior crust. See the posterior crust mobilized.
Yes.
I was asking Ashim about the incidents where the anterior crust can give problem, and see the example. Can you see?
Yes, yes, we saw it.
Straightforward example of patla de. Of the anterior crust causing problem. It's not about the thickness of the anterior crust. The anterior crust causing problems. And see, since I have a laser, let me handle it with the laser now. See my foot plate little mobilized. You can say a floater. Can you see?
Yeah. Yeah.
Now with floater, you have two options. Either to put a fascia and put a piston over it, or to make a fenestra with the laser. Patla.
This is going to be the case of the event. On a mobile foot plate, he's going to make a fenestra, which you can do only with a laser.
Yes,
That's the only way.
And
That's the
he
only
will
way.
probably laserize some part of the head of the stapes so that.
Yes, yes, that is what I am trying to now.
Yeah.
That I'll have to do now. Otherwise, I cannot.
If you have a crurotomy scissor, you can decapitate and just create a gap.
It is already mobilized.
Yeah.
I cannot take a chance. But with this floater, the only way to deal now to fenestrate is the laser.
Yeah.
That is for sure. Gel form. Gel form. So this is the classical example how floater can take place. And this was so unexpected after vaporizing the posterior crust. See that?
Yeah.
Dr. Satish,
Yes.
if suppose one don't have a laser in hand,
Yes. In
what
such
then
situation,
he should do?
in such situation, just put a graft over it and put a piston.
Okay.
Or you can do a pothole on the promontory side.
It should not even be that much.
DGV is telling you the other technique which they used to do, because see, that generation was used to a platinectomy.
Yeah.
They were used to remove the whole foot plate anyway as a part of the technique, so they are not scared. But for us to think to remove the entire foot plate, putting a right angle hook, I've only seen it. Yeah. See, now what Satish is doing is he is actually vaporizing the head of the stapes.
Yeah.
So that there is a gap. See there. Oh, fantastic, Satish.
No, I just asked a situation I've seen. If one don't have the laser and in such a situation, what to do? One should be prepared,
Oh, wow. No, thoda or.
Now it is
Okay,
far off.
let us take an example if we do not have a laser.
Yes,
Yeah.
yes,
There are
Satish. I saw it. Fabulous. This is going to disintegrate. That head of the stapes will die out. Be a gap. Yeah.
Now the issue is to make a fenestra in this.
Yeah.
Let me check first the length, required length of the piston. Now the only way to make the fenestra in such situation is laser.
Yeah.
Oh, it is bigger, 4.5.
Had the posterior crust been intact, could you have done the stamp, Satish, which you told me about?
Stamp is a different procedure, let me tell you. I will use a 4.25. Get ready.
அந்த புள்ள வந்து சொல்லிச்சு நீ சாப்பிட சொன்னேன்னு.
Ashish.
Yeah, Satish, we are watching.
In such a situation when the foot plate gets mobilized, The only way to carry out the procedure further, safer or goal pura nahi aata.
Like I took 2 lengths of your round knife, 3 mm,
God's
3 mm.
sake, don't try to use a
Then
drill
more.
or a perforator on this. That is
Never,
for sure.
never, never.
What
That will ruin.
Yeah.
Yeah. And now, see the magic of the laser.
Centralize, Satish. Centralize, please.
Yeah, just a minute.
Don't shoot yet. Yeah.
Horrible.
Fine.
Then what? Like,
Yes.
should
Very
be
nice.
more lateral.
See in the center inferior part. Can you see?
Team, I asked, suppose if you don't have the laser.
Yeah. Let him finish
Yes,
this,
yes.
Prakash. Then he will
Okay.
answer.
Yeah,
This is
please.
important. Oh, boom. Okay.
Yeah, boom, boom.
See, in spite of a floater,
Yes.
I could still make the finestra. Can you see?
Yes.
Yes,
Very nice.
beautiful.
Give me 4.25. And that is the only way to make a finestra in a floater situation.
Yeah.
Great.
Very unexpected, even after vaporizing the posterior crust, the anterior crust.
This surgery is sponsored by Luminous.
Close to the annulus.
So, see, with the Luminous has come out with a fiber guide laser. In this situation, if you want to, you can vaporize the posterior anterior crust with a fiber laser.
Yes.
4.25. And now my job is so simple. I am going to place my 4.25 titanium. Again, I told you it is like a video game.
Now, video game. Ashim, your case flap is raised. You ready?
2 minutes.
Yes. Okay. Because
No,
then
if you
I'm
want to go
also
ahead,
giving-
you can start. No issues.
No. I'm giving sedation now. So you start, please.
If you have a little talk or something, go ahead.
No, we have a next case ready.
I don't have a. Your third case is ready, Satish?
Yes.
Oh, okay. But Ashim,
Okay,
please.
then Satish can go ahead. No issues.
No, you speed up. No.
See my piston?
Yeah.
I have to be very, very careful not to mobilize the foot plate.
See this. Ashim has started piston corda relationship.
No.
The pistons are getting attracted to the corda.
Not corda this time, but it is falling. It slipped from my target,
तेरा क्रिकेट मैच उधर शुरू हो गया लगता है मेरे को.
Not yet.
But your mind is already gone there. Is this reverse stepidotomy? Ulta piston?
No, I have to properly. It slipped actually.
Yeah, I'm just joking. Yeah.
Madam, tilt the head up.
We can, if Santosh, Mrs. Kalilkar na bolu शकला तर after Satish, between Satish and Ashim, we can, It is just that, we thought, me, Satish and Ashim and the others, that Kalilkar has actually played a big role. They were the Karl stores of India. And they supported a lot, I think, to all my teacher, Tapan sir, and others. I have seen them sitting in that shop on Princess Street, looking at every instrument and selecting.
Ashish.
Yeah, I'm watching. Yeah.
See at the lower end.
Yes, very
See,
nice.
it's so simple to use for the beginner.
Yeah.
That's it.
Tuck. Yeah.
Just slide in.
See this, the lower end in the fenestra.
Yeah.
Foot plate absolutely intact.
Yeah.
No blood.
It's beautiful, Satish.
And on a floater. All this is all on a floater.
That is the beauty of it all.
Floater, the only way to make a fenestra on a floater is the laser.
He's dancing on a floater, no?
Dr. Santosh wants to know the depth of the laser used. The depth.
Depth 2. 2 depth, 20 watts. So depth is basically the energy what you use. And what I'm going to do simply on this floater.
Put some fat?
No way.
Blood drop. Okay.
That's it.
That's it. Okay.
My God, what an unexpected floater. For this only, this laser is important, but we consider anterior crest to be fragile and not giving problem. But sometimes.
Dr. Sharmila from Mustard wants to know whether vein graft will be useful in these cases of floater.
Yeah. In case you're not having laser, your foot plate is mobilized, you can place a vein graft and put a piston over it.
Okay.
It may get refixed later on, but may not. But until then, the patient can hear well.
The PGV sir was telling that you can extract the entire foot plate, then put a vein and then put. That is what he was saying. And to be able to extract the foot plate, you have to make a hole inferiorly.
Yeah.
And then insert a 0.2 millimeter hook, sir.
Yeah.
So what are the
0.
chances of SN loss in fishing out the foot plate and all that?
No, what you need to do is you have to go behind the foot plate and towards the promontory, and then make a what they call a pothole in those days.
Yeah.
And then extract it. Of course, with a laser, obviously that would be preempted. But I have a small algorithm for the floating foot plate. See, the floating foot plate, it's important whether it's floating with the superstructure or without the superstructure. If it is floating, if you don't have access to a laser, mind you, and it's floating with the superstructure, it could be either subluxated or dislocated inside. If it is dislocated slightly also inside, you have no option but to extract the entire foot plate, as Professor Vishwanathan sir recommends. However, if you have already removed the superstructure and you have a floating foot plate, then as Satish said, you can put a vein and a piston on top of it.
Sir, do you have any videos of this foot plate extraction, sir? Vishwanathan, sir? If you have any, then we could request Aruna or Anjana to put them on YouTube, because we in our generation also have really not seen it.
Okay.
The way to take it
It
out.
would be very nice to see it.
Yeah.
You know?
Okay. Okay.
Okay. So I think, Satish, can I go to Mrs. Kalilkar?
Yes, just a minute. One question to Ashim. Ashim.
Yes, sir.
You two having laser, what could have been your
how would you have proceeded?
This situation?
Exactly as you did, buddy. Exactly as you did. I mean, I don't think there's any other way. If you have the laser, there's no other way to proceed.
So just keep the foot plate, let it in place, make the fenestra with the laser and put a piston.
Absolutely, absolutely. The only thing is that in all cases, I generally, whenever I use a laser, I use the laser for a complete evaporation of the posterior crust.
But he did that here, Ashim. It was the anterior crust.
No. I know. I'm just telling you. I will tell you why I'm juxtaposing this for what Robert used to do. Robert generally makes it thin.
Thank you.
Okay, thank you.
Superb job, Satish.
Yes, I'm here.
Yeah. So we remember you as the brand as we grew up. Satish is still much younger than me, and Ashim is also younger. But I remember the times when we used to come to Kalilkar at Princess Street with Tepan sir. I used to be there for 2 hours and 3 hours looking at every instrument. And we feel a sense of gratitude towards Kalilkar at that time. It was extremely difficult to, the world was a very different place. And is she there?
Yes, I'm there.
Yeah,
I'm
sorry,
listening to you.
Yeah,
Oh,
okay.
I'm sorry.
And I don't think you all played a very important, at a national level, played a very important part in the development of the entire ENT, specifically otology, where you all took painstakingly the efforts to create all the instruments that were impossible for us to buy from abroad at that time. So we had to sort of say a big thank you to you for all that you have done. India now is at par or probably an edge above the rest of the world, especially in the ENT of what we know of. And we owe a lot for you to have done it, supported it in the way you all did. So thank you very much. If there's something that you would like to share about the past or the future, you please say whatever you wish to say.
Thank you. Let me begin by wishing all of you.
Yeah, thanks. We can see you. Yeah.
I would like to begin by wishing all of you a very good afternoon. And also by thanking Dr. Bhumkar, Dr. Jain, Dr. Desai for inviting me to be a part of this very, very august event. And I'm deeply, deeply touched by the recognition and the appreciation that you have bestowed on Kalilkar Surgicals. I can say I'm totally overwhelmed. My late father-in-law, Mr. Pratap Kalilkar, actually started this company in 1950 with the aim of providing good quality instruments at reasonable prices. My late husband, Mr. Yashwant Kalilkar, with whom I think you people have dealt with.
Yes, very much.
More with him than my father-in-law.
Yeah.
He carried on with the same vision. He took particular interest in ENT and laparoscopy surgery instruments. In fact, his passion for ENT was such that even in his last few days, he continued to ideate and to make, on developing better and newer instruments. That was the kind of passion he had. And along with my team, I promised to continue their vision, both the Kalilkar men's vision. Secondly, once again, I, along with my family and Kalilkar surgical team, would like to thank all of you for honoring their legacy. And finally, I thank all of you for your time and wish you a fruitful 2021.
To you too. Let us interact just like we are now interacting with the radiologists, with the pathology people. I think it's time that the instrument engineers start coming into the ORs and you can take the lead and have them interact with us. And it's time for India to come out with the innovations, and with your support we'll be able to do that and show to the world that we are probably better than the rest.
Can I just take a minute just for all of you to know? I think you should feel proud of being an Indian. You are, and you should feel more proud. I had participated twice in the American Congress.
Yeah.
Believe me, 10 suitcases filled with instruments, 5 of us from Kalilkar Surgical had taken.
Yeah.
When we returned, one case inside the other, we had to get back. So much so that the people at the counter, when we came back to India, in the US, I'm telling you, they asked, "Oh, you're traveling back very light." That was the kind. It was like a conference in India.
India, okay. Everything got sold off.
There were a couple of Dr. Rahul Agarwal, Satish Jain. He said, "I feel so proud of being an Indian." He told me there. He had attended the meet.
Yeah.
Really, it was a very nice gesture, Ashish, to call them.
Yeah.
And yeah, so many years I have been feeling that they are there. So any instrument we want, we can vouch on Kalilkar's to and very standard instruments.
Thank
Even
you
the
so much.
Curate still they work like magic. Excellent. But please, please send in your engineers to big centers like Satish.
Yes,
I think
I would
Aditya
echo
there
that.
has got many ideas for the piston measuring. He's got an engineering mind. There are many people who are inclined towards instrumentation and product design. We can collaborate and probably come out with our own. Yeah.
Sure.
Thank you very much once
Thank
again.
you.
And we really remain indebted to you. Thank you.
Me too.
Thank you. Thank you. Over to you, Ashim, if you are ready to be on show. That's a nice Ganpati
Once
at the
again,
back.
I will reiterate what you said about
Thank
Kalilkar
you.
Surgical. It was a pleasure and privilege to always collaborate with your whole family, madam.
Yes.
And you have played in no small way a role in the development of ENT surgeons by making available good quality instruments at good quality prices. So we are all very grateful to you.
May I just know who spoke? I can't see this. I can't see you on the screen. Is it Dr. Jain?
I'm Dr. Ashim Desai.
Ashim Desai. Oh, yeah.
Okay, so am I on screen?
No, I still can't see you, but I can hear you. Go on, please.
Okay. No, well, I'm operating actually. You can probably see my instruments.
Okay. That's fine.
No, but there are many things, many instruments, many things that we can collaborate with.
Sure. It would be our pleasure to collaborate with you.
Ashish?
Yeah, Ashim, go ahead.
Am I on screen?
Not yet.
Sir, we can see you. Just come in front of a camera, sir. Yeah, just come.
Ashim sir, screen gas.
Give me the microscope picture then.
No, sir, we can, yeah, now we can see the microscope picture, sir.
Yes, Ashim, you're on, buddy.
Sir, there is some glare coming, sir, the image.
Male or female? Ashim, audio is not audible, at least to us. I don't know the others.
Yes, sir. No. Screen also, there's a lot of glare, sir, in the background.
Can you hear Ashim?
Ashim is in mute.
Probably Asim is not able to hear us also.
Just 1 second, sir.
Ashim, phone karna.
Yeah, I'm just coordinating, sir. 1 second.
Yeah.
Sorry, please bear with us. There's something at Ashim's end. He's drilling the footplate. Suction, please. चला इथे लक्ष द्या. संतोष.
No. 5.
मला वाटतं त्या स्नेहाला सुगरला सांग स्नेहाला फोन करायला. तिची रेडिओलॉजीचं टॉकचं तयारी करायला सांग.
I think we are lost to Asim's voice, no?
We're trying to call him on the phone.
Yeah.
Okay.
Because he might not be aware the way he is doing everything. Yeah.
4798200.
Suction.
98200 47256. 47256.
त्याचं सगळ्याचं अँटीरियर क्रुराचं हे चांगलं आहे.
हॅलो.
Hello. Yes, Anna.
Dr. Sonal.
But you're not able to hear his voice. But we are not able to hear him at all. So you told. Anesthetist.
Ashish sir.
म्हणजे तीच ना.
Hello.
Sir, they are changing mic once again, huh?
Naveen.
Hello.
Yes, sir.
Right. Am I audible?
Yes, sir. Yes.
Yes, sir, but very slow, sir. Just little loud.
Hello, am I audible?
Yes, sir. Yes, sir. Yes, sir.
Oh,
Yes.
good, good.
Yes,
So anyway,
sir.
were you able to see what I was doing? I believe that I was off air for some time. I have disarticulated the stapes and removed the superstructure. And I also was in the process of demucosalizing the foot plate. Am I visible and audible?
Yes, sir.
Yes, sir.
Okay. Okay.
Asim, your voice is very low. If you can bring the
Yeah, I can do that.
closer was.
Microphone.
Yeah, because now it is better. It was very low.
Okay, is that better now?
Inside,
Yeah, much better.
Okay. Okay, is that better?
Yes, yes.
Okay, wonderful. So now you can see that our little challenge here is that it's a peripheral fixation of the foot plate. I'm just demucosalizing the foot plate. And you can see there's a large central band of ossification out there, which needs to be...
Dr. Asim, can you explain for the audience till now what you have done?
Yes,
because
sir.
that time your audio was...
Okay, so what was happening is that I checked the fixation of the stapes. The stapes was fixed.
Audio
the malleus and incus are mobile. I have already drilled through the posterior crust first. First step is to drill through the posterior crust. Then I disarticulated the superstructure.
Yeah.
And you saw the twisting movement with which I disarticulated to make sure that there is no low lateral forces acting on the foot plate.
Yeah.
And that is particularly important because of this band out here that you can see here. Give me a measuring gauge, please.
Yeah.
It's a relatively blue foot plate with a peripheral fixation and a central band. So I will perform measuring gauge, please. A similar procedure to what I did last time. Mostly I will need a vein interposition here.
Yeah.
Now, this being a young lady, typically she will undergo marriage, childbirth, so on and so forth. I would always, in such cases, prefer to do a vein interposition.
Yes.
So now the length is a little bit shorter than the previous one. This is at around 4 millimeters. Can you see? So I will now proceed to thin out the foot plate. The reason I've kept this little gel foam here is to keep my chorda moist.
Yeah.
I'm a little bit concerned about drying it out. In this case, the facial nerve, although is dehiscent, is not coming in our field at all. So we have a complete free run of the foot plate.
Yeah.
आज करेंगे अभी ये तीसरा है ना और फिर एक चौथा 4 करिए हो जाएगा
Ashim sir, you are using the skitter.
Sorry?
Sir, you are using skitter.
Yes. Even suppose you were wanting to use a laser, you would still need to use a skitter to thin out this wooden the bony band.
Yes.
So the one you're using is a Benner one, no, sir?
This is a BNR one, yes. It's much better than the Medtronics one. At least in my hands, I'm happier. It vibrates less. Much smaller. I will take this opportunity to thank my team.
Can we go half screens now? One audio, but half screens.
Yeah, why
Satish,
not?
Okay, sir. I will do.
Yeah, Dinesh, I think let's do that. Satish is also doing something there. I can see.
Okay, sir.
Okay. long coat.
Sir, again, the last time, sir, many people are asking, they are confused whether to use Teflon piston or titanium. Kindly give one message to the people what to use.
Whatever you
yeah,
like.
ourselves are using two different types. So Thane Mumbai is Teflon, Jaipur is titanium. But I think as a general, Teflon is fine. It's very easily
Teflon
available.
is absolutely fine. I've been using it for 25 years without difficulty. My father before me was using it for another 40 years before without difficulty. Dr. PGV also has been using it. It's a good piston.
So the answer is both are good, but if there's one
from the titanium, mind you, I'm not taking away the merit of the titanium, but the answer is that both are good.
But if they want one answer with Satish's permission, we'll say Teflon.
Because that's what we do. We walk the talk.
But Ashish, there are two groups of people like Dr. Robert Vincent and all. They say never use anything other than the titanium.
No, that they have not used.
Teflon,
but
sir.
if you ask,
So is there any clear-cut criteria which says you have to use Teflon? You have to use the titanium.
No.
I don't think.
No,
there are no such clear-cut criteria.
Right.
The only clear-cut criteria is when you want from malleus to footplate, that time titanium only.
Yeah.
I think all will be agreeable on that one.
Yes.
Like the video is a little bit foggy. Is it due to the lens or?
Is it foggy?
Kind of, a bit.
I don't know because I just cleaned the lens this morning. The first case was quite okay, I think.
Okay.
Let me see.
You?
See, this is a very vascular focus, as you can see. Long coat.
Yeah,
So
now
I'm
it is better.
continuously drying it up completely before I tackle it.
Yeah.
So I'm going to take my time, make sure that the oozing completely stops before I open the vestibule.
Yes.
So initially I used adrenaline gel foam. As the footplate got thinner and thinner, I shifted over to dry gel foam. No, it's still going on.
Adrenaline gel foam earlier.
Sorry, Ashish?
No, you used adrenaline in the gel foam earlier.
Initially, yes, before I started drilling. I always put a small adrenaline gel foam on the promontorium also. See, now we have a relatively bloodless field.
Pure adrenaline.
Drill. So now I will go in for the penetration of into the vestibule.
Yeah. Dinesh, if we can get Satish half, and then when Ashim finishes, me on the other half. We are trying to now speed up our.
In spite of demucosalization, Ashish, can you see?
Yes.
There's a lot of oozing.
Yeah.
In the junior otosclerotics, I have seen this as an anecdotal situation. I don't know what is your experience.
As a what?
When the patient gets early otosclerosis.
Yes.
I've always found the footplate to be very vascular.
Yes.
The footplate itself, mind you, I'm not talking about the mucosa.
Yeah. There's oozing from the bone of the footplate.
Yeah, the Haversian system seems to ooze in such cases.
And so many people wants to know, many people have been asking the choice between hearing aid and surgery. Can you throw some light?
Between what?
Hearing aid and the stapes surgery. Like what to do and when to give hearing aid and regarding the choice the patient makes.
Or if I put it in other way, can you tell me what are the contraindications, absolute contraindications of stapes surgery? Because anytime the hearing aid will not be a choice if surgery is giving a good result.
My absolute contraindication is
Yes.
It's only hearing ear.
Yes.
Number 2. Now, of course, it become a relative contraindication, in which case if the patient is willing for a cochlear implantation, I will first do the implantation in the dead ear and then consider operating on the better hearing ear.
Right.
Hello. Hello.
Hello. Yes, sir.
Yes, sir.
Yes, sir. Just adding on to what Ashim has made the comment about the only hearing ear. So, like what he said is a relative contraindication, means such ears can be operated for stapes surgery now. See, the results of stapes surgery are excellent, and 98 to 99% patient do well in good hands. So you should take a chance for stapes surgery, because still now, in any worst to worst situation, if it fails, cochlear implant is there to rescue.
Yes.
So in this era, there is no absolute contraindication.
Satish,
You have to understand the contraindication.
From the medical legal viewpoint.
Yeah, you have to give all the options to the patient.
Yeah, no, but from the medical legal viewpoint, no, not this. Okay, straight. I know.
See, you have to discuss all the pros and cons with the patient. Then only you have to take this call.
One thing is, I want to add that option of hearing aid should be offered to each and every patient.
Yes, sir. Yes.
There is no exception to that rule.
Yes.
If I put it plainly,
Those
Dr.
patients
Satish
who
and
do
Asim,
well with the hearing aid will do well with the surgery as well.
yeah, the patient should be, offered all the things, and they should be demanding surgery rather than we offering them.
Absolutely.
Yes.
Absolutely. I'm completely in sync with that.
Yeah.
Yeah. It is a complete decision with the patient.
It is called as the art of seduction.
Offering all the options. Number 2, another relative contraindication to me.
Yeah.
In patients wherein we find obliterative otosclerosis,
Role of imaging comes in now here.
Yes.
Suboptimal results after operating on that patient. It is high likely to have the obliterative focus on the opposite side as well.
Yes.
In such patients, wherein one side giving suboptimal results, I would tend to defer and opt for the hearing aid, rather offering patient the surgery on the other side. Though on one side, if you have an excellent result,
Permit me to differ with you on this one.
I know you are operating on an obliterative focus on the both sides.
Yeah. No,
That's why I mentioned with obliterative focus operated one side with suboptimal results, I would avoid to operate on the other side.
Okay, if I had done it with suboptimal results, I would operate on the other side. If it was operated elsewhere, I would continue with it. But I will tell you one thing, Satish. In the case of Van der Hoef, the Klein syndrome, osteogenesis imperfecta, the chance of SN loss is way higher.
See, that pathology is different, and you can't say that very high, because we are treating only conductive part. Number 1, our procedure of stepedotomy remains same, whether it is syndrome or not. In that situation, the crura becomes much weaker. We have to be much careful. The foot plate and crura are more brittle. You tend to give complication more, so you have to stay more careful. It doesn't mean that it is going to give sensory neural loss in a high percentage of cases.
Not going to be more careful. In my hands, high frequency sensory neural loss has been more common in Van der Hoef, the Klein syndrome than in the regular obliterative otosclerosis. And that is something that you have to discuss with the patient. 0.4 piston.
See, why I am saying this fact, obliterative focus need to be completely drilled, flushing the foot plate, and then you make a fenestra and operate like a regular one. Out of 100 cases of obliterative focus, if you take long-term results as compared to the normal blue foot plate are relatively poor. Relatively poor. It doesn't mean that it is 100% poor. So,
No, but it's a matter of discussion with the patient, my friend.
Such patients, if you have operated and not getting expected results, because one side results findings correlate very well with the second side, opposite side. Very likely that you are going to find an obliterative focus on the opposite side. You can confirm with the CT scan.
For sure.
In that situation, the call is very, very difficult because giving patient a sensorineural hearing loss on the opposite side is not acceptable. You can start autofloor, biphosphonates, whatever, to improve the situation. Take the patient in confidence. You can give a hearing aid meantime. And if it is progressive, then the call is different. If it is not progressive and confident enough to operate, you can still take a call. So it's a very, very difficult decision in such patient because the results are not as good as a blue foot plate. That's the only situation. Experience matters.
Dr. Satish, one more thing I would like to have your opinion. Say the operated ear and the non-operated ear, if the difference between the hearing loss of the 2 years, if it is less than 25 dB, probably patients will not appreciate. What is your comment?
Yeah. See, there are regions, ways to choose the ear to operate.
Yeah.
And that's why we always wait for a hearing, this airborne gap to be at least 25 to 30 decibel to take the call before we take the call for stapes surgery. The reason is not only what a patient appreciates, the reason, the safety concern also, let the foot plate get adequately fixed before we operate upon those patients to minimize the chances of complications as well.
Right.
I have one point, a very practical point to make, and that I've been following from day one, is that Rene should be negative at 512.
Yes.
Okay.
That gives an adequate information that the patient has a reasonably good conductive hearing loss to operate.
Yeah, whatever your audiogram says, your Rene and Weber should be absolutely at, you should be sure 512 is negative.
So that means minimum loss is more than 20 decibel, at least 30 to
More
40
than
decibel.
25 dB is what the books say.
Yes.
As far as I'm concerned, if my Rene is positive, whatever the audiogram says, I will not operate. Satish, any opinion on that?
Yes, we have done couple of, less airborne gap cases with a laser with good results, but still I would not operate without, for patients having less than 25 dB airborne gap.
And sir, one more thing people wants to know.
There is no harm in waiting for such patients.
Okay, now I'm doing my hanging test, bending
need to
test.
rush for operating unless the patient is very demanding.
Yes.
This is a 4 millimeter piston, and see this coming out. So it is a precise length. Can you see, everybody?
Yes.
Yes, yes.
This is the hanging test. Just be able to come to the edge.
See,
and the bending test is this.
Yes, it's very
not jumping out.
important. This
So
is
this is a
in
4
reference to
millimeter
the
piston, short piston.
use the adequate piston length. Adequate means it should not be short. It should not be over long.
Optimal piston length. Optimal.
Yes.
What is doing bending means as the piston comes to the edge of the fenestra, it bends. That means the length is adequate.
And
Hanging
the hanging
means-
test means that if I pull it a little bit outside, it should be able to be hung onto the edge of the foot plate. So it is not too long. 15. So this is the practical measurement of length I do in each and every case.
Sir, one more thing. What about the patients
The
having
position,
complaint of
the measuring
tinnitus?
of the length, so on and so forth. We hope that we are able to give a fairly good result in the majority of our cases.
Yes. So what about the people having complaint of tinnitus with otosclerosis? How to approach them? Like what to offer?
Counseling. What you need to tell them is that the intensity of tinnitus will reduce because your hearing has improved. However, there is absolutely no guarantee that the tinnitus will go away.
Okay.
Yeah, you cannot promise your patient, but mostly low frequency tinnitus will improve.
So for them, which option is better, a hearing aid or a surgery, or otherwise depends on the choice?
See, hearing aid or surgery is always a question for every case. The issue is with the tinnitus. What Ashim said, you cannot promise your patient that it is going to improve. Number one, yet it improves in majority of the patient where the tinnitus is because of the conductive component. And it is always low frequency tinnitus which improves in majority of the patients.
Okay.
No, but in the meantime, I will also say that by terms of counseling, what I often tell my patients is your perception of tinnitus will reduce a bit, because when you hear better from the outside sounds, the inner sounds reduce. And this is the language I use for the patient.
Yeah, and secondly,
So
on
you
the
will
other side,
perceptibly feel better.
in every case, during surgery as well, the surgical trauma can incite new tinnitus. So this surgery where you open the inner ear, you have to be very, very diligent to minimize the surgical trauma at the level of the vestibule to prevent the tinnitus beginning or tinnitus worsening.
Scissors. Very true.
Sir, what about giving a vertigo?
In this context, suppose the hearing is improved, but patient continues to have the tinnitus, because this is a subjective perception. So is there any medical role, or it is only the counseling?
See, I have given long-term sodium fluoride to many patients who have claimed to have a reduction in tinnitus. Whether it is purely psychological or not is a question I cannot answer.
Yeah.
There is such a huge psychological overlay for tinnitus that is almost impossible.
Yes. No, because there are many drugs which were compared for tinnitus, but if you do a double control trial, there were hardly much of improvement with most of the medicines.
Sir,
for tinnitus, as far as the tinnitus is concerned.
I have used Carovarine.
Caraveria.
Idiopathic tinnitus, and
Yes.
I would say that in about half of them, they seem to have improved.
Sure.
Or can we call it a self-limiting, or we give the credit to whatever medicine we give?
Sir, in the absence of anything else, I would like to try it. It's as simple as that.
Because my experience has been, it is a self-limiting. You give A, B, C, whatever you give, some role is there, but definitely it is a self-limiting in most of the cases.
A lot of emotional overlay, psychosomatic overlay, so on and so forth. Almost impossible to tell, you know.
Dr. Satish, what is your experience with tinnitus? Having a high pressure, high volume centric, you must be getting a lot of cases.
Tinnitus patients require a lot of counseling.
Yes.
Many times, a lot of psychotherapy as well. And dealing with the tinnitus in surgical patients, you have to be very tricky, because whatever you are aiming, the patient focus mostly remains on the tinnitus improvement. You have to be very loud and clear in explaining that.
What is he doing?
I think one thing, Dr. Satish, what I always suggest is you ignore this symptom. More you pay attention to your tinnitus, more it will affect you.
Yes, it is a psychological element.
And I think that really works.
Yes, one of that is part of tinnitus retraining therapy.
Yes,
sir. Right.
Positive
TRT is well known, well accepted.
Yeah.
And a lot of people practice it. And in fact, number 5.
It is the new particle adaptation which requires to be rehabilitated.
Right. That is the more, I think, correct approach and correct words. I will agree.
So now I will tackle my, I widen it to 0.8 millimeters forceps. 0.6 millimeter disc. Now, how do I know I have a 0.8 millimeter hole? I use a 0.8 millimeter disc, Amma. 0.6 to start with. Have you on the
straight holding?
So this is 0.6, 0.8. So it is still not wide enough. Can you see that?
Yes,
I need
yes.
to widen my fenestra a little bit more.
Yeah.
Why can't you do 2 screens?
Sorry?
No, I was thinking why is Dinesh not doing 2 screens? Satish, you are also washed up, no?
Yeah, my case is ready.
So we should go on 2 screens.
Added all 3 people. Viewer can see all 3 surgery together.
Yes, that is right, Dinesh. Ashish,
Yes.
I can see all the 3 screens.
Yeah, okay. Okay,
And I can enlarge one which I like.
Okay. So I am going to just go ahead because there's not much to be talked here. There's something similar.
Yeah.
The only difference in the personality of this foot plate is there's a thick ridge running right in the center of the foot plate. Again, these are the risky ones for perforators. Action. Drill posterior crus.
Can you see how I'm widening the fenestra?
Yes.
थोडंसं प्लेटला ड्रिल करायला ह्याच्यानंतर क्रुरानंतर पिस्टन लेंथ फेनेस्ट्रा आणि झालं.
Asim, can't you use a lesser diameter piston in place of widening more?
Piston, sir. It's only the
Okay,
width of
then
the
you
vein.
have to.
Yeah, because of the width of the vein.
Yeah, yeah. Yes, so you have to. True.
There are 0.3 millimeter diameter pistons available.
Yeah.
But I'm not very happy with them. They bend a lot.
They drill.
And the study says the conduction also impairs if it is too thin.
Yes.
So.
Chalo, vein.
Yes, Ashish and Satish ji, we are all with you.
Yeah, inferiorly.
Yeah.
Please stand by to pinch. Pinch. Release.
थोड़ा पेशेंट जागा झाला वाटतं. जरा ते कॅनल का दे.
Thoda. Yeah, but this is a thick one.
Ashish.
Yeah.
All 3 screens are going.
All 3 screens are on, na? Yeah, okay. Let Ashim do the commentary. We will just show because there's nothing more.
You can talk anytime.
Yeah.
And my case is at the bottom. You can see the foot plate completely
You
fixed.
can see how I've spread out the vein.
Yes.
Laser 0.6. See my foot plate. Can you see the ridge running in the center?
Yeah. You try to thin it out, no?
Yeah, I will thin it out, but I will first use the laser for my precision so that it does not ooze there.
Okay.
So it's like using the cautery on the foot plate.
Ashish?
Yeah.
Mine is again looking like a straight situation. So the basic steps I am doing, you can watch. I am not talking much. There's the same one.
No, I think on the YouTube channel on Zoom, Prakash, you can see 3, but on YouTube only one screen is seen.
That is what happens. The person is speaking, his video will be there.
Oh, then I will keep talking.
Whosoever have to show, that is my impression. Let us ask somebody who is on YouTube.
Sir,
I saw on YouTube only one who is speaking can see it.
Sir, we need to pin one video at a time. I can pin from my side. If you want, I can pin anyone of the.
Sir, I am going to update all 3 screens everywhere, sir, on YouTube also.
Okay.
YouTube only one video is seen.
One video at a time?
Yes.
And is it the one who is speaking, his video is coming?
Yeah, the one who is speaking, that video is visible.
Yeah, so that is exactly on the Zoom main screen that is coming. On the side screen, all 3 are there. So my proposition was same.
Prakash sir, and now I added to everyone on YouTube also.
Okay.
Now all of us are visible.
YouTube, I don't think.
Footplate, letter. Just tell me when we are, because I want to show this ridge and I want to show how it has to be.
So, is my picture going?
On Zoom again, it is the same. The person who is speaking, like Satish, you said your picture has come. Before that, Ashish said his picture came. So on the Zoom that is going, I don't know about YouTube. Somebody has to see on the YouTube.
YouTube, it is still the same. Like the one who speaks is seen.
Right, that is there. That is what I said.
Okay, so sir.
Like when you started speaking, that has gone.
0.5 karna. Sir. Hello.
Yes.
I'm sure my picture is going, the full cursor.
Yes, sir. Sir,
Yes.
sabka picture ja raha hai. It's going all pictures.
Yes, sir.
Hello.
Yes.
See, my picture is coming. Can you
Yes,
see
yes,
my
sir,
laser
but-
beam? Can you see my laser beam?
Yes.
Yes, sir.
But the moment somebody speaks, it will again, his picture
See
will
my
come. So
laser
we should
beam,
keep
it is
quiet. Yeah, we should keep
laser
quiet.
beam, and it is done. See the fenestra.
Yes.
Once fenestra is done, I will use my piston. That is done. This is to clean if any bone piece or anything.
Drill.
See that? And now finally my piston, which is going to come. So it's like, laser helps you a lot in preventing problems and dealing with the problems.
This is a bad canal. Side knife there.
Okay, so I have finished crimping my piston.
Mine is the last step in this, and that is just placement of the piston.
Dr. Satish, yours is a repeat of the last case, almost the same steps.
Yeah. See that piston?
Yes.
Just place on the fenestra, and this is the middle slot which is going to be taken up. That's it. Can you see?
Yeah. Yes. Excellent.
Drill there.
No manipulation, no crimping. See that? Absolutely befitting.
ते स्नेहाला बोलो लेक्चरच्यासाठी.
That's it.
Am I audible?
Asim, we lost your picture, boss.
You're audible, sir, but no picture.
Yeah, Asim, your picture is lost.
Am I audible, visible?
Audible or not visible?
Piston is done.
Dinesh, can you check my visibility? I just wanted
Ah,
to
now
show
you
one-
have come.
Yeah. So
No,
what I
it is
wanted to
Ashish
show-
only, not Asim.
Can you see the ridge there? I'm
Yes,
being
very clear, boss.
slow to get to the. I'm just
I
doing
just
time
want to
pass.
show one moment just to show the vein that is spread out properly.
Boss, Ashish.
Yeah.
Ashish?
Yes, Deepak, hi.
Hello.
Hi, Deepak. How are you?
That ridge is not time pass, boss. Hi, Ashim. That ridge is not time pass, boss.
No. I'm doing time pass there to come on the main screen.
You are already on the main screen. Asim,
Yeah.
screen is not visible. Hi, Dr. Deepak. Good afternoon.
Hi, Munka Sahab. Now
Yes,
Ashim is visible.
Yeah, now Asim is visible.
Okay, so
Now
now you can
Ashim
see
is
how the
visible,
vein
yeah.
is spread out on the promontory.
Yeah.
It gives you a visual impression of no invagination due to excessively long piston. And we are just doing the round window reflex. Everything is good. So that's about it. And I'm now going to place.
Yes.
I'm going to place the chorda tympani on top of the prosthesis.
Yeah.
Give me a dry gel form.
Fantastic.
So I will thank you very much. Now I am going off air so that you can concentrate on.
As usual,
Ashish.
picture perfect, Ashim. Ashim.
Yes, sir.
As usual, your picture perfect. Yeah.
Thank you, buddy. Thank you, buddy.
Your consistency is always amazing, as usual.
Thank you. Thank you, sir. Thanks a lot.
Yeah.
It's a pride and pleasure coming from you, buddy. Thank you.
Already on.
Ashish,
Yeah.
we are on your screen.
Hello.
Am I on the full screen? Or am I on the screen?
Yes.
Can I talk? Satish is done.
Sir,
Satish is done. Satish put the piston
Ashish,
fantastic,
I'm
as
done.
usual. Satish is done, yeah.
Yes.
Okay.
Yeah, Ashish, we can see you.
Yeah.
Satish, good afternoon.
Sir, good afternoon. Always nice to see you.
So now there is a ridge that runs straight between the anterior crura and the posterior crura.
Yeah.
And we have to first of all thin it out.
Off air.
See that it is fully thinned out.
Yeah.
Totally flattened. Can you see that, Deepak? In the posterior half of the foot plate, it has been drilled out. Give me. I'll make it a little bit more gray in color. De patkan drill. Although I know that where I want to make the fenestra, it is nice, but
Yeah, that ridge is almost gone.
gone. Yeah. Yeah. Okay. Perfect. Give me one dry gel foam to mop and just to highlight that the foot plate has become nice and flat. So that now so I had drilled the posterior crura while I was off air. Just to save on time. Yeah. 1 minute. Mala piston de. This is a little. Yeah. Our piston measurement and the piston rehearsal.
Ashish, this is a good technique for measurement and assessment of the piston. You don't use usually the measuring rod.
Yeah, I have a dyslexia. I'm not able to use it. I mean,
Okay. But
When
that's
I
a
come-
blessing in disguise, boy.
Yes,
It's
I have,
more perfect way to do it.
I have had to work around it.
Yeah.
Because I would just forget which notch I marked. So this became a much easier one.
Yeah.
Too long a piston there.
Rather, this is a more practical thing. It's a real time, you can say.
No,
And
actually, one can make the initial measurement. It's not, honestly, the measuring rod is a better way to do it. After measuring the rod, then maybe we could fine tune it with the way I'm doing. But
right, exactly. That should be the way.
yeah. We are going to have the radiologist. Bollega Hichashi? Sneha?
Yes, sir, I'm online.
You're online. No, okay. Satish, are you free? Is
Yes,
Satish?
Ashish.
Satish?
Yes, yes.
So Dr. Sneha is there.
Yes, yes. I'm waiting for a talk.
Yeah. In about 5-10 minutes, I think we'll get. So don't go away, please.
Yes.
We
We are
your
not going away.
contribution and your inputs on for her, specifically to improve our way of doing. We have made a lot of progress. She's suction, please.
So once your piston is in, she can start, no?
Yes. Yes. It's still right angle. It's still a little bit long. I'll take away a little.
Satish ka CT bajana important hai.
Yes.
Yeah.
Sneha, but
Yes, sir.
this part I always find it
5 or 7
amazing,
minutes.
Okay, sir.
Ashish.
If you want to try your screen sharing once, you can try it.
Okay.
Dinesh?
Yes, sir.
Yeah. Dr. Sneha is going to give the talk. Just make sure her
Spotlight. Okay. Okay.
Yeah. Okay. Suction.
Yeah, Neha ma'am, your video is off.
Video is off. Okay. Can you see my screen?
Yeah, yeah.
Yeah.
We can see the presentation, but your camera is off.
Piston. Yeah. Another. I should not.
Ashish.
Yeah.
This part of you making slices of the piston.
Yeah.
Without actually measuring the distance, that amazes me actually. I
No,
always use the measuring grid to cut the piston. This
But
part of Kirtane sir and you, I've seen you two doing this especially. I think it's amazing.
Yeah, okay, this is fine. The right angle. This length is good. I just have to make sure my field is good now. The motor canal.
And you always use a 0.5 piston, isn't it?
I always use a 0.5 and a 0.7 fenestra, and that has worked for me. Very rarely a thin narrow. What I do is I do have a 0.4, but there are times when I have just vertically split the thinned out the 0.5 piston in case it's a very, very narrow niche to sort of customize.
0.5 and made it a 0.4.
Okay. Fenestra. That.
Yes, is all ready and eager to go.
Yes.
This is what happens from the edge of the overhang that you removed. The shaft of the
Yes.
burr carries the blood.
Yes.
This is very,
Yes.
very, very upsetting. Yeah.
Annoying.
Very
Annoying. Yeah.
But there's really nothing you can do. There a suction.
At times, it's only the patience and waiting for some more time. That's all.
Ordinarily, it doesn't matter. But in a workshop, when you have
Yeah. No, even a workshop, Ashish, especially for the beginners and others, these lessons are even more important rather than a picture perfect case. This is my take.
Agreed. The fenestra. What I definitely don't want is a partially made fenestra and a bleeding there. So I'm investing my time to ensure a good hemostasis. So when I go, it should be in one go, and the blood, because that is the worst situation to land up with.
No, but Ashish, in the recent talk, Satish also mentioned that the pressure of the vestibular fluid is such, blood doesn't really get into the vestibule. Except that we suction there, then that is a problem.
No, it's not about the blood going in. If the fenestra size is narrow, if you have opened and then you land up, because then you don't want to. That is what I'm talking about.
Yeah.
I think coming from under the pyramidal process, let me.
Put a gentleman peak for about 4 minutes.
Is it available? See it, it was actually inferior to the pyramidal process. There was a clot. It just coming out.
Okay.
Drill. The overhang removal has been not proper. That is why I'm struggling. Mala curate there. Let me take out what is wrong. This is not allowing my handpiece to go. Only I have wrist.
You're using a skeeter?
No, just our regular drill.
Quadrangle, okay. Yeah, I think that's a good point you made. The second genu should be clearly visible.
Yeah. Because otherwise I was not able to see the ball of my burr, which is very important.
Sir, do you use self-retaining speculums?
No. Oh God. No, I hold it, or if I have to leave it for some reason, then my assistant nurse, she will hold it.
I use a self-retained speculum designed by Dr. Madhavaya.
Oh, that one. Yeah. Okay. Okay.
Yeah.
Can't fucking believe it. It's the mucosa on the fallopian canal. This mucosa. No, it's coming from. Let me address it properly. Yeah, it's This is really testing me. I like Zada gel from there.
Testing the tough man.
Just when I was planning to finish it fast. Neha, sorry. This is not what happens usually, but
No, you told 5 to 7 minutes, no?
I know.
I think the footplate heard it.
Footplate heard it and he says, "You arrogant bastard, you think I'm that client all the time?" No way. You know what I've done is I've kept the gel foam inferior to the stapedius.
Yeah.
Still coming. Suction.
Ashish.
Yeah.
Just a suggestion.
Yeah.
You did a fantastic job of the ridge. Why don't you keep a gel foam and wait for 3-4 minutes?
Yes, I think that's what I'll do. Because I have no other choice. I was just thinking whether I should use my laser.
You've done very well so far. And believe me, this is a very good lesson for the beginners to how to manage this. They're going to face this more often because they're not the masters. So I think.
Ashish, do you ever use just a laser beam to stop this bleeding?
I'm not able to see where it is coming from.
Yeah, so it is. But if
only-
you can see, you can use that.
In fact, he used the KTP in the beginning on that persistent artery. He did
What
it
I'll
well.
do is I'm going to keep a gel foam adrenaline there and wait patiently.
Right.
Maybe we'll go ahead with Neha's talk.
Yes.
That's better.
Neha, I think we can go ahead with your talk.
Yes, sir.
And then he'll come. Yeah, that's a very great idea, I think. Yeah. Over to you, Sneha.
Yes, sir. Thank you, sir.
Canal ka section mein.
So my talk today is regarding imaging of suspected case of otosclerosis. Otosclerosis falls in the spectrum of conductive hearing loss diseases with normal tympanic membrane. Diagnosis of otosclerosis is very important because along with the diagnosis, we also rule out other possibilities of conductive hearing loss, deafness, normal tympanic membrane. Name otosclerosis, even though it is a misnomer, because the earlier changes in the otosclerosis are predominantly otospongiotic. Pathology is important because CT diagnoses the otospongiotic phases more easily than the otosclerotic phases. The otospongiotic phases are characterized by hypodensity. Otosclerosis is common in middle-aged people, more common in Caucasians, and female-to-male ratio is more in the females. There are multiple etiologies which has been said cause otosclerosis, but none of them are definite. So the pathology, most important part is that in earlier stages, the bone is characterized by new bone formation with microcirculation. This is seen as hypodensity on CT, and which we can appreciate and diagnose. There are two types of otosclerosis, fenestral and retrofenestral, but ideally the retrofenestral is more of a continuation of an fenestral otosclerosis. Primarily retrofenestral otosclerosis is rare. Before going into further imaging, the most important structure when you are diagnosing an otosclerosis is identification of fistula antifenestrum on HRCT scan. Fistula antifenestrum is a cleft which is anterior to the window, that is oval window. So it is called as fistula antifenestrum. It separates the otic capsule from the middle ear cavity and is the first site where the otosclerotic foci occurs. There are different types of otosclerosis. In stapes, anterior focus, posterior focus, circumferential biscuit type and obliterative. The modality of imaging, first modality of imaging and first line of investigation in any conductive hearing loss is CT. It can be either MDCT or cone beam CT. MDCT can give you resolution up to 0.5 to 0.625, while cone beam CT can give you resolution much thinner, that is up to 0.08 or 0.125. Multi-planar reformatted reconstruction are used for further evaluation of the axial images. These are the two views along which the imaging is further done for MPR reconstruction. So the imaging finding in fenestral otosclerosis is characterized with hypodensities on CT. The first site obviously is fistula antifenestrum. This is followed by site like promontory, round window niche, tympanic segment of the facial nerve. Over period of time, there is possibility that the otosclerosis foci may increase, they become sclerotic and cause obliteration of oval window and round window, though complete stenosis is only seen in 2% of cases. Isolated round window involvement is rarer and is only seen in some patients. So I go through some images of otosclerosis fenestral type. This is a patient with right. Hello. This patient has otosclerosis foci in fistula antifenestrum. As you can see, the rest of the bone is very bright and white, and over there adjacent to it, we can see a focal area of decreased density, which is called as hypodensity or otospongiotic phase of otosclerosis. Similar image on the left side, there is lucency seen adjacent to the fistula antifenestrum. These are both crusts of stapes, and then you can see a lucency in fistula antifenestrum. Another case with bilateral involvement, as we know that bilateral involvement is very common. Up to 85% of patients can have bilateral involvement in otosclerosis. This is one more image in which this is a coronal HRCT temporal bone, which is revealing changes of otosclerosis in form of hypodensity along the promontory. Next image is again a subtle lucency. If you compare the rest of the bone density, you can see a hypodense area, that is decreased whiteness along the promontory. This is one more patient with focal lucency seen adjacent to the round window and extending up to the promontory. Again, one more case with lucency adjacent to the round window and adjacent to the basal turn of cochlea. Next is this image on actual image. This is a fallopian canal.
Foot plate.
Hello. This is a fallopian canal, and adjacent to it, we can see a lucency. Again, case of fenestral otosclerosis. The second type of otosclerosis is retrofenestral otosclerosis. It is usually associated with fenestral otosclerosis, and it is characterized by multiple areas of lucency in cochlear region, semicircular canal, along the internal auditory meatus, and vestibular and cochlear aqueduct. But the classical appearance in retrofenestral otosclerosis is a hypodense double ring on HRCT, also called as fourth ring of Valvasori. So this is a typical appearance of a cochlear otosclerosis, in which along with the turns of cochlea, that is basal, middle and apical, you can see one more lucency called as fourth ring of Valvasori. These are more cases of otosclerosis. There is a small lucency seen adjacent to the vestibule, and there is subtle lucency surrounding the turns of the cochlea. Again, there is one more case where there is lucency adjacent to the apical and the middle turn, and subtle lucency next to the round window. One more case of lucency seen adjacent to the basal turn of cochlea. There is one more case in which we can see there is lucency lateral to the turns of cochlea, predominantly the apical turn. Next case is showing lucency seen surrounding the cochlea with small lucency adjacent to the vestibule. Another lucency adjacent to the vestibule of the vestibule and lateral semicircular canal with subtle hypodensity seen adjacent to the vestibular duct. So the checklist that we are currently using for reporting a preoperative CT includes size and location of plaque, status of the oval window and its thickness, status of round window. Specifically, we are trying to mention overhanging margins so that if it requires drilling in case needed. Facial nerve canal, predominantly the course of facial nerve canal in the fallopian segment overlying the oval window, which if dehiscent can obscure the surgical field and is prone for injuries. Next is concurrent middle ear pathology. If there is any secondary middle ear infection or middle ear anomaly that needs to be mentioned or can be treated with infection prior to surgery to increase the better outcome of the patient post-appendectomy. Next is ossicular chain fixation, fusion or fracture that needs to be mentioned. Because only having stapes is not adequate. You need to know whether malioincus joint and incudostapedial joint predominantly is normal and is in continuity. The vascular anomalies includes dehiscence or high riding jugular bulb, aberrant origin of ICA and persistent stapedial artery. Inner ear pathologies include presence of otosclerosis, which might be causing membranous labyrinthitis or decrease in the lumen of the cochlear turns or any facial nerve or vestibular anomaly, cochlear nerve anomaly. And opposite ear also requires equal imaging. So the measurements that we are giving in the report includes oval window. Normal oval window should be more than 1 millimeter. Round window more than 1 millimeter. Oval window niche that Dr. Belsare had already explained on her images. So oval window niche less than 1.4 millimeter is associated with surgical difficulty and less than 1.1 millimeter is associated with complications in many of the patients. Stapes foot plate thickness is measured. We usually try to measure it at maximum site of the thickness because sometimes the thickness can be asymmetrical. Cochlear duct dilatation and vestibular duct dilatation, if present, needs to be mentioned. Along with that, we make a specific mention about semicircular canal, that is presence of third window, which we'll discuss later. So this is how we take the oval window measurement, the oval window niche measurement, but I think we'll add more measurements, that is oval window depth and the promontory facial nerve angle, so that we get a better view of the window. Round window measurement and thickness of the stapes foot plate. We are trying to see, like I have been trying to give this incudostapedial length, whether and we would like to see whether it will help the length of deciding the length of piston in the patients in future. Ossification of malleolar ligament, whether it is present or not, specifically the anterior malleolar ligament and the superior malleolar fold needs to be mentioned in the reports. The CT grading of otosclerosis was given by Simmons and Fanning. The grade 1 is specifically the fenestral otosclerosis. Grade 2 otosclerosis can be cochlear, depending upon where it is there. The basal turn is 2A, the middle turn is 2B, the lateral side of the cochlea is 2C, and the entire cochlea is 3. So as we can see the progression of the otosclerosis, in first image, there is no hypodensity. You can see the entire bone is white. There is no subtle hypodense areas. As the disease progresses, there is lucency seen in fistula antifenestrum, that is grade 1 or fenestral disease. Then there is second lucency seen adjacent to the basal turn. As we progress, there is one more lucency seen at the middle turn, and there is lucency along the lateral margin of the cochlea. And in stage 3, there is fourth ring of valvasori. Pitfalls in imaging of otosclerosis is in younger patient, there is an anatomical normal variant called as cochlear cleft, which can be mistaken as an otosclerotic foci. but it is more anterior to the fistula antifenestrum, more closer to the cochlea. Along with that, the age of presentation is in younger patients, and patients are asymptomatic. Along with that, as the age progresses, this lucency is completely gone. There is one more case of cochlear cleft which can be mistaken, but it is more common in children. So a caution is needed when you are trying to diagnose otosclerosis in children. Tympanosclerosis is another disease which can be confused with otosclerosis clinically because of presence of conductive hearing loss with identical presentation. And it is difficult to diagnose even on CT scan. However, sometimes on CT scan, we can see thickened sclerotic tympanic membrane. Also, sometimes there might be sequelae of previous surgery in the patient. The third important point that we need to mention, as I have told earlier, is superior semicircular canal integrity. Superior semicircular canal dehiscence can cause giddiness in patient. If such patients present with otosclerosis, the third window picture in the patient is converted into two window. So patient is asymptomatic for giddiness. But post-operatively after stapedectomy, again, all the three windows are open and patient is prone for giddiness. So specific mention of superior semicircular canal dehiscence is a necessity while reporting a CT for temporal bone for otosclerosis. These are cases in which there is a reformatted and corneal reconstruction to show that the bony labyrinth is dehiscent and the membranous labyrinth is communicating with the adjacent brain parenchyma and CSF space. Another mimicker of otosclerosis is Paget disease, which can cause lucency all around the bone, but there is diffuse bone involvement and not only cochlear and fenestral involvement. So that is clinical history and radiological diagnosis can confirm that. Post-operative imaging is done in otosclerosis patient post-stapedectomy if there are any complication present. HRCT is first line of investigation. It is usually done to see whether the ossicular linkage is properly restored. All the stapes prostheses that are used, including Teflon, stainless steel, titanium, and platinum, are all hyperdense on CT and can be easily appreciated. These are various complications that we can see in prosthesis implant. Over here, we can see that the prosthesis, which is hyperdense or white, has gone too much inside the vestibule. According to the articles, extension more than 2 millimeter within the vestibule is suspected of intrusion of prosthesis. In this case, the prosthesis is just touching the oval membrane and not having any contact with the vestibule. Next image, there is discontinuity in the vestibular gap. That is, the incus in this patient is resorbed. So the contiguity with the ossicular chain and the incus with the prosthesis, stapes prosthesis is lost, causing hearing loss. In next patient, the prosthesis is in place, but it is displaced superiorly. In this case, inferior to the oval window and superior to the oval window. So it is not in normal location, that is along the oval window, just reaching the vestibule. Role of MRI in otosclerosis is still developing, and it is kind of less, like MRI is less used in patients with otosclerosis. A patient who might present with predominantly sensory neural hearing loss without any conductive hearing loss can go for MRI as a first choice of investigation. So in such patients, including the basic MRI sequence, that is T2, T1 axial, we need to ask for specific cube and cis sequences along with thin T1 sequences of IM pre and post contrast in all the planes. MRI finding in patients of otosclerosis includes pericochlear enhancement. So you can see that along the cochlear turns, there is subtle hyperintensity, which is suggestive of otosclerosis in pericochlear region. Again, one more case in which on T1 we can see subtle bright signal, because on T1 everything looks dark. So on post contrast, you can see as compared to this grayness, it's more white. So these are findings of cochlear vestibular fenestral enhancement along with cochlear enhancement. In next case, again, there are subtle hyperintensities in pericochlear region, which on post contrast reveals ring-like enhancement appreciated on other images. MRI is also useful in identifying other inner ear abnormalities, in identification of post-operative labyrinthitis, in identification of membranous labyrinth ossification, a rare presentation in cochlear otosclerosis. MRI will help in diagnosis of cochlear lumen. So in this patient, we can see that there is significant sclerosis seen along the cochlea with obliteration of the basal turn of cochlea. On post-contrast scan, if you compare on, this is not a post-contrast scan, this is a CIS scan, which is a heavily T2-weighted scan, which shows fluid-containing structures better. So you can see as compared to the left side, the lumen of the right basal turn of cochlea is decreased in size. MRI is also useful in diagnosing of early labyrinthitis. There is subtle intermediate signal seen in the fenestral region and vestibular region on both the sides in T1 weighted images, which on post contrast scan shows significant amount of enhancement suggestive of inflammation. Thank you. There is one more case. Sometimes there is ossification of semicircular canal. So for seeing those, MRI cis weighted images can tell you a better presentation in this patient. You can see that all the semicircular canals are not well seen because of the ossification. Only partial semicircular canal whose lumens are mented are well seen. Thank you.
Madam, I have a question for you.
Yes, sir.
Can I ask a question?
Yes, sir. Yes, sir.
See, basically, we are more concerned about the pen lymph gushers. So how do we get prepared beforehand when we see the CT scans to know a pen lymph gusher, chance of high pen lymph gushers, high chances?
I think specific mention about the cochlear and the vestibular duct diameters, which can be site, and along with that semicircular canal, whether there is dehiscence anywhere along those lines, I think so that should be specifically mentioned in such patients.
Thank you.
Yes, sir.
Deepak, actually, can you hear me?
Yeah.
Yeah, Deepak, actually, Satish made a mention of this. You were not on. He said it's actually never the patent.
I was on. He meant about the diameter of the internal acoustic meters.
Okay.
Yeah. I just wanted to. Yeah. I'm there since morning, Ashish. Yeah.
Oh, okay. I thought you're busy doing surgery. Thank you, Sneha. Thank you so much.
Thank you, sir.
Excellent. We will take this forward and make you the imaging queen of India.
Yes, sir.
Temporal bone.
Thank you, sir.
She's scared. She's always embarrassed with whatever I say. Thank you. Thank you, Sneha.
Thank
She's
you,
helped us a lot in our congenital atresia cases.
Yes,
We've
sir.
redefined imaging in the world. She's published a paper in the radiology department, in the radiology journals. And I think there's a lot of work that she's helped us do in a much better way. She's able to give us very precise location of the facial nerve, of the ossicles, and the stapes. Very important.
And Ashish,
yeah,
you can embarrass the best of them.
Sorry.
You have the knack of embarrassing the best of them, I said.
No. So now Ashim apparently is having some problem. Ashim?
Yes, boss.
Yeah, his signal is okay now?
Yeah. There was a time when my audio was off. They didn't want to.
Are you ready to show one more?
No, it'll take about 15 minutes or so. So why don't you start?
No, my case is also just over because I had some issues with oozing. Now I had to finish it off. Because
your oozing stopped with the gel form?
Yes, it stopped with that gel form adrenaline, but now the patient was in for too long. So, his bladder had started troubling him. So I had to finish it off. It was simple. After keeping that gel form adrenaline for 2 minutes or so, it stopped. It was from the undersurface of the pyramidal process. I don't know why it was oozing.
Ashish,
Ashim, do we have some talk?
Ashish,
2 or 3
I have
things.
some, I think I have something new videos I already shared in last.
Rajiv, is that Rajiv?
Yeah.
Rajiv.
Yeah, please go ahead. We need a 15-minute filler.
Yes, sir.
Yeah, because I was seeing something is going on. That's why I just prepared the videos. These
Okay,
are the,
lovely.
of course, since we have done so many, since morning, we are seeing, since last few months, we are seeing all the webinars and
Yeah,
we
so
are
I
doing
think
wonderful.
one last case from me and one from Ashim, and I think then we are off.
Yeah, I
Okay,
just
so
wanted
this-
to, at some convenient time, wanted to, since so much talk has been done on the facial nerve, just wanted to share a quick clip on how to handle a very, very prolapsing nerve. So
Oh, yes.
we can do it at the end of all of this, if anybody is
Okay,
interested.
okay, perfect. Yeah.
Okay,
So
go
I'll
on,
do just
Rajiv.
one
Since so many surgeries been done on the steppies and all are wonderful surgeries, is from starting from injections to everything, and everybody is groomed with all the cases. But I think we should also know that we, as a learner or as a new surgeon, we do some mistakes. And I would like to share a few mistakes which we have gathered from my friend, colleagues, and from myself, because I have done few mistakes. And I would like to share those mistakes with all of them. My next video is okay, Dinesh?
Yeah, we are not seeing a video. We've got the still.
Yeah, now it's the video is on.
Yes.
Yes.
Yeah. So one thing I would like to, because the one plus point, I think we could not see the local injection. But main thing before starting any steppy surgery is just to give a wonderful local anesthesia, because if you do not give a proper local anesthesia, then I think it makes your surgical steps and your half an hour surgical journey very difficult. So I think it should be a single prick incision, single prick local anesthesia, and you should not put multiple, you can say, pricks in the canal wall, and because it makes the things worse, and you can get this picture after putting the local anesthesia, and nobody would like to see this picture, like making some hematoma and some sort of blisters in the canal. So one point I would like to share with all that we should take care of this, giving local anesthesia before starting the steppies or any endometal or endoperimeter surgery. That is the plus main point everybody should know before going for a steppies. If you're doing perimeter,
Hello, check. Hello, check, test.
Yeah, Dinesh, is it okay? Hello.
Rajiv, go ahead. Perfectly all right.
Yeah. Okay. And second point is that
Rajiv, you can put your video. We cannot see you. Your slides are there, but you are not visible.
Sir, mine, okay.
Yeah, that will be good because we can see your expression as well.
I think that so.
Nunca sabe. If his work is visible, it's more than enough.
Yeah, okay, fine.
So, like sometimes we get frustrated while doing steppy surgery because we do some mistakes like this one. The main thing is that we take care of the flap length, as Dr. Satish mentioned in the starting. You should have at least 4 to 5 millimeter flap only. Never take a very lengthy flap. You can say more than 8 millimeter, because it during surgery it will create problem for you. While you have to keep it in the canal, you have to sometimes you have to get disturbed by this long flap, and even the small flaps are sometimes can cause perforation, residual perforation after surgery. So I think you should keep in mind that take a proper length of the flap. Second is that is the worst part. I think this is in fact my video. And blind curate can destroy the ear, because never, like if you are using curate, you are using gauge hammer, you are using scissor, whatever you are doing. But and in last you are using curate, but never try to do like this one. This case, the surgeon is doing curating without seeing the incus or anything, and now see the thing. Incus is out. It is totally dislocated because of the blind curating. And that is, I think, that is I would say it's a criminal act. Nobody should do, because if your incus is dislocated, your surgery would be in the difficult phase. So I think never do blind procedure, blind thing in steppies. Always do everything under vision, without keeping your eyes away from the site of the surgery. Third point is that do not play with the and once if your incus is hypermobile, do not play with it. Just try to deposit back. You can give sometimes. Never do like this. Never do like this. These are very rare cases.
पैसे पे डिपेंड करता है ना.
हेलो. हेलो.
इसमें एक तो विक्रम है. अब भाई इनको जानता है कोई? सुनील जाखड़ कौन है?
हेलो.
नंद किशोर.
ये भी है ओके ओके.
संयम.
संयम ठीक ठाक है बट इतना भी मतलब नहीं. इनमें तो ना ऐसी है सुनील अरोड़ा बहुत
रोहन जाखड़.
रूमर पे आप थोड़ा चार्ट लगाना तो लगा सकते.
रोहन जाखड़.
रोहन जाखड़ ठीक है बैठता है. अरे अच्छा नहीं है. अच्छा नहीं. ओके ओके मारता है.
हेलो.
Hello. Yeah, now it's okay. Can you hear me?
Yes, yes.
Something was wrong. And do not play with the hypermobile incus, as you must have seen in the video. So because it can destroy your ear. Few more things. One will never compromise the piston quality. Never compromise with the piston quality, and do not. 1 second. Hello, something was wrong. So never compromise the piston quality. Go for the best quality piston, because during manipulation you can damage it, you can bend it, you can sometimes you may by bending the length of the piston may become you can say altered, and that can create problem later on. And never lose patience at this stage. So never once, so because this is one more thing I think which we have in our piston. Once sometimes your piston goes inside your vestibule. At that time, just have some patience and take it out very patiently. Otherwise, if you manipulate it with the normal forceps or thing, then it can damage the inner ear, and you can give a SN loss in post-op cases, post-op stages. These are few steps which are very much important in the. So at this, the surgeon is trying to take it out with the same forceps, and it is going inside, and you can imagine how much damage he must have done for this vestibule, and you can expect SN loss in these cases. Just have some patience, wait for some time, take out your right angle or whatever instrument suits you, and take it out patiently, and then after you can do whatever you can, but never try to play and have some patience at this level, because it happens with everyone. And those who are doing a step surgery, it can happen to anyone, because we are playing with the instrument, so it is not a new thing. But one thing I would like to share with it, those who are doing the step is, they should know this step, because you never know, your piston, your foot plate may come out. Before starting a step surgery, you should be well aware about this step, that is how to take a vein graft, how to prepare it, and nobody should say that I don't know how to take out vein graft, and he or she is taking the cases for the step surgery. This is a basic step, whether you are using it or not, but that is a different issue. Like Dr. Satish showed us today, that hypermobile foot plate, since he was having this laser, he could manage it, but a new person or new guy or those who do not have laser, for them it is very difficult, and they should know how to take the vein graft, how to place it, how to put a piston over it, how beautifully Dr. Asim put the piston over the vein graft. So that it is I would say it is a primary step, basic step. Every step surgeon should know it before taking the patient for the implant and for the step surgery. So how to prepare it, how to where should be intima, where should the extra surface should be there. All the steps everybody should know it. And this is one more. I think this is a very mistake. Whenever you use your piston, you should take a proper guide. Means how to take a proper length, how to cut it. Never try to cut your piston with your old knife. Let's just see this. The surgery was done. Surgeon put the piston inside. Even the patient was having vomiting, whatever, so many things. And he was very confused that how it happened. Somehow he has to take out the piston out, and he see that one tag was left because of the cut was not properly done by the knife. And again, he put the piston, he cut it, and he put the piston again. with proper cutting, and the patient was finally very fine after second, third day. So these things you should keep in mind. Again, very frustrating. No fight. If your piston is, you're not able to put your piston inside the incus, because something is wrong with your piston, or you have not opened it properly. But do not struggle at this phase, because struggling can create problem for the piston, for the foot plate, for the incus. So just have patience, open it. And one more step, which is very much technically, everybody can do it. And I have taken it with the graphical. Just cut two angle of the piston, and then put it inside. It will go very smoothly, and it is very common with your Teflon piston. So either your memory should be good, or you use this step, then you can put your stump very well, and it will be a smooth surgery. Never try to play with the. Never you can don't play with the piston while inserting it in the step incus. One more thing, and second point is one more point. Yeah, never this step was since morning today. Everybody is taking this same sentence that never remove attic bone excessively. You should have a well concept in mind that you should not ever expose the attic area, because it can create problem later on. Because if you take it out, this is the maximum. Incus body should not be visible over there, and pyramid should be. You don't take out attic and do not bear the incus, because excessive removal of a stapes can create problem later on, because you may get a attic retraction, you may get a attic, you can say your piston may come in contact with the tympanic membrane, and you can get this picture because you recurrent discharge from the piston side, or this may be create a granuloma, or later on you have to take out this piston and you can create problem for the patient. So never try to take out, just see this granuloma is there. So these are very frustrating problem for any surgeon who has done a wonderful job in his stapes, but because of the single mistake, the surgery is doomed out. And again, keep this step in the mind before taking or while doing the surgery. And if you have done the mistake, then put a small cartilage piece over there and on the piston and the graft. So if they're finished, even suppose you're doing Malleus staphylococcus, then you can put a cartilage piece over there. So these are a few things which I wanted to share here, and many more are there, but best and Asimos and Dr. Ashish will take care of all things. So thank you, Dr. Ashish, Dr. Satish.
It's always nice to hear from you, Rajiv. What you said was quite practical, quite sensible, and I think it's a take home for most people.
Yeah. So who is doing next? Satish, Dr. Asimos, ready?
No, my case has just got on table. It will take 5 minutes. I'll just discuss a quick video, maybe 5 minutes on the stapes with a gross facial nerve prolapse. So with your permission, I'll just start my screen sharing.
Yeah, sure.
Is my movie visible?
Yeah, visible.
Okay, so now this is a case of otosclerosis, and there's a gross prolapse of the facial nerve. Now, in such cases, what happens is that this all areas mucosalized is very thin stapes superstructure, and this kind of a gross prolapse precludes the use of a laser. So now what I'm doing here is I'm drilling out the complete pyramid. Whenever you have a difficulty in approaching the foot plate area, just go from posterior to anterior. The more posterior you go, the more likely you are going to be able to create some space for you to put your prosthesis in. This holds true even for a situation where you have a persistent stapedial artery, because ultimately it goes in the obturator foramen, that is between the anterior and the posterior crus of the stapes. And what happens here is that when you drill from posterior to anterior, the crura themselves create enough space for you. Now you can see that although the crura has been drilled out, there still is very little space. So rather than drill a promontorial window where there's a risk of disrupting the endolymph and perilymphatic connections, it's always better to try and create space in the position of the oval window. So what I do here, first of all, I separate out the IS joint, exactly as you saw us all do. And the way we do it is to twist rather than out fracture. When you twist it on the axis of the anterior crust, least chance of having the floating foot plate occur. You saw in the second case I did that in spite of a large prominent band, this problem of floater did not occur because you twist it on the axis. So it's like a Potts fracture, a rotational fracture rather than a side-to-side fracturing. So now you can see that there's still not enough space. So what I do is I create space by gently putting dry gel foam between the foot plate and the open facial nerve. And over a period of time, it takes about 15 to 20 minutes. This is an accelerated limit. Now you see, this is the only area that I have. Only that much, maybe about less than 0.2 millimeters. But by using this technique, I'm able to compress the fascia nerve very, very gently. And all the while, my anesthesiologist is keeping an eye on any facial nerve twitches, and the patient is continuously asked to show their teeth. So you see how I'm using dry gel foam between the promontory and the prolapsed nerve. And this is creating space. We keep stuffing it for 15 to 20 minutes, bit by bit, bit by bit. And then you wait. See, now you will see a little more space. Can you see now? Still not enough. So keep doing that until you have about 0.3 to between 0.4 and 0.5 millimeter space. And very gently, we demucosalize the foot plate. Then, at the expense of the bone over the promontory, I will just lower the bone over the promontory a little bit. Very, very, very slow RPM, as you can see. Because you don't want to cook the mucosa on the facial nerve. Then again, we follow the same procedure to create space, and then the length is measured. Again, a little bit of the lowering of the promontory is done. All of this takes time. This is an 8-minute clip. Believe me, it takes more than an hour and a half to do this procedure. And finally, you can see you have a 0.5 millimeter space. In which you can make a fenestra and properly place a piston.
Yeah. So the laser, Ashim, the laser can be used on the promontoral side of the mucosa.
Yeah, you can use it. You can use it.
And, yeah. So
now you see the amount of space that you have, Ashish?
Yes.
Yeah, we started off with less than 0.1 millimeters. And a combination of lowering the promontory and compression of the facial nerve allows us, but one has to be sure that one does not make a promontorial window.
Yeah, one is only extending the annular, I think.
Yeah. Now you can see, you can very clearly see the annular ligament, and there is enough space for us.
Yeah, Sai had shown that, with one hand with the suction, it's impossible. I think it's good to show a line drawing.
Yeah.
but you cannot really compress the facial with the suction tip and
You
then
use this dry gel foam and the bodily fluids, soak it up, and that gives you very gentle pressure.
yeah.
So now you can see it's almost through. Obviously, there's no question of vein interposition in this kind of a technique. Stands to reason.
And now the piston, you have the length of the incus going all the way down.
Yeah, I have sufficient length, and if I don't, I will use a bucket handle prosthesis. I have a couple of very good titanium bucket handle prosthesis which I can use when the piston is short.
When the incus is short.
Sorry. I'm so sorry. When the incus is short. Forgive me.
Fantastic.
So here again, the 0.5 millimeter, 0.4 millimeter piston will be used in a 0.5 millimeter fenestra.
पांचवर्ती कर कॉटरी inferior incision कॉटरी में था.
Using my measuring diameter, a lot of people say I measure with the eyes, but I am kind of very bad with that kind of thing. You know, I just need quantification.
But Ashim, the burr size itself is our measuring device, if I may say so.
Agree. But you know, I don't push the burr all the way in now. So sometimes if it's a 0.7 burr, you really need to widen it.
Fantastic, yeah.
So this is about it. And again, I will do my hanging test, bending test. You know that. See, it's coming out.
You have the vein there?
No vein. You saw it get hung on the edge of the hole. Even when I use the vein, I do it on an open oval window. I never do it with the vein the way Robert does it, because it just does not give me adequate feedback. In this case, anterior malleus ligament needed.
Yes, we can see that the malleus, the loop of the piston is almost touching the neck of the malleus.
Exactly. So that's about it. Thank you.
Great.
Is Satish operating anymore?
No. Satish is out of his OR. So just now your one case and my one case.
All right. My case is already on table. You can probably see it in the thing. My junior colleague.
I haven't done a facial nerve prolapse case. Not the way you. I mean, I've never had a case or an opportunity. The partial ones I've always been able to get around.
Yeah.
But never really needed to do this. But if I do need, I'm going to do this for sure.
Thank you. When you say that, I feel very good about it. Thank you. So, keeping in mind that we should always encourage our juniors. In fact, next time we have a talk or something, I'm going to get my junior, very promising young chap called Priyank Talati. He's just joined me recently.
No, we'll definitely have him if you recommend him to be the next orator for the young rising stars.
Yeah, definitely. I mean, he's a very focused, very good guy, and he's the one who actually opens and closes for me nowadays. So he has picked up the endural technique very well.
Great. What's his name again?
Priyank Talati.
Priyank Talati. Okay.
Yeah. He's from Mumbai only.
Okay.
So in the meantime, while we wait for the cases to get prepared, maybe you want to talk about, you're talking about giddiness and otosclerosis. So rather than a formal presentation, why don't we have an interactive between you and I and whoever in the audience wishes to join in?
If you don't mind, you go ahead as a monologue.
Okay. All right. So
I'm just going to eat a little bit and then get started. But
all right.
I'll be around. Yeah. Okay.
So who else is online? Is Deepak there? Deepak?
Prakash will be there. Rajiv is there for sure. Udbhav is there.
I can only see 2.
13 participants. No, right now they have split the screen only between us.
Okay. So it would be nice if somebody else was to join in. But just to give a brief idea about giddiness and otosclerosis, let's start with preoperative. When you have preoperative vertigo, see, whether you say it is vertigo, giddiness, or call it what you will, but when you have a conductive hearing loss and more importantly a mixed hearing loss with a prior history of vertigo, that case has to be investigated completely. Let it be an old history, let it be a recent history, it doesn't really matter, but anything wherein he has had a true kind of vertigo, rotatory sensation and imbalance, you have to make sure that you're not dealing with coexistent endolymphatic hydrops, stroke, if it's a mixed hearing loss, a coexistent Meniere's disease, because as Satish very rightly put, when the pressure is high and you try to do that, the endolymph will be coming close to the surface, and the act of creating a fenestra is enough to cause a total subtotal sensory neural hearing loss. So how do we go about this? There are 2-3 things. One is that if there is an active vertigo preoperatively, we will ask the patient to do a simple CCG, craniocopography, and if he is swaying in one particular direction, you know that there is some labyrinthine mismatch that's happening, in which case he gets further investigation in the form of V-hit. A V-hit along with the history, so on and so forth, will give us an idea of whether we are dealing with some sort of otologic vertigo or not. Because you can have a vestibular migraine along with otosclerosis. You can have a BPPV along with otosclerosis. So all of these, so the bare minimum for a patient of suspected otosclerosis who has had vertigo is imaging. If you are sure that he has a migraine mania complex or even pure Meniere's disease along with otosclerosis, the gadolinium 4-hour washout MRI. He also has to have the CT scan to make sure that there is no third window effect. Sometimes they also complain of the Tullio phenomenon. So you need to look for the third window effect. You need to do a CCG. You need to do a V-hit to determine if there is any labyrinthine weakness, especially in recent vertigo, so to speak. And then, of course, Ashish used to do a glycerol test. I don't know whether he still does glycerol tests or not.
I do.
Yeah. Would you want to say something about it very quickly?
No.
Really interesting. I don't do it.
No, Ashim, go ahead.
Okay.
You go ahead. I'll talk about it when the time comes.
Okay. So glycerol test is also a very good thing that Ashish is doing, and I will plan to adopt it to my practice.
Like, can you throw some light on glycerol test? Like how to do? Like, can you throw some light?
Ashish does a lot of it.
Okay.
And in this scenario, what happens is that you have to be 100% sure from medico-legally as well as medico-legally as well as from the point of view of the patient welfare, that you have done your V-hit, you've done your imaging, you've done your craniocopography, and of course, craniocopography is the least of all of the tests, mind you. Lastly, when you have extensive hearing loss, you want to make sure on both the sides, you want to make sure that there is no sensory neural component creating a shadow curve. So you need to do speech discrimination on the side that you're proposing to operate on. Hearing aid amplification on the opposite side, a hearing aid trial. All of this is part of your protocol. So now let's come to the next step. And that is the next step will be on table if you have vertigo. On table vertigo is due to only 2 reasons that I've seen ever. One is an overlong piston. The second one is excessive manipulation of the labyrinth, either by means of moving around a floater or by sucking the labyrinth. There is really no third reason that I've seen this. Now, post-operatively, you will have post-operative vomiting, nausea. 9 times out of 10, it is due to acidity. Look for nystagmus on table as well as post-operative. That's why you want the patient pretty light before you do anything. When you are looking for nystagmus, you are finding some sort of irritative nystagmus, it is time for you to take a step back. On table, if you see it, remove the piston. Remeasure. If you are having a perilip gusher, take care of that gusher. Use a vein. All of these steps should be observed when you have that irritating nystagmus. Don't try to just control it with stemetil, that comes later. Post-operative nystagmus. Again, mostly it's due to a slightly longish piston. When you are very sure that you've done your piston operation, you found that it is not too long, and you are very sure that it's not too long, wait for a while. In a day or two, it will settle down. Give head high, give diamox, and reduce the pressure of the labyrinth. If the vertigo continues, if there is a lot of nausea and vomiting, you need to re-explore, maybe remove the piston. Last 25 years, fortunately, with God's grace, I've not had an opportunity to do that. That's a theoretical thing that I'm talking about, not what I've done. But in effect, this is the thing that you do for the immediate post-op vertigo. When you have vertigo occurring in the late post-op period, you need to do like perioperative, like within the next 5 to 7 days. You need to do a bone conduction immediately. You need to compare it with the previous bone conduction. If you're finding bone conduction deteriorating, and that, I'm sorry, I forgot to mention, all of these cases of vertigo, they need high dose of steroid. It has a membrane stabilizing action, and it helps in the sensory neural component, if at all that should occur. It also reduces the pressure of the intralabyrinthine pressures. So steroid is a must. Udvam, you are muted.
So which steroid and the dose, like how much to give?
In every case of stapes, I give dexamethasone intraoperatively 8 mg, post-op 8 mg.
Okay.
In those who have even a slight vertigo, intraoperative 8 mg, post-op 16 mg 3 times.
Okay.
PDS for the next day.
Got it.
All cases will receive oral steroid. Betnesol for betamethasone 1 mg 3 times a day, tapering for 3 days and tapering off.
Okay.
Asim, just a point.
Yes, sir.
You operated a case, and just after post-op, you are sure about your surgery, nothing wrong.
Yeah.
And post-op, say after a couple of hours, patient has severe vertigo.
Yes, sir.
So before going back,
yeah,
as you said, you will give what medications you will start with.
Okay, with the vertigo, I will look whether he's got the nystagmus or not.
No nystagmus. Say condition no nystagmus.
Okay. So if he has no nystagmus, it is unlikely to be, it is going to be a short term. This is due to the serous labyrinthitis that
right.
occur.
Yes.
In serous labyrinthitis, what you need to do is give a high dose of steroid.
Yeah.
Dexamethasone better than hydrocortisone. Yeah. If you can give methylprednisolone, well and good. 500 mg IV stat. And also then give the, if there is no nystagmus, you can go ahead and give the stemetil, antiemetics, and labyrinthine sedatives.
Okay. Beta-histidine.
Not really. Beta-histidine is a long-term acting thing. It takes hours and hours to start acting.
Yeah.
Good labyrinthine sedative is the fact that you can use a very, very simple drug like stemetil. It works brilliantly.
Okay. And suppose if there is nystagmus associated,
exactly the same.
Yeah.
Give head elevation, sleeping on the opposite side, and diabox.
Yes. And how long you wait for it to subside before thinking of re-exploration?
48 hours later, one should do a repeat bone conduction. Okay. If the bone conduction is showing a problem, go ahead, immediately re-explore. Okay. If there is intractable vertigo on operation table, we are sure of a long piston or a displaced incus which is pushing inwards or whatever the case may be.
Because in our practice, we are stop, vertigo does occur, but not that intensity, and usually stabilizes in a day or two.
Subside. Give it 48 hours to subside. Severe vertigo.
Yes, that is the more common scenario than going back to long piston and other pathology you have nicely described.
I mean, these people talk about. Sorry, I need to go. I'll just catch up from the OT. Please excuse me.
Yeah, I think now we can go on, Kar. Dry gel form, please. Hello.
Hello.
We can go to screens.
Okay.
Motha de na.
Yeah, sure. Yes, we are with you.
Zara motha de. See, gross overhang. You can't even see the incus and the stapes. I've just lifted the tympanic membrane. So again, in this case, I am going to drill out. Suction, please. The corda is running here, I know. So I'm going to drill from here to here. Okay.
Yeah.
So again, very thick bone. I will thin it quickly and yeah, suction. The first time you use the drill, the vibrations, you have to be very watchful. Sometimes the patient can jump. Am I audible, Prakash?
Yes,
Yeah,
sir.
yeah, easily. Audible, visible, your video is excellent.
Sir, this is micro drill or stator? This is micro, right?
This is a micro motor, yeah.
Okay.
Regular
Yeah.
mastoid drill. It has a geared burr. That is where the corda has skeletonized the corda. Can you see the faint presence of the corda here under the bone?
Yes, sir. Yes.
Yes.
Yeah, so I'm preserving that. That is my landmark. Then you, in this case, you are going to need a lot of bone to be removed. Again, I train myself in every drilling to thin out and look for the color change. That's how I train myself to look at the thick foot plate when I am drilling, how the color changes. See, the gray started to come up. It has started to become thin. We must not leave these edges, smoothen these. Yeah. Give me right angle. दूसरा दे. See this corda, if you can see it, it's been skeletonized.
Yes.
Here.
Now you try to separate
Now
it.
I will try to unroof it.
Yes.
There.
Yeah.
You have. Now I will take the कौन सा हो गया किधर है अच्छा दे दो sorry I tore my glove. Now I'll use the gouge and hammer, the thinned
Why don't you continue with the drill?
I can, it is just more efficient.
Right.
So the first stroke is at the junction where the bone and the corda are.
Yes.
So that's a weak stroke, but that's a definite crack you do so that the largest stroke does not. Yeah. Right angle.
It was a big overhang.
Very, very big. You could not see the stapes and the incus. Oh God, this is also a very awkward situation.
Yeah.
Cup. I'll have to give a lot of head low. It's a
Yeah.
very oblique alignment. Right angle.
Wonderful, sir.
See where the
Amazing.
incudostapital joint is?
Yes.
Way up there. Head low there. So a lot more to be removed. Maybe I'm going to use the drill.
Sir, amazing the way you have saved the corda.
या वरती कर टेबल अख्खं टेबल वर कर. Drill.
Actually, drill is more controlled than using a gauze and hammer, isn't it?
Yeah. झाड आहे. Hold this. Both the previous one and this, both the canals are very, very odd.
Yeah.
See, now you can see the pyramidal process, the stapedius.
Yeah.
But I have to make sure that my instrumentation is going to be easy.
Yeah.
Very thick stout posterior crust. In fact, it's a strong. Okay, this patient is also a little bit troublesome.
How come? Troublesome in what sense?
No, she is not cooperative.
Okay.
I mean, she will move.
What pre-medication you give under local?
I really
what
don't.
What sedation you give?
What?
Midazolam, deuterum, and propofol infusion.
Propofol infusion
Midazolam.
and medazolam. Okay, fine. Quite standard.
Infusion.
Okay, this is a good case.
Yeah.
If Sai is there, she's got her prolapsing facial, but just a little bit. Suction, please. It's dehiscent and it's now suction.
Yes, sir.
Now
Very prominent.
we have the overhang removal. Had it not been.
Yes.
Ek number. We'll just palpate the facial nerve with the side of the. And what Ashim was saying, how to create space in such cases.
Yeah.
Not with the gel foam, but see, it is dehiscent.
Yes, sir. Yes.
Yeah.
But it's not really on the foot plate.
Yes.
Like today we are seeing floater, we are seeing dehiscent facial nerve, all the type of cases.
All the type, yeah.
It's true step is faced, huh?
Yes, sir.
Got to see the
Now
varieties.
what I'll do is give me laser. So now because I have the KTP, I can again see the orientation of the stapes. Although I've given a head low, it is still so oblique.
Yeah.
For it to be ek number, I'll just make sure because I don't see an autosclerotic focus. It is rock hard. Something tells me this is more like a congenital anomaly rather than autosclerosis. 0.6 laser. I'm not sure whether a CT scan was done for this. There's a mucosal band between the two crura, so I want to get that out. I want to get a glimpse of the foot plate.
Yeah.
And there's definitely no autosclerotic focus. So we may be dealing with something.
You do it with the right angle curve?
No, I'm
The
going to use the
mucosa?
laser.
Okay.
She's a good candidate. That is why Can you shut that, please? Who was that? Curate. She's a good candidate, sir. Yeah, where is the win? This one is a very good win. मैंने वो भी नहीं लगाया अभी तक. नहीं टोनी के लगाओ यार. टोनी के लगाओ. टोनी के लगाओ. Must have a टोनी के. वो तो demonstrate will. We'll ask. We will demonstrate. Put my mic on. सर ऑडियो वहाँ पे करवा दो ना इसको पीआई चालू कर दो सर को ये कैमरा लगेगा अभी. Ashish.
Yeah.
Can you hear me?
Yes, yes,
sir. Yes.
Okay, so my question is, how often do you encounter non-autosclerotic fixation of the foot plate?
So I don't know the numbers, but I always look out for it, Ashim. And one interesting case I think was a fusion of the posterior crus to the promontory. But honestly, even with my laser, I could do nothing. So I had to go ahead and do a regular stepidotomy. Again, like in this case, this is a very, very thick crura.
Yeah.
And it's not just thick, it is very strong drill.
Yes, sir, yes.
There's something not right about even the anterior crura. It's 1/3 the size of the posterior, but for sure there is something not right. Although the foot plate is quite there. This is what Ashim told you. If you cannot go conventionally like this, go from posteriorly to anteriorly.
And what is the limitation of laser? You used to use the thinning with the laser, and now you have come to drill.
So the laser I cannot go as I go closer to the facial nerve. I cannot go that close. So I'm creating space.
Yeah.
And then again I will use. Fortunately, the foot plate is blue and thin.
Yes, sir. Yes.
Suction. Dry gel. I'm still not happy with the crura footplate junction. I think I must weaken it a little bit. I must drill it. The base here.
Looks very stout. Is it so?
Yes. The way to know is how much bone dust got accumulated when I drilled it. See? It's like a chakki.
Yes. So you're preserving the tendon in this step just to give the stability to the crura while drilling.
I do it absolutely at the end. So
okay.
What I'll do is I will laserize the right laser. I will laserize. See, when you drill the posterior crura, your access, visibility and access to the anterior crura also increases.
Yes.
Piston length. Next. I will.
I think now we have quite sufficient space, isn't that?
We have enough space, but let me go ahead and weaken the anterior crura because I'm expecting see this?
Yes, sir. Yes.
Quite sturdy, as if ossified sort of thing.
After the fenestra, I may further weaken it. Give me dry gel form.
Yes.
A little fear in my that I hope the foot plate is not mobile. One more dry. Dry on top of it, big one. संतोष टेबल जरा थोडं माझ्याकडे कर आणि एकच मिनिट कर बस थँक यू Give me laser 0.6. See that mucosal band can give me trouble. So I'm going to go way past that dehiscent facial nerve with my laser.
Yeah.
Okay. So the piston length. Table अख्खं वर घे जरा.
Audible?
The yeah, Sati, Ashim, yeah, 5 minutes. Okay.
No, take your time. I'm just wondering because I was talking to you, there's no response.
Yeah.
So I was just wondering.
And now I can hear you. ना जरा जास्त वर गेलं.
No, what you did was very good. You created space around.
Yeah. Suction. Ashim, I remember you giving this suggestion to Hugo Fish at the course at the Oberoi. When he was talking about it, that about the reverse epidotomy and the limitations of a crowded niche. And I remember you getting up and I was so impressed. And so was he.
I impressed you then. You still impress me now. Uska kya?
Right angle. Okay. So
it's about mutual appreciation, that's very important, in one's life.
That's one of the things I'm grateful to the good Lord above for is my sustained and maintained best friendship with Satish and Ashish, It's something
No, there
I
cannot be
record to
nothing
say
big
that I'm
compliment
fortunate
and
for that.
appreciation by your own colleagues,
Yeah.
So
now in my case, I don't know if I have a PIP.
now you can go to Ashim. That's okay. Now my steps are going to be similar. I'm
You
just
can
going
see
to do
that-
the length. Yeah.
Yeah,
Ashim, you
Ashim,
go
we
ahead,
can
show your findings.
Yeah. So what is happening here?
I'll
What
keep
is
quiet.
happening here is that I have a large pyramidal process that is obscuring the posterior crus. Until I see the base of the posterior crus, I will continue to drill out the processus pyramidalis. Quite similar to Ashish, I also have a prolapsing nerve which is not really obstructing me. Can you see now?
Yeah, it's quite away.
Because of Sai.
Also, like Ashish, I think we are duplicating.
Yeah.
That I have a very thick posterior crus here.
Asim,
And
can
as
your
I
picture
mentioned-
be little more sharp?
Unfortunately, this is the best I can do. I can just magnify a little
Now
bit.
better. Yeah, now
Is
it
that
is
better?
better. Yeah,
Okay,
now it is better. Yeah.
Good. Okay.
Yeah.
So now I will, as I had mentioned earlier, move from posterior to anterior.
Yeah.
It's really a monster crust.
Right angle.
Blocked. Give me a smaller. Not working. Okay, I've just gone through the crust.
Yeah.
Number 2. I'm seeing that anterior crust also is pretty much stout.
Yeah.
Prakash sir, can you see that?
I mean, almost same as that, as it is almost same as Ashish had.
Yeah, exactly. So now what I'm going to do is try and drill out the anterior crust also, at least weaken it.
Yeah.
Number 2.
Ashish, have you created Fenestra? I think so.
No, not yet. I'm
Okay,
doing
not
the
yet.
piston,
Okay, fine.
yeah, I'm actually listening and watching to Ashim in the middle.
Okay.
Ashish, feel free to take over whenever you want, yeah?
Yeah, no, I'm in my that laborious piston length measurement.
It is the only way, buddy. The perfect length is the only way. Let it be laborious. Scissors. So now here, once again, I have
Asim,
gone through the
centralize a
capsule
bit,
of
boss.
the joint.
Asim, centralize.
So,
I
I've
should
gone through the
centralize.
capsule of the joint and I'm dividing
Little more, yeah. Yeah.
stapedial tendon.
Yes.
Just chavarta hai khada, clot.
Number 2. 5, sorry. And now, as always, I mean, unfortunately, today the cases have been quite sort of.
Again, your field has gone out of the screen. Asim, your field has gone out of the screen.
Yes, sir.
Yeah, now it is good.
Again, I'm twisting it.
Yeah.
नहीं ज़्यादा देना क्लॉट गया अंदर
Fractured, yeah. No.
And I'm removing it.
Yes.
You see, in the meantime, my little piece of gel foam has been keeping my chorda fresh.
Yes.
This case also, I think I will be able to do a vein interposition without difficulty.
You almost in every case do a vein.
Fine.
Unless it is a narrow niche or an obliterative focus, it will be a vein interposition. Another thing, now here I have a very nice lenticular process.
Yeah.
But since I have the superstructure right here, let me tell you what I do. Assuming that this lenticular process was not good,
दोनों बाजू-बाजू में करा सांगना.
I would use the superstructure.
Which one are you seeing?
Like a
Right
horse.
now with Asim, but we can come back to you. Yeah, in PIP I can see you, Ashish.
Yes, sir. On the main screen, Ashim sir is there.
Yeah.
Ashish, you want to take over? Go ahead.
No. I'm just going to make the fenestra. My piston length is done.
So this is what I do. I use this like a horse on top of the long process. So it becomes, and then I stabilize it with gel foam and the chorda. I use the superstructure to
Come again,
recreate
couldn't
the
get you,
lenticular
Asim.
process.
Asim couldn't get you. What you said, repeat it.
Okay. So you see, this is a superstructure.
Right.
Now assume that the lenticular process was gone. In this case, of course, I have a good lenticular process.
Yeah.
I would do this.
धागा आला देते.
Okay, and that is in between where it is lying.
And the piston would hang here.
Yeah.
And this would be like this.
Is it stable enough?
Of course. And then you can put a tissue glue or something like that. But even if you did not, this is extremely stable. Look at that.
Okay. Yeah,
So
yeah.
literally, the idea is to prevent the processor from sliding off.
Yeah.
And does a remarkable job. I've done it in many situations.
Oh.
Now, quick question is, does the audience want to know how to harvest a vein? Or is it not necessary to show?
Sir, if you can show, it will be better. Many
Yeah,
people
that's
want to
better.
know.
Okay, okay. So now the next step, of course, is demucosification. Please feel free to go back to Ashish whenever you wish. Long curve.
So we like to see with the external camera the whole process of taking the vein.
All right.
Ashish, centralize a bit, boss. Your screen is off. You are out of the screen. Yeah, now better. Little down, yeah.
ड्रिल नाही पाय अशी माझ्या.
No, I need to see it. Maybe I can show it beginning to end right here. Which one? ये वाला. Okay, now, no, we'll use it from microscope.
Sir, it is like watching the old times, Saurav Ganguly and Tendulkar opening together.
Am I in
I
focus?
think which vein usually you harvest?
It's on the dorsum of the hand, any good vein, I'll just pick it up and harvest it.
Yeah.
So you can see that this vein is there.
Yeah.
I will just inject some local.
Mm-hmm.
Dinesh, can you make the Ashram sir picture in the center?
Wait for 10 to 15 seconds.
Yeah.
Am I visible?
Yes, yes.
Sir, you are in the PIP.
It's okay. This is nothing critical, just an
Yeah,
idea.
yeah, it's okay. We can have both.
Exactly. So now what I've done is I've taken a horizontal incision.
Yeah. Just like any venue section people have done during their internship and housemanship.
Literally.
Yeah.
So you
Only
can see
thing
that
is in venue section you just make a very small piece. Here you go little longitudinal. That's all.
no, sir. The incision is only 2 millimeters or 3
Yeah.
millimeters.
No, not incision. The separation of the vein.
Yeah. So here the idea is that so that's all there is. The most important now, there are 2-3 things I want to make points.
Yes, that is.
One is you never mop it because mopping causes the problem of the fibers touching the vein.
Yes.
So always without mopping, it is harvested. Now, of course, they can mop and do what they like, but there is a no touch technique. The fibers, the cloth should not touch, your hand should not touch. And the forceps I'm using is a toothless forceps. So it's totally smooth, no serrations.
Plain forceps.
Okay.
Yeah. Yeah.
Okay, that's about it. We can go back to Dr. Bomkar.
Yeah.
So what are your sites of taking the vein? Like from which all places you usually take the vein graft?
Some of the hand 99% of the time, yeah.
Okay, okay.
So can we see the fenestra? Am I on the main screen?
Yes, sir. Yes, sir. We can see the fenestra.
Yeah, and give me the drill. I'll just show you. I had laserized the anterior crura.
Yeah.
And further weakening. After my fenestra is made, I am further weakening with a 0.6 millimeter burr, taking it to the base and just letting it touch the crura. Yeah.
Yeah.
So they are very flimsy now. Both the crura, they are intact but flimsy.
Yeah.
Yes, it's amazing to see how you are working in such a narrow corridor.
Because we had got a good. ये बंद हो जाता है मेरे को 10 बार करने में हर टाइम तू force
Now it
करके
is thinned out, Ashish. It can be
Yeah.
easily taken out, no?
Yes, it will crack now. I just have to blow some air and it will crumble.
Right.
Hopefully, I hope I have not said it too early.
Mhm.
You never know how stapes can surprise you.
Yes. Perfect.
Section. See, what is happening is the shaft of the piston is getting pinched between the facial nerve and
Yes.
actually the head of the stapes.
Yes.
So it's not moving down. Can you see it being pinched here?
Yes, we can
Centralize, please. We have gone out of screen.
See, here and here it is getting
Yeah.
pinched.
Yes. Yes.
So I have to get it off that. Section. I was in half a mind to drill away that head of the stapes,
Mhm.
but early on. Yeah.
Wonderful,
Yeah.
sir.
Yeah. Perfect.
Table tigre. The table is towards me, so I am taking it to the other side again.
No, it's okay. Perfect picture for us.
Yeah. Okay. 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 Okay.
So one of the delegate was asking how to know that you have crimped the piston perfectly. You have to feel it, like how you
You
make
have to
sure.
watch it close. So
Okay.
therefore the
Yes.
overhang removal is important. Suction ek tha. And now the disarticulation and
This is very important step.
the disarticulation. Good. See, it just had to be invited to be cracked.
Yeah.
Okay, done.
Done.
Ashim, you can take over.
What Uddhav asked about the crimping, if you do the crimping and then apply little pressure on the incus,
Yeah.
reflux
Okay.
as well.
So I'm done. You can go to Ashim. It's over. Just to get the flap back.
Yeah.
This is Ashim to karal tha.
Yes, Asim, we are with you now. Asim, can you hear us? We are not
Ashim, back
getting
to you, Ashim. I'm done.
we are not getting Asim's voice.
Side. Ashim Sarana Sanga.
His voice is not coming.
Ashim,
In the
again, just
meantime,
a-
Asif, for the benefit of delegates, now
Yeah.
you tell about your post-op regime. You pack it with the gel foam,
So I actually keep only the gel foam on the incision line. I keep
right?
the most of the ear canal open,
Yeah,
so that when the patient goes out into the room, the relatives can talk to him and they can be convinced that the hearing has improved.
yes,
And we really need just these are like a suture.
yeah.
So
This is also 4, huh?
then nothing, just
How
an
often you have to put a pack if there is some oozing, some small pack?
no, we will bipolarize it, we'll cauterize it. Anything in the external canal,
Okay,
if there's a oozing or a
right,
bleeding, you can either monopolarize or bipolarize. But
right.
Am I
bipolarize
audible?
Yeah.
see, this is just
Asim,
really like
Am I
sutures is
audible?
what I take.
right, I got it. So,
बार बार आवाज चला जाता है यार.
Ashim, you are now, we can hear you.
now Asim, now you are right.
Okay, so now am I audible?
Yes.
Yeah, you are.
Great. Now you saw
So
me.
it's done. So I think
got the
this
measurement
was
of
my last screen.
425,
Hmm.
and it was a bit longish. Pipe.
Yeah.
Acha, 425.
So I have cut down by 0.25 millimeters. So that is where my hanging test and bending test comes into use,
Yeah.
because it could not get hung.
Yeah.
Now it is okay. Can you see that?
Yes,
Yes,
yes.
sir. Yes, yes.
Outside.
Yeah.
Otherwise, it was not going in.
And since the vein will come in between, yeah, the vein will come in between Asim, so that
Yes.
will also stabilize it further.
No. The point, you don't get the point. The point here is that I need it to be exactly 0.2 millimeters into the vestibule.
Okay. Yeah.
What is the normal excursion of the incus? The normal excursion of the incus is between 0.1 and 0.2 millimeters. So by giving a lateral
Yes.
pressure on the incus, if I'm able to get it
Yeah.
out,
Mm-hmm.
then I know the piston is not too long. So
Yes.
when I tried it with the previous piston, that was 425, I could not pull it out enough. It was
Okay.
coming out. That means it was a little bit too long, only 0.1 millimeter too long or so.
Yeah.
So I decided to truncate it a little bit
Yes.
and make a smaller piston.
Yeah.
So I truncated by 0.25 millimeters.
Mm-hmm.
And now it is exact. We saw it now jump out. So that is the
Yes.
right length. So
Right length.
this is 4 millimeters. So everybody who says I use only a 4.5 or 4.25, today out of 3 cases, in 2 cases I've used 4 millimeter piston.
Yes.
So it is, you cannot generalize.
Yes.
Just because the average size of Indian foot is 8 numbers does not mean 8 number will fit you or me. Customization is essential. If there's one
And that's the importance of measurement.
Yes, sir. If there's one take-home measure message from this whole Stapes Carnival that we've had today, is that the measurement of the piston is of utmost importance,
Yes.
and the size of the fenestra is of utmost importance. It should be a discrete fenestra.
Right.
It should not be a partial platinectomy, irregular platinectomy.
Yes, sir. Yes.
As long as these fundamentals and the mobility of the ossicular chain should always be assessed correctly.
Yes.
As long as these few caveats are maintained,
The results are going to be good.
will always be over 98%.
Yes. And we already discussed about the long piston. If you keep the length even 1 mm long, it can lead to vertigo and other things.
Sir, I've had cases of persistent perilymphatic fistulae which have been asymptomatic except for reduced discrimination for many years before they suddenly got a sensory neural hearing loss in cases done somewhere outside,
Yeah.
That's why since almost 30 years, my father before me has been obsessing about length of piston.
Yeah.
ABR Desai sir was
Yes, sir.
always saying length, length, length and length.
Length. Very
And
important.
that importance has fortunately percolated down to the people nowadays.
Mhm.
In the past, there were many authorities who said that they use only 4.5 millimeter piston, never had a problem.
Yeah.
4.25, never had a problem. But, the problems often go to somebody else. That's not to say we don't have problems. We all do.
Yes.
But the point here is that these are the caveats that one has to sort of follow
Yeah.
in order to make sure that the patient's result is outstanding
Yes.
for the most part.
Mhm.
Scissors. So here I have now trimmed off the perivenous adventitia.
Yeah.
Scissors.
Open it up.
And you open it up, making sure that the adventitia is facing the intima is facing you.
Yes.
It's a lovely thin vein, wonderful.
Yes, sir. Yes.
Measuring. Even this, you have to sit with a measuring rod and make sure everything is right.
Yeah.
See, the way I measure it is this is a 4.75,
Yeah.
the length of the rod. So this is about 5 millimeters
Mm-hmm.
by 5 millimeters. I cut away the excess.
Yeah. Why you want it to be the same size that of the piston?
No. You see, the idea is that your hole is 0.8 by 0.8.
Yeah.
You want adequate overlap on all the directions.
Yes.
To make sure that it's part of the vein does not dip into the vestibule,
Exactly.
Sometimes the edge goes inside.
So it should be like a sheet which is put, and in the center there should be the step is that graph should be coming.
Absolutely true, sir. Absolutely true.
It should not be that one corner is dipping into and causing
the
problems.
corner should never dip inside. Again, I'm going to measure. One sec. Measure.
Yeah.
See, this is perfect. This is a bit too long. Needs to be cut a little bit more.
Mm-hmm.
See, a lot of people say they do it with their eyes. Somehow, and it's been a bugbear for me. I've never been able to do it with my eyes. Need something or the other to measure it.
I think the size of the fenestra it should be adequately covering from all around the fenestra, and
Exactly.
little more than that, so that when the prosthesis goes in, and it should not disturb.
Invaginate. Correct.
Right. That
Absolutely
is the main
correct.
purpose.
Yeah. So in my hands, I found that this is the right size.
Yeah.
Now let me put a 0.6 millimeter disc. I will still need to widen further. Please mind you.
Yeah.
Sir, you are using which company instruments for this? Like disc and all these things?
The disc is made by, actually, we had an old instrument manufacturer called Hegde. These are made by on demand by us. So these are custom instruments. I don't know where else you can get a disc. You can't.
Yes, sir, because only I have seen you using that. Otherwise, not. I've never seen.
No, now suppose you have a 0.4 piston, you will want a 0.5 fenestra. Of course, as Ashish very correctly said, the size of your burr and all is a good indicator.
Yes.
But this is nice,
See, this is widening the posterior side of the edge of the fenestra.
Yeah.
You can know he's touching the footplate because of the dust that is generated. It's not floating in the air.
Yes.
Can you hear me, Hashim?
Yes, boss. Absolutely correct.
So we are done for the day, but I'm going to wait and watch. Did you finish?
Yeah.
And
Thank you
everybody for watching.
Yeah.
And we hope we did justice and some movement forward.
No, we have comments all over the world. People
If
are
I have to say, today we had variety of cases, plus radiology and Rajiv's lecture about the pitfalls for the beginners, and what are the care to be taken. These are marvelous, small points, but has a long way to go.
Yes, sir. And so for people who are watching, many people have joining between. So I just want to tell them that on YouTube, you can have the whole recording available. So people who have joined in between can log in and can watch each and every case.
This is 0.8, Rashmi? Give me 8.
Lupin has promised to support the entire year, whatever number of events we want to do. My associate, Dr. Hitesh, is in touch with their top people. And in principle, the assurance is that any high quality event, they will
That is
support
very
us.
good of Lupin to help us and to help increase the knowledge base is a good thing indeed.
I think this is one of the biggest plus of the COVID scare,
0.4.
that it brought many of us together in same platform, good learning experience. Though we worked little less, but yes, in the long way it will help.
Of course, of course.
Satish has revolutionized
Yeah.
ENT
It
education. I think.
Boss, it needs courage. During the peak of the COVID period, he is doing a surgical webinar for 8 to 10 hours. I mean, it's a daring as well. And that too, some of the staff were reported positive and all that.
The more than 300 hours of live surgeries have been shown last year.
And what surgery? Not stapes. He's doing angiofibromas and he's doing.
No, starting. I said, if you remember, from pleura to, what you said, dura.
Dura, yeah.
Yeah. So, and we had all the branches covered, almost everything, larynx covered, parotid covered, thyroid covered.
And sir, the icing on the cake is the autoplasty, the microtia surgery that Ashish has shown in this whole lockdown.
That still Ashish has to make it more popular, boss.
Yes, sir. Yes, sir.
Still, many people are not taking it as a challenge.
The microtia.
Yes,
Yeah.
sir. Yes, sir. The highlight of the COVID year is the microtia surgery of yours.
Because it's a learning curve is there. It needs courage. It needs conviction. And it's more or less a training. Good training is required. Learning curve is a bit there.
Yes,
So,
sir. Yes, sir.
Still, people are going to plastic surgeons for microtia and all that, and they don't realize.
No, but now the plastics are only referring the patient to us.
Yes, because it was not. See why they are doing so.
They don't have any
Not
option.
result oriented in their hands.
You see, they are happier to do their liposuctions and all that.
The other things, yeah. They have got so many
Yes.
other procedures to do.
Mhm.
So.
Vain.
Sir, I know I've listened to one of the Magyu Sana's talk. Earlier, when he used to do acoustic, cases were less, but now the whole neuro department of the Italy is referring cases to Dr. Sana. Same goes with you. Now the whole plastic is referring cases to you.
Actually, one has to give consistently good results. Then there is no dearth of cases.
No, 2021 is going to be the year of the facial nerve by the ENT surgeon.
Hopefully, yeah.
We assure you that we will do our best, the three of us,
Yeah.
all of us put together,
Yeah.
to try and create a paradigm to follow.
Yeah.
Ashish. Ashish. Ashish.
Hello.
Ready to pinch.
Dr. Ashish.
Are you talking? That's I'm Ashim. Ashish is off the air, I think.
So now you are placing the vein.
Yeah, placing the vein.
And well beyond the fenestra which you have created all around.
Yes.
Yeah.
Yes, that's where leave
So that there is no invagination.
Exactly.
Yes, Dr. Deepak, you were telling something.
Okay. Thank you so much.
Deepak, were you talking to me?
Yeah, Ashim. I think basically you three did a fantastic job through the pandemic. And that is one point which Munka sir said, which I second. To do surgeries at a time when a lot of them were even scared to see OPDs. It was an amazing act. No doubt at all about
Deepak,
that.
friends call it bravery, the enemies call it stupidity.
Foolishness.
No, but one more thing, Asim and Satish is not there. Now you are not only 3, you have added multiple hundreds of it.
Yeah, that's true. That's true.
And
Yeah.
personally, Ashish,
Yeah.
I gained a lot because me and Vishwas, you know that we have started doing this surgery together now. That single stage, what you taught us through this thing. So I think whatever anybody calls it, it's a yeah. And I feel whatever the friends call, whatever the enemies call, it is the inner call which matters the most.
Absolutely right. ये अंदर की बात है.
Vein interposition. Except in obliterating.
25th, I'm coming to Vijendra's place to do a microshare.
Oh, fantastic. Good, great. Vijendra was in our place yesterday. He did a cholecystoma in chest vein. And today also he was watching this program.
I think I sent him the link.
Yeah. And when the oozing was happening in that last case, in fact, he gave me an input, whether it is coming near the chorda or something, but then you said it is below the pyramid, isn't it? Medial to the...
Asim, centralize करो boss थोड़ा भाग गया.
Sorry, boss. Sorry. I thought everybody is tired and gone home.
Yeah.
Or are in home. Anyway, that's so that's about it, sir.
Yes, you have done good
Now
job.
you see the loop. Udbhav, you were asking the question about crimping. You watch him.
Yes.
See the anterior end of the loop, and when he crimps it, you have to see it going around the incus, the anterior surface of the long process.
Yes, sir. Yes.
So you have to visibly see it, and to be able to do that, your overhang removal has to be good.
5 and 5.
As a chorda you put on the top of the prosthesis.
Yes.
Will it not going to alter any sensation when you speak? Anything reflex sort of thing?
This is look at this double hand. Satish is such a big fan. Yeah. Lovely, Ashim.
What happens is that it adapts it better, rather than compress it. That when you compress it with a piston, at least in my hands, it forms an oval rather than a perfect adaptation.
Okay.
Good. So here I like this, and then I will do a final tightening with the forceps any which ways.
So and the forceps can be used both ways. Like the working handle can be anterior or it can be posterior. Sometimes when I have a lot of crowding, I'll put it the other way around. I'll hold the forceps the other way around.
Yeah.
Yes.
Shame.
Yes, sir. Yes, sir.
PTV here. Excellent.
Yes, sir. Thank you, sir. Thank you. I am truly honored that you are here to see my work. Thank you, sir.
Thank you. Thank all of you. Okay.
Thank you, sir.
Thank you, sir. Nice to have you.
Ashish and Satish, every one of you.
Thank you, sir.
Thank you for being here, sir. And thank you for guiding us through.
Thank you, sir. Thank you, sir.
I hope when you look back, you think you've done yourself proud by creating people like us.
I enjoyed
Sir, Dr. PGV, thank you for your inputs that you've given. Okay, one last point I want to make before I go off air. I'm sorry, I'm holding everybody back.
Yeah.
But in this case, you saw in the previous two cases, when I moved the malleus, it was a very free movement, blocked, large. In this case, I'm finding that the movement is relatively restricted. See, it's moving, but restricted.
Yeah.
So this is a little bit of hyalinization of the anterior mallear ligament. Actually, I became fascinated by the anterior mallear ligament after the work of Hüttenbrink of Düsseldorf.
Okay.
So now I will just divide it.
Yeah.
There, that's it. This simple act.
Yeah.
Now see the movement. See
Yeah.
it, so free. You saw the difference?
Yes,
Yes.
So
Yeah,
you go a
so
little anterior to the
Ultimate, sir.
malleus.
Ultimate.
excellent. That's all you need to do. Okay, thank you everybody.
How did you do
Thank
that,
you.
Ashim?
How
Ashim,
did it? Yeah.
exactly how did you do that?
Okay, so you can
Old.
see now anterior to the handle.
It's about 1 o'clock position, Gauri.
Gauri,
Anterior
Yes,
to the
yes,
neck.
you see this is the head of the malleus, okay?
correct,
Now do you see the white bit?
correct.
Okay, that's a lateral process. Just
Ah.
anterior to that.
Yeah,
This
with a
place.
sickle. With a
No,
sickle.
this I'm using a long curve.
Okay.
And then you again palpate it. Very free. That's what you want.
Hmm.
Superb. Thank you all. Thank you very much indeed. It was always a pleasure
Thank you,
and
Thank you, sir.
privilege.
Thank you, sir.
Thank you. Until the next time, everybody. Thank you so
See you all
much.
next time.
Thank you, sir. Thank you, sir.
Satish, Ashim,
Yes, sir.
Thank you, sir.
Ashish, we enjoyed your demonstration.
Thank you, sir. Thank you very much.
Thank you, sir. It was an honor, sir, once again.
Okay.
This was dedicated to you, sir, for all the good work you've done for
Wonderful work.
generations of ENTs. Thank you, sir.
Thank
Thank you so much, sir.
See for
Okay, everybody.
yourselves.
Bye-bye.
Bye, sir.
Not as much as the
Hi,
last.
Ashish.
Bye.
But-
Bye, Gauri. And congratulations. What a
Masta.
wonderful daughter. Very talented girl.
Thank you for the
It
opportunity.
will happen. Don't worry. This is not a big deal.
Okay.
Yeah, it will.
Thank you, sir. Thank you, sir.
I need to work
Thank
with. Put my microphone off.
Close it.
बट निकाल दो ना सर सर मैडम बंद करो ना
बरोबर.
हेडलाइन निकाल दो
Open